Just started.
We'll start, sir.
Sure.
Yeah. So, good evening, everyone.
Sorry for that. Yeah.
No, not at all. No, sir. We are blessed to have you. You don't have to be. I know small. Exactly. When the program starts, this is called technology. So when the program starts, something or the other gives away. So, good evening, everyone. Thank you so much, Gurudat sir. Gurudat sir, I'm sure everyone knows about him. In fact, sir has won many best teacher awards. I think many, and his classes are, the students die to listen to his classes, even including me. Sir's knowledge is immensible. I mean, the depth is, you will get to know after the class. So, thank you, Gurudat sir, once again for accepting this invitation. And there are 333 participants today, out of which.
Thank you, sir.
Thank you, sir. So 75 have joined. So what we'll do, sir, we have muted everyone. We will request everyone to, sir, I hope you're comfortable with the phone, because I'm sorry.
No problem.
Okay, fantastic. So we will sort out after the class about with your laptop, sir.
Okay.
So we have muted all the participants except Lakshmish and Lakshmish, can you just say hi once, because sir should know who is who.
Good evening, sir.
Lakshmish is in black, sir. Yeah. Introduce Lakshmish.
Good evening, sir. Dr. Lakshmisha J. Hegde here. I'm
Okay,
a DNB candidate from Bhagwan Mahavir Jain Hospital, sir.
Okay, good evening, Lakshmish.
Thank you, sir.
Good evening, sir. Myself, Dr. Mukesh, secondary DNB student from Bhagwan Mahavir Jain Hospital, sir.
Yeah, good evening, Mukesh. So, you see, I'm very happy that you people, both of you have volunteered to present this case. And it's very important, especially diabetes mellitus, because invariably you will have a case in the practicals, and majority of the times, as you have going to present probably a diabetic non-healing ulcer, and which is commonly kept. And also many times, many of your patients may also have a comorbid condition of diabetes, and in the practicals, all the questions can be asked regarding diabetes mellitus also. For example, now you may have a patient with ischemic heart disease and diabetes mellitus, because ischemic heart disease is so common with diabetes. So in such situation also, all the questions can be regarding diabetes itself, because it is so common comorbid conditions among majority of the patients who come for surgery, because diabetic patients are more prone for surgical problems, and they keep visiting the operation theaters, and we will have to deal these patients with diabetes mellitus. And invariably in theory also, there are a lot of questions will be asked in theory also regarding diabetes. And because it is such a common comorbid condition, so let us know more about this particular comorbid conditions, because a lot of questions will be asked and a lot of confusions are there, especially in the management of the hyperglycemia in these patients. Especially I have seen with many of the students, they'll not be knowing exactly how to manage these patients when they are posted for a complex major surgeries or even minor surgeries. So let's go about. So I request you to present the case, whatever the case you are presenting. We'll go ahead afterwards.
Yes, sir.
Okay. Present Lakshmish.
Good evening, everyone. Today we will be presenting a case on diabetes mellitus. Examiner is Dr. Gurudat sir. Patient details: he is a 55-year-old male patient. Am I audible, sir?
Yeah, you're audible.
He is a 55-year-old male patient, hails from Hoskote, who is a retired police constable by occupation. He came to us with the chief complaints of wound over the right foot since 1 month, and pain in the right foot since 10 days, and fever since 3 days. These are his chief complaints. History of presenting illness. Patient was apparently all right 1 month back when he had an injury to right foot by shoe bite injury. Initially, injury was of small size, then gradually increased and progressed to present size. It is now associated with pus discharge, foul smelling. And also history of pain in the right foot since 10 days, which was insidious in onset, increased during walking, and relieved on rest. It is a non-radiating type of pain. Also history of fever since 3 days, gradual in onset, intermittent type of fever with chills relieved on medication, and history of burning sensation in the bilateral feet present. There is no history of constipation or diarrhea, no history of gastroesophageal reflux disorder symptoms, no history of bowel bladder incontinence, no history of erectile dysfunction, no history of heat intolerance, no history of vision or blurring of vision problems, no history of dyspnea on exertion, paroxysmal nocturnal dyspnea, and no history of orthopnea, no history of chest pain, palpitation, or syncope, no history of altered sensorium or stroke symptoms, no history of cold or cough at present, no history of burning micturition, and no history of pain in abdomen or vomiting. In the past history, patient is a known case of diabetic since 10 years. Other significant surgical history is he had a open appendectomy surgery in 2009. Apart from diabetes, there is no history of hypertension, tuberculosis, asthma, or cerebrovascular accidents in the past. In family history, his parents are also a known case of diabetes. He consumes mixed diets, no habits or no substance abuses. His bowel and bladder movements are regular till now. Recently, sleep cycle is disturbed because of pain in the foot. As a part of his treatment to the diabetes, he takes tablet metformin 500 milligram 2 times a day, tablet glimepiride 1 milligram 2 times a day, and tablet vildagliptin 50 milligram once a day. So after the history, provisional diagnosis is 55-year-old patient, known case of diabetes with peripheral neuropathy, without cardiac involvement, came with complaints of wound over the right foot, probably diabetic foot. Going to general physical examination, patient was examined in daylight, and patient is moderately built and nourished. He is conscious, oriented to time, place, and person. Height is 165 centimeter, weight is 55 kg, BMI is 29.4 kg per meter square. No pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, or no pedal edema. Vital parameters are pulse rate of 75 per minute, regular pulse with good volume, no radio-radial delay. Peripheral pulses are well felt. And blood pressure of 140 by 80 millimeter of mercury in right arm in sitting position. Respiratory rate of 16 per minute, which is regular, and room air saturation of 96%. Airway examination, mouth opening of 5 centimeter, Malampatti grade 3, no loose tooth or no missing tooth, no artificial dentures, thyromental distance more than 6.5 centimeter, neck movements are normal, upper lip bite test +1. Cardiovascular systemic examination. On inspection, chest shape is bilaterally symmetrical, apical impulse is not visible, no pericardial bulge, no scars, no sinuses, or no venous engorgement are visible on inspection. On palpation, apex beat is felt at the left fifth intercostal space, 2 centimeter lateral to mid-clavicular line. No palpable thrill or parasternal hue. On auscultation, first and second heart sounds are normally heard and no murmurs. In respiratory system, trachea is in the center, no chest deformity, no accessory muscles of respirations are involved with the breathing. And on percussion, resonant note is heard. On auscultation, normal vesicular type of breath sounds are heard in all lung fields. Per abdomen examination, quadrants are moving equally with respiration, no dilated veins, no visible pulsations. On palpation, abdomen is soft and non-tender, no obvious organomegaly, bowel sounds are heard. In central nervous system examination, higher mental functions are normal. Patient is conscious, oriented to time, place, and person. And power is 5 out of 5 in bilateral upper limb and lower limb. And there is reduced sensation to touch in bilateral lower limb up to ankle joint. Reflexes are normal. On local examination, there is a 3 into 3 centimeter ulcer on the dorsum of the right foot, which is also extending into the fourth web space. On palpation, inspectory findings are confirmed, and 4 into 3 centimeter size ulcer on the dorsum of the right foot extending into the fourth web space. Skin surrounding the ulcer is cold. Ulcer covered by granulation tissue. And base of the ulcer is formed by muscles of the dorsum of the foot. And few investigations. Complete hemogram says hemoglobin of 10.4 gram per deciliter, PCV of 32.1, WBC counts are 15,200 cells per cubic millimeter, platelets are 1.9 lakh, blood urea nitrogen of 13.1 milligram per deciliter, serum creatinine of 1.3 milligram per deciliter, serum sodium of 139 milliequivalents per liter, potassium of 4.6 milliequivalents per liter, chloride of 100, random blood sugar 302 milligram per deciliter, and HbA1c value is 8.3%. On urine routine and microscopy, it says pus cells 2 to 4 per high power field, and ketone 2+, proteins 2+, and glucose is present in urine. And ECG is showing normal sinusoiding.
Okay, Hegde, you have taken a very good history, and also you have done the very good examination also. Nicely done. And few comments on your history before we actually go in history and examination, before actually we'll go in for the discussion on this present case and also on diabetes mellitus and anesthesia.
Yes,
so one of the important things you have left out is the METs, metabolic equivalents. Because this is very, very important in order to know how much of the cardiovascular system is affected in this patient.
Yes.
And also, you know, the excess tolerance can get reduced because of the autonomic neuropathy if the patient has developed, because he has already developed peripheral neuropathy from your history and examination.
Yes, sir.
So if the peripheral neuropathy is there, he may also have an associated autonomic neuropathy. So whenever autonomic neuropathy is there, definitely, so there can be an exercise intolerance.
Yes,
so
sir.
we'll go into details about those things later.
Yes, sir.
But METs also you should have taken the metabolic equivalents. Can you just take, did you take the history of what is his excess tolerance? Because he's a police constable.
Yes, sir. As of now, he is able to do his routine household activities like taking bath and walking on a level ground, and all other routine household activities.
No,
like,
because you know he is a police constable, he will have to do some strenuous duties also. As a constable, he may have to run after the thieves also many times.
Yes,
so before he has developed this ulcer, that is 1 month back he has developed this ulcer, isn't it?
yes, sir.
Should always ask about his the amount of exertion he can do, and what are his METs, because that becomes very important for our management of this patient.
Yes.
So that is one of the things you should always go into. The other thing is many of these patients with autonomic neuropathy also develop, you know, the OSA, obstructive sleep apnea.
Okay.
So that is mainly because of, you know, improper you know, the vagal supply to the pharyngeal muscles may get altered.
Okay,
so that is the reason they may also go in for OSA. So history of OSA in all diabetic patients is very important. You have just said that the sleep is disturbed due to pain, but you have to go into really the OSA, obstructive sleep apnea, because that again is very important for us. I'll come into, or just now like that only I can ask you about why OSA history is very important for us. You can wind up the PPT. You are able to see me?
1 second, sir.
Yes, sir, we can see you.
Yeah, okay, okay.
Okay.
Yes,
I've
sir.
done it.
Yeah, now tell me why OSA obstructive sleep apnea history in any diabetic patient is important as such in any patient for that matter.
If a patient is a known case of obesity also along with the diabetes, uh, obstructive sleep apnea history is important as far as airway management is concerned. So when he comes
Very
for
good.
surgery under general anesthesia, so
Very good.
first thing is he can have a difficult airway, mainly from the obstructive sleep apnea component, sir. And other than that, during induction as well as from the emergence from the anesthesia, he can go into rapid desaturation episodes, sir, because of reduced FRC component as a part of OSA. And also they may not tolerate opioids or other painkillers very comfortably, sir. The higher chances of respiratory depression are more common in OSA component patients. And other thing is, as a pathophysiological changes of OSA, in the later stages, they can have sympathetic overstimulation in the later stage leading to cardiac abnormalities. So cardiomyopathy changes due
No,
to
that is okay. But most important thing is, even you may have to think about giving any pre-medicants like benzodiazepines for these patients because they may develop hypercarbia because of the sleep apnea. They can have hypercarbia, and even there are incidences wherein they have not come out of their ward at all because when you gave in the previous night the benzodiazepines, they just go in for severe hypoxia and hypercarbia, and they have gone for carbon dioxide narcosis also. So this particular history, and again, many times you may have to go for awake intubation in these patients. So
yes,
now why I asked you is, suddenly you may be asked some question which you are not actually thinking about. The totally unanticipated questions can be asked in the exam. Okay. So that is one thing which you should always take in the history whenever you have a diabetic patient. The other important history is the medication history is not complete, whatever you have taken. We'll go into detail later, but because whatever you have written is only the 3 anti-diabetic drugs, the oral anti-diabetic drugs you have included in the medication history, because when this patient has been admitted to the hospital, when he has been admitted to the hospital,
like
how many days
around 3 days ago.
Yeah, 3 days ago. So in the hospital, he would have been placed with some other drugs, isn't it? He cannot be only on these oral hypoglycemics, isn't it? So that is the reason why it's very important for us to completely, when you are presenting the case, actually, you are not trying to diagnose something here. You are doing a pre-anesthetic evaluation. Whatever the current medications the patient is on becomes important. Maybe he is on insulin, or maybe he is on antibiotics, or maybe he is on some pain-killing drugs. All those can interact with our anesthetic medications, and all those particular history becomes very important. So another thing regarding your examination, so you have written that the patient's height is 165 centimeters and weight is 55 kgs. Okay. So, but the thing is, just wait for 2 minutes. My charge is going on. I am going off. I'll just get the charger. Okay, just wait for 2 minutes. Yes.
Lakshmesh, when sir asks questions, don't sit and think. If you know answer, yes, otherwise you say, I don't know, so that time will not be wasted.
Okay.
So sir will try and answer that. Should not be a problem.
I think it's okay now. Okay, so his height is 165 centimeters and 55 kgs. His body mass index cannot be 29.5. What was actually his body weight?
Same, sir. 56 only.
Yeah, 55 is this thing. It should be around 20 body mass index. Is he thinly built?
No, not so, sir. Moderately
Then how
built.
can be either your height is wrong or your weight is wrong, whatever that you have recorded.
Okay,
He cannot be 165 centimeters, 55 kgs, because I am also 165 centimeters and 55 kgs. My body mass index is just 20, 20.4. So that you be careful when you are presenting regarding these things. And the other thing you have missed is the temperature recording you have missed. See that the temperature is always recorded in because this patient gives you history of fever. And the other thing is when you want to check whether the pulse rate, whether it is a resting tachycardia is there, you have to know what is the other cause for resting tachycardia other than the autonomic neuropathy, isn't it? So he may have fever also. So unless you have recorded the temperature, you cannot say in the exam this tachycardia was due to either fever or due to resting tachycardia as a result of autonomic neuropathy. So that is one more thing. And always record the pressures, blood pressures in standing and lying down. You can definitely make him stand with support because you are trying to rule out autonomic neuropathy. So postural hypotension is one of the most important components of autonomic neuropathy manifestations. So that you have to do in every examination. So that also you have left out. And examination of spine you have left out. Isn't it? You have not examined the spine. Probably you are thinking of going in for a spinal anesthesia for this patient. And in the exam, if you say spinal anesthesia, then the examiner may question you. You have not examined the spine. There may be some ulcers there or some problem there where, there can be a contraindication for even regional anesthesia there, a central neuraxial block. Okay, that is another thing. And if you think that the patient has higher body mass index, always check for the abdominal circumference.
Okay, sir.
Just to rule out syndrome X. We'll discuss about all those things now. And because, in the investigations, you have written that he has got hyperglycemia of more than 300 milligrams of blood glucose, also has ketone bodies, check for signs of dehydration. Very important to know whether the patient is having the dehydration, what kind of dehydration is a mild, moderate, or severe, what maybe is the requirement of the fluid deficit. So that becomes very important. So that's how, these are some of the observations I have made. So, okay, now let us discuss, going to proper discussion regarding the diabetes and anesthesia. So one of the common questions, I'll be talking about majority of the common questions that we'll be asking you people in the exam. So like, you may be asked to define diabetes mellitus. What is diabetes mellitus? Can you just, we can ask Mukesh. Mukesh, can you just define diabetes mellitus?
So diabetes mellitus is characterized by hyperglycemia.
Very good. So what is it? Is it a endocrinal disease or a metabolic disease or a syndrome?
It's an endocrine disease. Endocrine disease, sir, characterized with hyperglycemia.
Sure. It is not just endocrinal disease, it is a metabolic syndrome.
Okay.
Though it is to do with the insulin that is being secreted from the pancreas, and majority of the times the patients with diabetes are seen by endocrinologists. So it's both a more of a metabolic disorder than a pure endocrinal disorder, isn't it? You can even tell it is a metabolic syndrome. And you're telling correctly that it's characterized by hyperglycemia. That is fine. Okay. What is the cause for hyperglycemia should come in the definition.
Basically, either due to the deficiency of insulin or due to the insulin resistance.
Very good. Absolute deficiency, a lack of insulin, or relative lack due to the resistance, isn't it? Okay, Lakshmi, how do you classify diabetes?
Diabetes mellitus is commonly classified as type 1 diabetes, type 2 diabetes, and other maturity onset diabetes of young, and from the etiological point of view, and other causes like endocrinopathies drug-induced diabetes, and diabetes due to exocrine disease of the pancreas, sir.
And do you have any type 3, type 4?
Unable to recall, sir.
Yeah, type 1, type 2, as you said, it's fine. The other things are, like type 3, many times is gestational diabetes, and type 4 due to other causes, as you said. So as anesthesiologists, why should we, classify diabetes, Lakshmi? Why should we know? And for us, it is majority of the times it is type 1 and type 2, isn't it?
Yes, sir.
So why should we know about this type 1 and type 2 diabetes?
Sir, if we look at the incidences, almost 85 to 90% belongs to type 2 diabetes, and 10 to 15% belongs to type 1. And type 2 is more common, and these are the number of patients coming to surgery. And other end organ damage and complications due to diabetes is more important to us rather than the actual cause of the diabetes, sir. And both type 1 or type 2 can have end organ damage or due to hypoglycemic or hyperglycemic emergencies.
No, we'll come to that, all those things.
Quality of the diabetes.
So most important thing, when you are answering in the exam, your answer should be short.
Okay, sir.
And specific to the question. Like, so the type 1 and type 2, very important is the type 1 of patients always require insulin.
Yes, sir.
Even intraoperatively, they require insulin, isn't it? For us as anesthesiologists, type 2 patients, they don't require all the time insulin, isn't it? So we can even manage them without insulin intraoperatively also. Even otherwise also, they may not require any insulin at all. So that is why it is very important for us. It is whether the patient is type 1 or whether it is type 2 being managed by only diet and exercise, or type 2 being managed with diet, exercise, and hypoglycemic agents. Because we don't say now oral hypoglycemic agents, because there are injectable non-insulin hypoglycemic agents are also, like GLP-1 agonists are also there. And the third thing is type 2 patients, long run, they almost get exhausted. Their pancreas may get exhausted, and it may not be, secreting insulin. So then they may become dependent on insulin. So for us, these three are very, very important. So type 1, which is these patients are totally insulin dependent. Type 2 on oral hypoglycemics or injectable non-insulin hypoglycemics, or on diet and exercise only, or type 2 patients who now are dependent on insulin, because our management depends on these things. So another very important thing we should always talk about is the differences between type 1 and type 2. Many times you will be asked in the exam the differences between type 1 and type 2 diabetes mellitus. So type 1, what is the age of onset?
Age of onset in the younger age.
Mukesh can answer this. Okay, Mukesh.
The type 1 usually occur at the younger age, like 20 to 40 years of age, and usually it's caused due to absolute deficiency.
No, even in children it can occur, isn't it?
Yes, sir.
Type 1 can occur even in children. So less than 40 years majority of the times, and type 2 is after 40 years. Okay, that is one very important difference, is the age of onset, and how the body constitution will be there, Mukesh, in type 1 and type 2. Body constitution means, thin patients, obese patients.
Type 1 will be thin patients. Type 2 will be overweight.
Yeah, type 2 will be overweight, isn't it? And which is, what is the cause for type 1? What is the cause for type 2?
So type 1 is due to absolute deficiency of insulin, but due to immunological restriction of the beta cells.
Yeah, because most of the time it may be pathophysiology is autoimmune.
Yes,
isn't it? Again, we have in type 1, 1A and 1B is there. 1A is totally autoimmune. 1B is idiopathic. We don't know exactly why there is a destruction of the beta islet cells, isn't it? And type 2?
Type 2 is due to decreased secretion of insulin, or increase in insulin resistance by the peripheral tissue.
Yeah, it is mainly because of increased in the glucose production by the liver and decreased peripheral utilization of the glucose because of the insulin resistance, and later because of decreased production of insulin from the pancreas also. That is another thing. And how the presentation of, okay, Lakshmish, how these type 1 patients present and how type 2 patients will present?
Type 1 patients usually symptoms are developed over from small fraction of time, sir, and type 2 patients will have symptoms over months to years, sir.
Now, type 1 patients, majority of the times, their presentation is stormy. They present with, the acute complications like diabetic ketoacidosis. Majority of the type 1 patients present with diabetic ketoacidosis. It is stormy. So diagnosis is very early in type 1. Whereas type 2 patients, majority of the times, they come for something else and it is insidious. The diagnosis of diabetes mellitus is, the accidental diagnosis will occur, isn't it? Your patient, how the diagnosis of diabetes mellitus, was made? About 10 years back, you said that 10 years back.
Yes, 6 years back, sir.
Pardon?
He had 6 years back, it was diagnosed, sir.
Okay. How it was diagnosed? Did you have symptoms of diabetes mellitus?
No, sir. Actually, as a part of their routine healthy checkup, when he was diagnosed to have higher blood sugar level, he was asked to follow up in the hospital, sir. Then with the levels of increased HbA1c level, he was diagnosed.
So that means the diagnosis was totally incidental.
Yes, sir.
Isn't it? So that is how, type 2 diabetes. And why should we know that the type 2 diabetes is always diagnosed very late? Because it is incidental diagnosis, and type 1 diabetes is usually diagnosed very early. Why should we know?
Because in type 2, even by the time we diagnose diabetes, complications would have been set up, sir, which will alter the perioperative management of anesthesia, sir. So
by the time it is diagnosed, already they may have the majority of the complications can be there. So that is very, very important. Whereas type 1, so the whatever the complications of the diabetes mellitus would not have started, isn't it? So that's how it becomes very important. So the other differences between type 1 and type 2, which runs in families, is type 1 or type 2?
Type 2, sir.
Type 2. And sometimes we will be talking about the concordance rate. What is concordance rate?
Not able to recall, sir.
Yeah, concordance rate in type 2 diabetes is 100%. What is concordance rate is, for example, if for example, now identical twins are there. If one of the twins develop the disease, if the other twin also develop the same disease, it is called as concordance rate being 100%. And it is 50% if only one of the twins develop the disease, the other twin does not develop. Like type 1 can be concordance rate is just 50%, whereas type 2 is 100% because it runs in families and also it can be genetic.
Yes, sir. Hello, sir. Hello, sir.
I think Dr. Guru, that the connection has been lost. So we'll wait. I think he'll join again.
Okay.
Yeah.
I think sir is logged off. I think he'll join back.
Okay, sir.
Yeah. Sorry.
Can you tell me?
Yes, sir. 94.
Just a minute.
Sir.
94.
88.
Just a minute. Just a minute.
No problem, sir. No problem. Sir. 9488.
Just a minute.
Not a problem, sir. Take your time.
Tell me.
9488
Okay.
435
Yes.
1761.
61.
Yeah. And passcode is
Tell me.
6457
6457
04, sir. Logged in, sir?
Yeah.
Okay, sir.
Can you see me?
1 second. 1 second. No, sir, I don't think so.
I'm logged in.
Yeah, 1 nimsha. I'll just.
He's here, sir. He's here.
Yeah. Yes, sir.
Okay. Okay.
Are you audible, sir?
Now we'll continue with our discussion. So can I?
Yes, sir.
Hello.
Yes, sir. You are audible, sir.
Audible, sir. Audible, sir. You're audible, sir. You're audible. No worries.
Yeah. Okay. 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 Can I see Lakshmish and Mukesh?
Yes,
Yes.
sir.
Yes, sir.
Yeah. Okay. Now let's go into the complications of diabetes. Mukesh, can you just tell me what are the complications these patients will get or they develop, and how do you classify these complications?
Sir, they are classified into microvascular and macrovascular complication.
No, first you can always classify as acute complications and delayed complications,
Okay.
isn't it? Or long-term complications. What are the acute complications, Mukesh?
Acute complications are diabetic ketoacidosis,
diabetic ketoacidosis.
hyperosmolar state, sir, and also acute hypoglycemia, sir.
Hypoglycemia, isn't it? So these are the acute complications. Again, these acute complications are very important because they can be even life-threatening. Okay.
Yes,
now, Mukesh was talking about the delayed complications or long-term complications. What are these delayed complications here?
The peripheral neuropathies, autonomic.
No, you again classify. You are trying to classify, isn't it? Always in the exam, you try to classify macroangiopathic and microangiopathic lesions. So, what are these macroangiopathic lesions in diabetes mellitus?
Ischemic heart disease, sir. Peripheral.
Yes, very good.
Peripheral vascular disease.
Then
cerebrovascular disease.
Cerebrovascular disease. So these three are the macrovascular complications. And microvascular complications, Hegde, you can tell.
So the microvascular complications are mainly neuropathy, sir, which can be autonomic neuropathy or cardiac neuropathy and peripheral neuropathy, sir. Next important is nephropathy, and other important is retinopathy, sir. These are the most common microvascular complications.
Okay, so these are very, very important. And in the whenever we are taking the history, so this becomes very important for us to know whether the patients are having any acute complications. History of acute complications becomes very important, and again, history of delayed complications are also very important. Now, Mukesh, why should you know about the history of acute complications? For example, if the patient is giving you a history of getting admitted with DKA, or the history of having, again, repeated hypoglycemic attacks. So why should you know about these acute complications history as an anesthesiologist? Why should you get this history?
Sir, if patient came with acute symptoms, there could be a severe dehydration, electrolyte
No. History of, for example, now the patient tells you that 3 months back he was admitted with DKA, or he also tells you that every month or every week he also has all the symptoms of hypoglycemia, or sometimes even he develops severe hypoglycemic attacks. Like even he has gone in for coma for which he was admitted. Suppose if the patient gives this history, or this history is very important for you to take. And why should you take this history? What does this imply? As an anesthesiologist, why it's important for us? Okay, Hegde, why it's important to know? Repeated acute complications the patient is developing.
Sugar levels are more fluctuating, sir, in the past few months, and there may be he's going into the more absolute deficiency state of insulin, sir, increased deficiency of insulin.
No, it gives an indication that whatever the control he has is not proper.
Okay.
Isn't it? He is either going in for hyperglycemic that end, or the other end of hypoglycemia. That means he is not properly having a control of his glycemic status. So if this history is there, these patients are highly labile. Even intraoperatively, preoperatively, postoperatively, these patients can go in for any of these acute complications. So their prognosis, or even the incidence of morbidity, or very rarely the mortality also can increase. So that's why the history of acute complications, if the patient is having, is very important. And how many times the patient is having these hypoglycemic attacks or hyperglycemic problems. So you have to inquire in your history. So that is another very important thing. Then coming to the macrovascular complications. So the delayed complications. The history of ischemic heart disease becomes very, very crucial in these patients. So details about the ischemic heart disease is very important, because you have to know whether the patient, one thing you should always realize, all these patients with diabetes mellitus should be considered to have ischemic heart disease unless proved otherwise by invasive investigations like the coronary angiogram. So otherwise, you always assume that they do have ischemic heart disease. So when you know that invariably these patients, especially type 2 diabetics, once they have 4 to 5 years of diabetes after diagnosis, so invariably you can expect them to have ischemic heart disease. And the history of this becomes very crucial for us, because the management of these patients, anesthetic management. Another very important thing here again is you will have to know whether the patient has had any revascularization procedures. If the patient has had any revascularization procedures, then the patient may be on drugs like antiplatelet drugs, or he can be on anticoagulants. So again, all the problems associated with these drugs will come into play when we are managing these patients, whether to stop the antiplatelet drugs, if the patient is on dual antiplatelet therapy, when he has had the revascularization procedure, whether the revascularization procedure is only a percutaneous procedure, or whether it is an CABG, and when it was done. So can we stop clopidogrel if he is on dual antiplatelet therapy? Suppose if he is on anticoagulant therapy, so what we should do about the anticoagulant therapy if he is posted for an emergency procedure or an elective procedure? So all those questions can be asked for you in the exam. Okay, that is one part. The second part is we have to know whether the patient has got a good left ventricular function or a poor left ventricular function. Because he has got diabetes mellitus, invariably he'll have ischemic heart disease. So because our anesthetic management entirely depends on whether the patient has got a good left ventricular function or a poor left ventricular function. So that is another very important thing, because if he has got a poor left ventricular function, you may not be able to give spinal anesthesia. You may have to go with a lot of caution. The segmental epidural, graded epidural, you can go. Suppose if you want to go for regional anesthesia, and if you want to go for GA, again, you cannot directly go for regular dose of propofol or thiopentone. You may have to go for etomidate, isn't it? So all those things becomes very important if the patient has ischemic heart disease, and details about the ischemic heart disease, it is very important for us to know about. And one more problem in these patients, if they have autonomic neuropathy, they may not have angina.
Yes, sir.
They may not give you any history of chest pain, isn't it? So why they may not give you any history of chest pain if they have autonomic neuropathy, Lakshmish?
There may be sympathetic overactivity with parasympathetic dysfunction, sir. So heart is more like a denervated heart, sir. So they may not have the symptoms of ischemia, sir.
No, how the pain from the heart is related to to the brain. Which fibers will take this pain impulse to the brain, so that the pain is perceived by the patient?
A delta.
No, it is sympathetic fibers, isn't it?
Yes, sir.
It is a sympathetic fibers. So if the sympathetic blockade also, or the autonomic neuropathy occurs of the sympathetic system, then the patient will not be able to perceive the pain. So in such situations, the patient may not give you a history of angina. Then how do you know that the patient has ischemic heart disease?
He may have other failure symptoms, like sometimes like pedal edema or
No, he need not have to have pedal edema or failure, isn't
yes.
it? Because even if it occurs, ischemic heart disease is a left heart disease. So edema is always the right heart problems. So angina equivalent. What is angina equivalent? Breathlessness or dyspnea, exertional dyspnea, and you may have to even go for NYHA classification of this dyspnea also. What is the severity of dyspnea? So because in these patients, that also is very important, that the patients may not have angina, or they may not come out with chest pain if they are having a long-standing diabetes mellitus. So they may have angina equivalent like breathlessness. So that is very important. So the other thing, Mukesh, they may also have a cerebrovascular disease, isn't it? So history of stroke becomes very important, and they are more prone for stroke. So why should you know whether the patient has had a stroke when the patient has had a stroke?
So if patient as having this giving history of there may be accelerated atherosclerosis. Patient
No. Suppose the patient has had a stroke, gives you history, because we are still in the history. So when you are taking the history in a diabetic patient, because we know that one of the delayed complications of diabetes, macroangiopathic lesions, can be cerebrovascular disease. And let us say that the patient gives you a history of stroke about a month back. Now he is being posted for an elective procedure. Can I take him up for the elective procedure, or should I delay the procedure? Lakshmish, have any answer regarding this?
From the
after a stroke, when ideally is the elective surgery should be done? After how long we have to wait?
Not able to recall.
No, usually at least 3 months you have to wait. Ideal would be 9 months after a history of stroke, because the blood-brain barrier will get altered after a stroke, and many times these patients, the vascularity of the brain also will get altered, especially the amount of blood flow to the brain. So after an episode of stroke, so because of this, the incidence of the another stroke is very high. So another, cerebrovascular accident chances will be very high if we take these patients for elective procedures within 3 months. So ideally, you may have to postpone the surgery for minimum period of 3 months. So that's why, history of stroke in these patients, because cerebrovascular accident is very common in diabetic patients, one of the delayed complications. So another delayed complications can be, peripheral arterial disease. Again, Mukesh, why should you know about the peripheral arterial disease these patients are prone for?
The patient who is presenting with symptoms of peripheral vasculitis might have coronary artery disease also, sir.
The peripheral arterial disease. Okay, coronary artery disease already we discussed. Now, how do you diagnose the peripheral arterial disease with history?
Usually patient present with claudication pain. So
Yeah, claudication pain. So as the anesthesiologist, why you should know about this peripheral arterial disease? So it's very important to, there may be, they are highly prone for, the ischemia of the limbs, isn't it? And
Yes.
another very important thing is some of the, the pulses may not be palpable at all. So you have to go into the palpation of all the pulses also in these patients. Suppose if you have not palpated all the pulses and he has got peripheral arterial disease, one of the pulse is missing. So then suddenly you may have problems intraoperatively, because you try to palpate the pulse and pulse will not be there and you may get alarmed, isn't it? And another very important thing is if you want to go for invasive monitoring, so you have to be extremely careful with patients with peripheral arterial disease. So that is another reason why you should know that the peripheral arterial disease is very common and you should examine these patients for peripheral arterial disease and also take the history of claudication pain in these patients. Okay, coming to the microvascular lesions and especially, the nephropathy, the neuropathy and retinopathy. Among them, for us, the neuropathy is very important, then the nephropathy, and then the least important for anesthesiologist is retinopathy.
Yes,
so let
sir.
us briefly discuss about the neuropathy. So as Lakshmi, you have told that these patients are prone for both the somatic neuropathy, that is the peripheral neuropathy, and also they are prone for autonomic neuropathy, isn't it?
Yes.
So can you just tell me about this autonomic neuropathy in these patients? Who are the patients at risk of developing autonomic?
Mainly type 2 diabetes with the long history of diabetes are prone to develop neuropathic changes, sir. And patient who have
One, as you said, is, long-standing diabetes. Okay. Second is geriatric patients.
Yes, sir.
Geriatric patients. Third is, female patients are more prone than the male patients.
Okay,
And fourth is their control. If they are
yes, sir.
not having proper control, then also they are highly prone to develop diabetic autonomic neuropathy.
Yes,
Isn't
sir.
it? So Mukesh, why should you know that whether the patient has got autonomic neuropathy or not?
So it has anesthetic implications because there will be the impaired autonomic response of heart rate to the blood pressure. That will be.
So what are the systems that are involved with autonomic neuropathy? It can involve cardiovascular system, isn't it?
Yes, sir.
Okay.
Gastrointestinal system.
Gastrointestinal system. Yes. Then
Generative system.
a genitourinary system. Yes, correct. Then
and even
the pseudomotor system. Yes, then it can also involve the pupils.
Yes, sir.
Yeah, it can also involve the metabolic components also, isn't it? So what are the, Lakshmi, can you just tell me about the cardiac autonomic neuropathy?
Cardiac autonomic neuropathy from the
What are the
history of
symptoms of cardiac autonomic neuropathy?
exercise intolerance, sir.
Okay,
And
why exercise intolerance?
because there will be abnormal sympathetic function, so exercising group of muscle will not get enough blood supply, so they will have poor compliance to exercise, sir.
No. For
So,
doing exercise, the patients have to get good amount of blood supply, isn't it?
Yes,
Blood
sir.
supply means cardiac output.
Yes, sir.
Perfusion is by cardiac output, but
Yes,
because
sir.
DO2.
Yes,
DO2
sir.
is nothing but cardiac output multiplied by the CO2. That is the oxygen content of the blood. So what happens to the cardiac output? Whenever you want to do exercise or any exertion, the cardiac output has to increase, isn't it?
Yes, sir.
How cardiac output will increase?
Cardiac
It is-
output will increase by increasing the stroke volume as well as heart rate, sir. But mainly
Yes, very good.
heart rate, sir.
So very good. So stroke volume has to increase, the heart rate has to increase. In these patients, what happens to the heart rate? Will there be any increase in the heart rate?
No, sir. There will be not be much increase in the heart rate, sir.
Why there won't be any increase in the heart rate?
Denervation of the
Pardon?
heart, sir.
Pardon?
We could not hear
Properly
you.
audible.
There is impaired. Hello, sir.
Yeah. Tell me.
Yeah. There is unopposed sympathetic action and impaired parasympathetic action, sir. So heart rate may not increase much during exercise, sir.
Yeah, because that is correct. Because they have a fixed heart rate, isn't it? Resting tachycardia.
Yes, sir.
So the heart rate is already increased, and further increase in heart rate may not occur. So for any exertion, so the cardiac output may not increase because the heart rate may not increase. So when the heart rate is not increasing, so these patients, that means the cardiac output is not increasing, the patient will not be able to do a particular exercise. So exercise intolerance is very, very common. So that history you will have to take. So what are the other symptoms of cardiac autonomic neuropathy?
They can
One
have
is exercise intolerance, then other is easy fatigability. Okay,
yes,
that is also there.
then resting tachycardia, sir.
No, that is not a symptom, isn't it?
Okay,
It is
sir.
a sign what you are
And he
going
can
to.
have symptoms of postural hypotension, sir. When he suddenly stands up, he
Yes.
may have symptoms of giddiness or blurring of
Okay,
vision.
okay. That is another very important thing. Postural hypotension, syncopal attacks,
Yes,
frequent syncopal attacks. That is another very common symptom in these patients. Okay, cardiac autonomic neuropathy. Are they prone for dysrhythmias
yes, sir.
Yes.
because of the cardiac autonomic neuropathy?
Yes, sir. More in
Yeah, they are
chances.
also prone for dysrhythmias. And what are the symptoms of dysrhythmias?
Palpitation.
Yeah, palpitation.
yeah.
So they can have history of palpitations also.
Yes,
So
sir.
why dysrhythmias? What kind of dysrhythmias they can have?
Not able to recall.
No, because many times they may have a prolonged QTC interval in the ECG.
Yes.
So because of this prolonged QTC, majority of the times it may be because of an imbalance between the right and left stellate ganglion output.
Okay, sir.
Because of the autonomic neuropathy. Because of that, they may have a prolonged QTC. And what is the most common dysrhythmia that occurs whenever there is a prolonged QTC interval?
Torsades.
Yeah, torsades de pointis. So they may also have torsades de pointis or any other kind of dysrhythmias they are highly prone for. So that is another problem. So
We lost, sir.
we discussed, silent ischemias are very common. So they may not come out with the anginal pain.
Yes.
So, okay, now what are the implications of cardiac autonomic neuropathy for us as anesthesiologists?
They are more prone for labile changes in the hemodynamic parameters like blood pressure and heart rate, so during induction and emergence of the anesthesia.
Yes, very good.
And,
So refractory
hypotension is more common.
They
sir.
can develop refractory hypotension. Okay.
And other important is when we are positioning them for either procedures of anesthesia or for surgery, they can have autonomic changes that will cause change in the heart rate and blood pressure. So.
No, do they develop also refractory bradycardia also?
Yes, sir.
Yeah, they are highly prone for refractory hypotension and refractory bradycardia also intraoperatively. Okay, what are the other things they can? So whenever you are managing them with regional anesthesia like central neuraxial cell block, so the patient may develop a refractory hypotension.
Yes.
And many times this refractory hypotension may not respond to your routine vasopressor drugs like phenylephrine, ephedrine, or methylphenidramine. So many times you may have to use adrenaline.
Yes, sir.
For correcting this hypotension. And second thing is they'll not tolerate, change in the positions. Any change, for example, now head up tilt. So severe hypotension can occur, isn't it?
Yes.
So you have to, if at all, if you want to change the positions for these patients, you have to be extremely cautious and very slowly you will have to change the position. So that
Yes.
is another problem. So again, the silent ischemias intraoperatively are again very common, and dysrhythmias are all kinds of dysrhythmias they can develop, even fatal dysrhythmias they can develop. Sudden cardiac death is also known thing in these patients because of the autonomic neuropathy, cardiac autonomic neuropathy. So it is very important for us to, in the history, to know whether they have any cardiac autonomic neuropathy, and also in the examination. So we'll come to the test for autonomic neuropathy. We'll also discuss. So the other things, what we can do is two things. One is to know whether they have a resting tachycardia, and another thing is whether they have a postural hypotension examination. Otherwise, we'll come into, we'll discuss about all the tests for cardiac autonomic neuropathy a little while later, after discussing about the other systems that are involved. Okay, Mukesh, the other system that can get involved is the gastrointestinal system. So what are the symptoms of gastrointestinal autonomic neuropathy and how it is affects us as far as anesthesia is concerned? What are the symptoms of gastrointestinal autonomic neuropathy?
The patient may present with abdominal bloating, constipation, and diarrhea, and there will be delayed gastric emptying.
Okay, delayed gastric emptying, very good.
Esophageal dysmotility can
dysmotility of the esophagus. Lower esophageal sphincter tone is altered. So there can be reflux also. Belching is very common. So, early satiety is also very common. Gastric distension. Why gastric distension? Why he feels that bloating sensation and gastric distension like symptom?
Because of decreased motility action.
Why there will be a decreased motility? What increases the motility? Which system increases the motility?
Parasympathetic activity will be decreased.
Yeah, parasympathetic activity, parasympathetic autonomic neuropathy will produce gastric stasis, isn't it? Stasis of food for a longer time. So that produces, fullness, early satiety, and also, sort of the patient always feel, the stomach always being full. That is one thing. So the other thing is you said that about the diarrhea and constipation. So which occurs first? Diarrhea occurs or constipation occurs first because of the autonomic neuropathy? Which particular system of the autonomic nervous system gets affected first? Is it the parasympathetic or the sympathetic?
Parasympathetic.
Yeah, it is parasympathetic. What has been found is longer the nerves, more often it gets affected first. The vagus nerve, which is the longest autonomic nerve, that's how the vagus nerve gets affected first. So parasympathetic is the first one to get affected. So parasympathetic is very important in increasing the motility of the GI tract. So once it gets affected, invariably the patient may present with constipation first. Yes, and later, once the sympathetic also gets affected, he may have diarrhea also. So constipation and diarrhea is very important. So now what is the implication of patients having this gastrointestinal autonomic neuropathy for us as anesthesiologist, Mukesh? Now you said that gastroparesis and then esophageal dysmotility. How does it impact you?
So there will be risk of aspiration, sir. And
yes, very good.
Because very of delayed gastric emptying time, the stomach will not be empty. So
these patients should be considered as
full stomach, sir.
Full stomach patients. So once you consider them as full stomach, what precautions you have to take?
We have to go for a rapid sequence induction for these patients.
Yeah, very good. Either rapid sequence induction
And
or you may have to even go for, if you find them to have a difficult airway, awake intubation also. And also you may have to go for aspiration prophylactic drugs also before, isn't it? So
Yes.
that's how it's very important for us to know whether the patient has the gastrointestinal system involvement. Okay, Lakshmish, you said about the involvement of the genitourinary system. So anything important for us?
He can have symptoms of neurogenic bladder, sir. Like he
Okay.
can have symptoms of incomplete evacuation of bladder even after emptying the urine. Then
Okay.
things is he can have erectile dysfunction. And
Okay.
then
No,
he
but
can
as an anesthesiologist, they're very important because, you know, the neurogenic bladder is prone for repeated infections,
yes, sir.
isn't it? So again, that can produce even pyelonephritis.
Yes, sir.
And already the patient may have the problems because of nephropathy, and adding on this also, pyelonephritis, repeated infections can produce more problems. And again, the postoperatively, the urinary tract infections are very common in these patients. So as anesthesiologist, we also have to know about this. Okay, the other thing is about the metabolic derangements they can have. So what about the metabolic derangements, especially which particular problem of the metabolic derangement is important for us, Mukesh?
He can have hypoglycemia unawareness or something.
Yeah, very good. So hypoglycemia, unawareness, and unresponsiveness.
Yes, sir.
Isn't it? So, Lakshmish, why hypoglycemia unawareness?
Whenever there is a hypoglycemia, sympathetic system will act, sir. It produces palpitation, restlessness, sweating, and all. So
yeah, what blood sugar level usually the adrenergic symptoms will occur. These are called as adrenergic symptoms because the sympathetic system gets activated whenever there is hypoglycemia. It's a stress. So stress hormones are released, and most important stress hormones are definitely the catecholamines. So the adrenergic symptoms occur. At what blood sugar level the adrenergic symptoms do occur in these patients?
Not able to recall.
Now, if the blood sugar starts coming down anything less than 70 milligrams per deciliter, so the adrenergic symptoms will start. So, and once the adrenergic symptoms starts, the patient will come to know that he is going in for hypoglycemia, and he'll eat something, isn't it? Or he'll even take some sugars, so he can avoid it. But in these patients, these adrenergic symptoms may be blocked. The patient may not know because he has got sympathetic autonomic neuropathy. So sympathetic adrenergic symptoms may not be felt by the patient. So that is the reason. So what are the adrenergic symptoms the patient can have?
Palpitation, sweating.
Yeah, palpitation, sweating, tremors.
Tremors.
Isn't it? Palpitations, tremors, sweating. So these symptoms, very important symptoms, may not be felt by the patient. So unawareness of the hypoglycemia, and directly the patient may go for neuroglycopenia, isn't it? So it can be even fatal also.
Yes,
that
sir.
is why this autonomic neuropathy becomes very, very important for us to know about. Even intraoperatively, he may not know that he is going in for hypoglycemia because he is not manifesting with adrenergic symptoms. So that is one thing. The other thing is the unresponsiveness for hypoglycemia is also very common, isn't it? What is this response that occurs whenever the patient develops or is going in for reduced blood sugars? How the body will respond to this?
There will be increase in glucagon level, and hepatic gluconeogenesis will occur. And
so the release of counter-regulatory hormones, isn't it?
Yes.
So immediately the body will try to release the counter-regulatory hormones like cortisol, then all the stress hormones, glucagon, and catecholamines, growth hormone, So all these will increase neoglucogenesis and glycogenolysis, isn't it? So that because of that, they'll increase the blood sugar levels. So once the blood sugar levels are increased, so the patient, the hypoglycemia can come down, isn't it? In the meantime, the patient also will try to take some food or even sugars. So, but if the body does not respond and the patient is also not knowing that he's going in for hypoglycemia, so then it becomes a very serious matter. So that is the reason very important for us to know that whether the patient has autonomic neuropathy involving the metabolic system also. So one more thing is the pseudomotor problems. So Lakshmi, what is the pseudomotor problems? Because of that, what symptoms the patient can have and how the anesthesiologist has to know about this? What are the implications of anesthesia?
He can have anhidrosis, gustatory sweating, sir.
Anhidrosis or even dishydrosis.
Okay, sir.
So when he has to sweat, he may not sweat.
Yes.
When he should not sweat, he may sweat, isn't it? There can be total dishydrosis can be there, anhidrosis can be there, temperature regulation, because the sweating is very important for temperature regulation. So temperature regulation may be altered. So because of this, these patients are highly prone for both hypothermia and hyperthermia. And majority of the times, they are highly prone for intraoperative and postoperative hypothermia. So more prone than other patients who do not have any autonomic neuropathy. So that is why it is very important to know about autonomic neuropathy. And of course, they can also have an Argyll-Robertson pupil-like pupil, isn't it? Where accommodation reflex is present, but light reflex is absent. So that also will be there. So these are some of the signs and symptoms of different systems of autonomic neuropathy. But there are certain tests are there to know whether the patient has autonomic neuropathy or not, especially the cardiac autonomic neuropathy tests are there. So who introduced these tests and when it was introduced? Cardiac autonomic neuropathy CAN tests, they are called as CAN tests. So it was introduced in 1979 by Clark and Ewing. Clark and Ewing introduced these cardiac autonomic neuropathy tests in 1979. Again, they modified these tests in 1993. So what we are usually using the present day cardiac autonomic neuropathy tests were being introduced by Clark and Ewing. So, okay, there are 5 tests are there. The tests are there for parasympathetic system and tests are there for sympathetic system. So Mukesh can talk about the tests for parasympathetic system, and Lakshmi, you can tell about the test for sympathetic system. Invariably, you will be asked these things in the exam. Autonomic neuropathy tests. Though many times you may not be doing these tests, but you have to know about these tests.
Okay.
Okay, Mukesh, parasympathetic.
For parasympathetic test, heart rate variability with respect to respiration, the patient is asked to
deep
take
breathing.
Deep
it is called as heart rate response to deep breathing. There are 3 tests: heart rate response to deep breathing, heart rate response to Valsalva, heart rate response to standing. Okay. Now, heart rate response to deep breathing. How do you do this test?
So patient is asked to take a deep breath at a rate of 6 breaths per minute. Then the heart rate and
why 6 breaths? Why not 8 breaths? Why not 9 breaths?
At a rate of 6, there is a maximum variation in the heart rate, sir, as per the hypothesis.
Yes, very good. So they have conducted these tests on number of patients, Clark and Ewing, and they have found out that the maximum variation of heart rate, because sinus arrhythmia,
yes,
isn't it? So maximum variation of heart rate occurs when a patient takes 6 breaths per minute. So this 6 breaths per minute means how many seconds for each breath?
10 seconds.
So 10 seconds for each breath, isn't it? So again in this, so each inspiration and expiration should be equal.
Yes, sir.
Yes.
That's how they have to take 5 seconds for inspiration, 5 seconds for expiration. So that is for 6 breaths per minute. Okay. Now, what is the normal heart rate variation? And in these patients, when you think that it is significant to say the patient has got diabetic autonomic neuropathy?
Usually the ratio of longest RR interval to shortest RR.
No. It need not be the ratio. You can even know the heart rate by RR interval,
Okay.
isn't it?
Yes, sir.
So, Mukesh, how do you check with the heart rate from RR intervals? Normally, how do you check? The small squares between the RR interval or the large squares between the RR interval. How do you get the heart rate from RR interval? How about Lakshmi?
Number of box between the RR interval divided by 300.
The opposite.
300 divided by number of box between the RR intervals.
Yeah, isn't it? R 1500 divided by number of small boxes. So you can directly know what is the heart rate.
Yes, sir.
Isn't it? During inspiration and during expiration. So what happens to the heart rate during inspiration? This is taking a deep inspiration and also deep expiration.
Heart rate
Heart
is
rate? Yeah, why heart rate should increase during inspiration?
So there will be increase in preload.
Yes, correct. Because you are creating negative pressure, more blood enters into your right heart. So naturally, vein bridge reflex. Immediately the stretch receptors get activated. So they increase the heart rate, isn't it? Vein bridge reflex. Sometimes you may be asked about vein bridge reflex also in your discussion. Okay, during expiration, so invariably there is more towards the positive pressure inside the thorax, so less venous return. So there is decrease in the heart rate. This is a protective reflex by the heart. So more blood flow enters into the heart, it tries to push the blood back into the systemic circulation, isn't it? So heart rate should increase during inspiration, heart rate should come down during expiration. So this is otherwise called as sinus arrhythmia also. Normally also it occurs and it becomes more pronounced when the patient is taking deep inspiration and deep expiration. So how much should be the normal variation during inspiration and expiration? How many beats or how many breaths?
More than 10 to 15 beats.
How many beats?
10 to 15 beats per minute.
Yeah, usually more than 15 beats per minute variation should be there when the patient is taking deep breaths. So when you say it is significant to say the patient has got diabetic autonomic neuropathy.
And the variation is less than 10 beats per minute, sir.
So it says that the patient may have autonomic neuropathy. So significant is when the heart rate variation is less than 5 beats per minute. Then you can definitely say the patient has diabetic autonomic neuropathy. Okay. Now the second test is, the standing test or heart rate variation for standing. So how do you check this?
Initially the blood pressure initially the heart rate is measured when patient is sitting position. Then the patient is asked.
No, you have to do a continuous ECG monitoring. The patient is lying down, you are continuously recording the ECG. Now you have to ask the patient to stand and ECG recording should be continued, isn't it? Yes. Now you have to see the maximum RR interval and then the minimum RR interval. So maximum RR interval by 30th beat and minimum RR interval at 15th beat. That is what in 1979 they did, and they modified it in 1993, saying that between when the less than 15th beat, what is the maximum or the minimum RR interval, and from 15th beat to 30th beat, what is the maximum RR interval? You can take any one of them, because there is always a confusion. If originally they said that 15th beat. If they say 15th beat, RR interval between 14th and 15th or 15th and 16th, there was a confusion. Again, 30th beat, again RR interval between 29th, 30th or 30th and 31st. That's why they have modified it. So the shortest RR interval in less than 15th beat and the longest RR interval in between the 15th beat to 30th beat. So the ratio you have to take from the longest RR interval to shortest RR interval. What will be the normal ratio?
Greater than 1.2 will be there, sir.
Yeah, very good. So when do you say it is significant in these patients?
Less than 1, sir.
Yeah, less than 1.03 or less than 1 also. So that means there is not much of heart rate variation even when they are standing, isn't it? So that means the sympathetic activity is not occurring. So that is the reason why they may also have a postural hypotension also later. So again, the heart rate response to standing. Now the third thing is heart rate response to Valsalva. So let me ask Lakshmish. Lakshmish, how do you do this? Many times this is commonly asked. I have seen, the examiners asking you to write down the heart rate response in different phases of Valsalva on your the case sheet and then show them. So can you explain about the Valsalva maneuver and how the test is done? What will be the normal response and what will be the response in patients with diabetic autonomic neuropathy?
Here, sir, the patient will be given in supine position and he is connected to the ECG monitor for knowing the RR interval. Then he is connected to a manometer where he is asked to exhale for a 15 second with the pressure of 40 mmHg.
No, otherwise, what is Valsalva maneuver?
Valsalva is expiration against closed glottis, sir.
No, will it be done like that? The patient will be exhaling against a closed glottis here?
No.
Against a closed valve of the manometer.
Yes, sir.
It's a specially designed manometer will be there,
Yes,
where
sir.
the valve will open during inspiration, the valve will close during expiration.
Okay, sir.
So when the patient is trying to expire, the valve is closed.
Okay, sir.
And what is the pressure he has to create during Valsalva?
40 mm of Hg, sir.
Yeah, he has to create at least about 40 millimeters of the pressure. Okay, so now what will happen?
There are 4 phases of Valsalva, sir.
Very good, very good.
In phase 1, as he trying to exhale, intrathoracic pressure will increase. So there is a increase in the blood pressure and there is a decrease in the heart rate, sir.
So why if the increase in intrathoracic pressure occurs, why there will be an increase in pressure and decrease in the heart rate? Now what will happen, Lakshmi, here is the blood is squeezed out of the central blood volume to the peripheries. Because of sudden increase in the intrathoracic pressure from the aorta also and from the superior and inferior vena cava, the blood is pushed to the peripheries. So once so much of suddenly the more amount of blood enters into the peripheries, automatically the pressure will increase, isn't it? And Mary's law, once the pressure increases, what happens to the heart rate?
Decrease.
Heart rate has to decrease. That's why
Yes.
initially the first phase, the heart rate will decrease. Now you know what is the reason why the heart rate decreases. Okay. What happens in the second phase of Valsalva?
In the second phase, the initial fall in the blood pressure followed by rise in the blood pressure, sir.
Heart rate.
And also there is increase in
Here, the heart rate had in the first phase, the heart rate had decreased. In the second phase, now the venous return will immediately, comes down because of the sustained increase in the intrathoracic pressure. Now, what will happen to the heart rate? Because the pressures now will fall.
heart
Blood
rate
pressure will fall. So the heart rate will
increase.
Okay. And afterwards, body will try to sustain the heart rate because somehow the body will try to compensate,
Yes,
isn't it? So the heart rate which is increased will sustain, it will not further increase. Now the patient will release the pressures. That is the third phase. So immediately what will happen once the patient releases the pressure?
There is a increase in the venous return, so increase in the blood pressure and decrease in the heart rate, sir.
No. In the third phase, there is sudden increase in the heart rate because there is further decrease in the pressures because as soon as he releases the pressure of his thorax, so body will take some few milliseconds before the blood will or the venous return can come to the heart and then, increase the cardiac output. There's a brief interval in which there won't be much increase in the venous return as soon as he takes out the pressures. So that is the time when suddenly the pressures will fall, there is an increase in the heart rate. The maximum increase in the heart rate occurs in the third phase. This is the third phase.
Okay, sir.
Then it is followed by fourth phase, wherein suddenly the venous return, enough venous return will enter into the heart, and the cardiac output increases, the blood pressure increases, so the heart rate will come down. So there will be an overshooting of the pressures, and also there will be the bradycardia will occur. And the maximum decrease of heart rate occurs in the fourth phase because of the overshoot of the pressures. And the maximum increase in the heart rate occurs in the third phase. This is a normal one. And you have to look for the longest RR interval and then the shortest RR interval, and you have to get the ratio. So what will happen to the ratio in normal individuals?
Ratio is more than 1.2 in normal individuals, sir, and ratio less than 1.2 signifies there is a autonomic neuropathy, sir.
Yes, the overshoot will not be there in diabetic patients. Normally, whatever the overshoot that occurs in the phase 4 is always abnormal in diabetic patients with diabetic autonomic neuropathy. So that's the reason they may have increase in heart rate and there may not be any decrease in the heart rate. So that's how the ratio will be either 1 or even less than 1. It will be definitely less than 1.2. So this is the Valsalva maneuver and the parasympathetic involvement. These three are the tests for parasympathetic cardiac autonomic neuropathy. Okay, Mukesh, for sympathetic autonomic neuropathy, there are two tests, isn't it? One is the blood pressure changes in standing and the blood pressure variation after sustained hand grip. So what is this blood pressure changes with standing?
Sir,
how do you do this test actually?
First, the blood pressure is measured when patient in the sitting position. Then
sitting or lying down?
Lying down, supine.
Lying down, always supine. That's what I was telling Lakshmish again, that he had he should have examined at least this to rule out autonomic neuropathy in these patients. Plus, the patient is already having ketone bodies and also the blood sugars are so high. Chances of dehydration are very high. Hypovolemia also you can know, because hypovolemia also will present with the postural hypotension. So very important to test for these things when you are examining a patient with diabetes mellitus patient. Okay, now you record the pressures in supine posture and then you make the patient to stand. So after how long time you are going to record the pressures? Immediately, or you allow the body to compensate for few minutes? When you should actually record the pressures?
After 2 minutes.
After 2 to 3 minutes. You should give enough time for the body to compensate. Now, how the body will compensate as soon as you get up? Because because of the gravity, venous stasis will start. The venous return may not be adequate, isn't it? That is the reason even in normal persons, there will be slight decrease in the pressures. Because the cardiac output decreases, the pressures may decrease. So how the body immediately will take care of this?
Normally, as soon as the person stands, the systolic blood pressure can drop up to 30 mm of Hg and diastolic can drop up to 10 mm of Hg. And then baroreceptor reflex will take care. It will increase the heart rate. So by that,
sympathetic activity. Immediately sympathetic activity will occur. So the constriction of the venous system also will occur.
Yes.
Because of that. So venous return will immediately increase. So once the venous return increases, the cardiac output is stabilized. So the blood pressure gets stabilized.
Falling blood pressure is usually less than 10 mm Hg in healthy individuals.
Okay. So in patients with diabetic autonomic neuropathy, there can be a fall of more than
10, or it can go up to more than 30 mm Hg.
Usually more than 20 millimeters of mercury, you always say that it is the significant cardiac autonomic neuropathy, sympathetic system involvement.
Yes.
Okay, one more test that is done is hand grip test. isn't it? So for this test, what equipment is required? A dynamometer is required.
Okay.
For hand grip test, a dynamometer is required. The patient is asked to press this dynamometer with maximum force and see what is the maximum force he can press the dynamometer, and then he has to sustain 30% of that for
Yes.
about 5 minutes, and you'll be recording the blood pressure in the opposite upper limb. When you're recording the blood pressure in the opposite upper limb, you look for the diastolic pressure. Normally, the diastolic pressure will increase by more than 10 millimeters in normal individuals without diabetic autonomic neuropathy. But in these patients, there may be a fall in the diastolic pressure if
Yes.
they have cardiac autonomic neuropathy. So this is the another test that is called as the blood pressure variation in sustained hand grip test. So these 5 tests are called as the cardiac autonomic neuropathy tests that were introduced by Ewing and Clark. And how do you grade based on these tests about the diabetic autonomic neuropathy? How do you grade it as mild, moderate, and severe? Which test to say that it is a mild autonomic neuropathy, which test to say that it is a moderate, and which test also, if it is there positive, you say it is a severe one. Okay, Mukesh.
Heart rate variability with deep breathing is indicates the mild and this one.
No, heart rate variability with deep breathing, yes, very good. It's a mild one. When do you say it is moderate?
Heart rate variability with Valsalva maneuver is moderate.
Valsalva. Yes, very good.
And
So severe when
patient
sympathetic nervous system is also involved, isn't it? So always better to know about these autonomic neuropathy tests. So these can be asked for your theory also. Many times it has been asked, the 10-mark question is there regarding autonomic neuropathy. So, and its implications. So now we had a good discussion about diabetic autonomic neuropathy. So it's very important for theory as well as the practicals also. Now coming to the other things regarding the diabetes mellitus. So invariably these patients will be on anti-diabetic drugs.
Yes, sir.
Isn't it? So these patients, especially if the patient is on a type 2 diabetic, he may be on oral antidiabetics or injectable non-insulin antidiabetics. And if he is an insulin dependent diabetic, so or type 1 diabetic, he'll be on insulin. Or even many times the type 2 diabetics can be on both insulin and oral antidiabetic agents. So let us discuss about these oral antidiabetic agents. So Mukesh, how do you classify these oral antidiabetic agents? Oral or injectable also? Because now I told you GLP-1 agonists, receptor agonists are available as injectable form, non-insulin injectable form. So how do you classify them?
They are classified as sulfonylureas, magnetitide, bigonides, and
Sulfonylureas, meglitinide, okay.
bigonides.
So usually both of them are classified under what heading? Yeah, you can classify them as secretococcus first. Secretococcus. So examples are sulfonylureas and meglitinides. Okay. Next is
phosphodiesterase 4 inhibitor and GL.
No. Next is sensitizers. So very easily, I'll tell you how you should classify very easily. One is the secretococcus. Under secretococcus, sulfonylureas and meglitinides. Then is sensitizers. Under sensitizers, you have biguanides and thiazolidinediones. Okay. Next thing is very important is incretin mimetic agents. Incretin mimetic agents. Ones which will increase the amount of incretin in the body. So again, you have DPP4 inhibitors, that is dipalmityl. What is DPP?
The net is bad.
No, there is some.
Dipeptidase 4 inhibitors, sir.
Okay.
DPP4, am I audible,
inhibitors.
sir?
Yeah, now it is audible. Another thing is the GLP-1 agonists.
Yes, sir.
These are incretin mimetic agents. Okay. The next two groups of things are one which actually increases the excretion of glucose from the urinary tract, that is from the kidneys. So which inhibits SGLT2 inhibitors, isn't it? So SGLT2 is very important for reabsorption of glucose from the proximal convoluted tubules, isn't it? What is SGLT? SGLT2, sodium glucose co-transporters.
Yes,
So
sir.
if these co-transporters are very important for reabsorption of glucose from the proximal convoluted tubule. So if we inhibit this, there is more amount of excretion of glucose from the urine or through the urine from the kidneys, isn't it? So that's how, the glucose levels will come. So the other group is from the gastrointestinal tract. Excretion of glucose occurs. That means if the reabsorption of these glucose or the carbohydrates from the GI tract, if it is not occurring, so alpha glucosidase inhibitors.
Yes, sir.
Isn't it? So acarbose, alpha glucose inhibitors. So what is this alpha glucosidase inhibitors? How they help in decreasing the absorption of carbohydrates from the gastrointestinal tract?
Basically, they inhibit the alpha glycosidase enzyme, so as to inhibit the degradation of the
conversion of disaccharides to monosaccharides. It is only the monosaccharides which can be absorbed from the gastrointestinal tract, isn't it? So there is an inhibition of conversion of disaccharides to monosaccharides. So that's how, more excretion of these decreased reabsorption or absorption and more excretion can occur, isn't it? So that's how very easily you can classify the oral and non-insulin injectable anti-hyperglycemic agents or hypoglycemic agents. The first is, as I told you, that the secretagogues, then it is sensitizers, and third group of incretin mimetic agents, and then fourth is one which increases the excretion through kidneys, that is SGLT2 inhibitors, and the other one is the alpha glucosidase inhibitors. Now we have to know about these drugs individually, isn't it? Because many of the patients can be on these drugs. Okay, let us discuss about the sulfonylureas. So how do you classify the sulfonylureas, Lakshmish?
First generation and second generation sulfonylureas, sir.
Okay.
In first generation, we have chloropropamide and tolbutamide.
Tolbutamide, very good.
And in second generation, we have glibipride, glibenclamide, gliclazide, gleburide drugs, sir.
Okay, very good. So what is the difference between this first generation and second generation? First generation are long-acting drugs.
Yes, sir.
There are
more risk of hypoglycemia is with the first generation, sir.
Yeah, first generation, prolonged hypoglycemia.
Yes, sir.
Isn't it? So what we use nowadays is the second generation only. But still, these agents are very dangerous. They can produce quite a bit of hypoglycemia.
Yes,
isn't it? So that's how you have to be extremely cautious about these agents. They may have to be stopped on the day of surgery. And another problem, what is the other problem with the sulfonylurea drugs? How do they actually release the insulin? They are secretagogues, isn't it? So how they increase the secretion of insulin from the beta islet cells?
They block the potassium channel.
Yes, very good, Mukesh. Yeah, they block the potassium ATPase potassium channels in the beta islet cells of the pancreas, isn't it? That's how they release. So is this potassium channel blocking effect also can produce other problems for the patient?
Ischemic
Suppose if it, this also occurs in the heart.
Yes.
This also will be occurring in the heart. The potassium channel gets blocked. So the ischemic preconditioning is mainly because of the opening of these potassium channels in the heart.
Yes,
So
sir.
by blocking these potassium channels in the heart, they may also interfere with the ischemic preconditioning. So that's how, they may have to be stopped, because that is again very important in the perioperative period for prevention of ischemia and the effects of ischemia.
Yes,
So
sir.
these two are the problems with sulfonylurea drugs. So invariably, we don't continue the sulfonylureas on the day of surgery, whether it is a minor surgery or a major surgery. Very
Yes, sir.
important thing. Okay, and other problem is severe hypoglycemia they can produce. Okay, what about the meglitinides?
They are potassium channel regulators.
Meglitinides, the difference between sulfonylureas and meglitinides is their extremely short duration of action, meglitinides.
Okay.
Again, they can produce quite a bit of, hypoglycemia. Nowadays, hardly meglitinides are used because of their shortest duration of action, because they may have to be taken just about half an hour or 1 hour before meals. So because of their short duration of action, so they are hardly being used. Okay. Now coming to the sensitizers. So we have, I told you the sensitizers, we have biguanides, and also we have thiazolidine diones. So the biguanides, the most commonly used biguanide is metformin.
Yes, sir.
Okay. Now, Mukesh, how these metformin acts?
So it decreases the hepatic glucose synthesis, and also decrease the insulin, increases the sensitivity, peripheral sensitivity to the insulin. Basically, the uptake of glucose by the peripheral tissue will be more.
Yes. Most important thing is it's the glucose production from the liver. That is the most important, the effect of these biguanides, especially the metformin. Fenformin was the first one to be introduced, but fenformin used to produce lactic acidosis. That's why it has been withdrawn. So metformin nowadays is most commonly used, and one of the first drugs that is always given for the type 2 diabetics, metformin, isn't it? Because it increases the peripheral, increases the or decreases the glucose production from the liver, and also especially it produces sensitization in the periphery, and also it helps in the early satiety and weight loss also. It helps in weight loss also for the patient, which is very, very important in diabetic patients. So suppose the patient is on metformin, so what should we do? Should we continue the drug on the day of surgery, or should we withhold?
If it is minor, we can continue minor surgery and expected to start the meal after post surgery. We can be continued. Otherwise, it has to be withheld.
So majority of the times, you usually stop metformin also on the day of surgery, though we know that there is a remote chance of patient developing lactic acidosis, isn't it? So that is one of the reasons why usually we don't continue metformin on the day of surgery. So majority of the drugs we don't continue on the day of surgery, including the biguanides, isn't it? So now coming to the thiazolidine diones. So what about the thiazolidine diones?
Pioglitazone, rosiglitazone.
Yeah, they mainly, they are sensitizers.
Sensitizers.
Yeah,
They
they improve the peripheral utilization of glucose. And what is one problem with these, thiazolidine diones? What
retention,
complication they can produce?
Water retention, weight gain, and case of ischemic cardiac failure can happen.
Yeah, they can produce cardiac failure, isn't it? So that's how, nowadays hardly thiazolidine diones are being used. So if the patient is taking these, you have to check for any cardiac failure in these patients. And also it may have to be not to be given on the day of surgery. Okay, coming to the other drugs like DPP4 inhibitors. So I told you they are incretin mimetics. What is this incretin, Lakshmish?
Incretin is a hormone released from the intestine, sir, which will stimulate the release of insulin whenever there is a presence of glucose, sir. So these incretin mimics all the drugs which will act as a secretagogues only in the presence of glucose, sir.
In the intestines.
In the intestines. Yes,
isn't it? When carbohydrate meal is taken, so incretin is released from the endothelial, the epithelial cells of the intestines, and this incretin will help in the release of the insulin from the beta islet cells of the pancreas. So, what is the half-life of this incretin? It is
Not
extremely short. It is
okay.
extremely short. It is in milliseconds. So it gets destroyed by DPP.
Yes, sir.
Dipalmityl peptidase enzyme is the one which destroys incretin.
Yes,
That is
sir.
why, if you give a DPP-4 inhibitor, so incretin that is released is not destroyed. Incretin that is released from the gastrointestinal tract can have a prolonged duration of action. That's how a sustained release of insulin can occur.
Yes, sir.
So that's how DPP-4 inhibitors will help. GLP-1 itself is an incretin.
Yes, sir.
So, but GLP-1, the difference between the incretin and GLP-1 is GLP-1 will have a long duration of action,
Okay, sir.
unlike incretin. So it will not be destroyed by DPP-4.
Yes, sir.
That's how, it also helps in the increased release of insulin whenever there is carbohydrate intake. That's how these two will help. So should we continue GLP-1 agonist on the day of surgery?
Yes, sir. We can continue in minor surgeries where patient is expected to skip one meal.
Now, one thing you should realize, the GLP-1 also produces, delayed gastric emptying. And also they decrease the intestinal motility. And many of these GLP-1 will have a long duration of action. So because they can produce, decrease or delay in the motility or decrease in the gastric emptying, so it is always better you stop GLP-1 agonists, receptor agonists. They are not to be continued on the day of surgery. Many people will say that they may have to be stopped at least one day before.
Okay.
GLP-1 receptor agonists. So now what about the DPP-4 inhibitors? Should we continue on the day of surgery or should we have to stop on the day of surgery?
It's to be stopped, sir.
DPP-4 inhibitors. So any problems because of DPP-4 inhibitors? Usually they have been found not to produce hypoglycemia, though they secrete insulin.
Yes,
they're
sir.
quite safe. So it has been found that even if they have been continued on the day of surgery, they have not produced any problems. So they may produce, a better effect in maintaining the glycemic status. That is why only DPP-4 inhibitors are the class of drugs which can be continued on the day of surgery. All other drugs you may have to stop. Now coming to SGLT2 inhibitors. So Mukesh, what about the SGLT2 inhibitors? Can we continue them or we have to stop them on the day of surgery?
It has to be stopped, sir, before the
Why?
surgery.
What are the problems of SGLT2
euglycemic
inhibitors?
ketoacidosis can euglycemic
Pardon?
Euglycemic ketoacidosis, sir.
Yeah, they are prone to produce a complication called as euglycemic diabetic ketoacidosis. One rare complication is always there with SGLT2 inhibitors. What are the other problems?
Risk of UTI, sir, since they are excreted in the urine.
Yeah, the risk of repeated urinary tract infections can occur. Even candidiasis is very common with that. And more important than these things for us as anesthesiologists. Because, they are excreting glucose, isn't it?
Yes, sir.
Along with glucose, what else is being excreted out?
sodium. Sodium.
Water.
Yeah.
Water is also excreted. Electrolytes are also excreted. So these patients may develop dehydration,
Yes,
hypovolemia, dehydration, electrolyte imbalance intraoperatively. That is why, many times these SGLT2 inhibitors may have to be stopped at least 2 days before the surgery.
Yes.
On the day of surgery, definitely they should not be continued. SGLT2 inhibitors. Okay. How about alpha glucosidase inhibitors?
They have to be stopped on the day of surgery, sir. Since
So there is no meaning in continuing them, isn't it?
yes, sir.
Because they are effective only if food is taken.
Yes, sir.
And invariably you keep the patient, fasted, empty
Yes,
stomach. So there is no point in continuing the alpha glucosidase inhibitors. Okay, so these are very, very important things about the hyperglycemic agents, non-insulin anti-hyperglycemic agents, and whether to be continued or not, and what are their implications if we continue. So these becomes very, very important during your practical exam also, because invariably the patient can be on, especially your patient has got a DPP4 inhibitor he is on, and
Yes,
he is also on a sulfonylurea drug, glimepiride he is on,
yes,
and
sir.
he is also on,
Biguanide.
metformin, a biguanide. So definitely you have to know whether to continue these drugs or not to continue. Out of that, only DPP4 sitagliptin or which gliptin he is on.
Vildagliptin, sir.
Which one?
Vildagliptin.
Vildagliptin. If that is the only thing which can be continued on the day of surgery, other two you have to stop. So these are very, very important. Of course, now we have almost reached 8 o'clock. So I think tomorrow we can continue with the insulins. So the pharmacology of insulins becomes very important. Read about pharmacology of insulins and we'll discuss. And then we will also discuss about few of the things which you have left out in the examination, especially the prior sign you have not dealt with. We'll also discuss about the prior sign. And also we'll go into the investigations for these patients, and also the intraoperative hyperglycemia, how to manage, what are the different regimes, and also how anesthesia has to be managed in these patients when they are posted for elective procedures, and also when they are posted for emergency procedures. I think Dr. Azam will give a break for today, and we'll
yes, sir,
continue tomorrow at 10 o'clock
yes, sir.
again.
Yes, sir. Sorry, sir.
If
I
there
think
are
I'm
any-
taking the phone from long time.
Yeah,
It-
that is
Sorry,
again,
sorry,
I'm
sir.
not very comfortable with
I know, sir.
talking on phone.
I know. We'll do one thing, sir. Tomorrow we will log in little early. We'll
Okay.
give a dryer. And
Yeah,
then
we'll
we
check
will.
with the laptop, and then probably tomorrow, I think there should not be any problem.
Sure. Sir, there
Okay.
are a few questions, sir. Can
Yeah,
we
we
take?
can go ahead and then answer them, and start tomorrow afresh.
Done. So one question from Saurabh, sir. We discussed about OSA, correct, sir? So he was
Yes.
asking, will oral alprazolam of 0.25 mg can lead to hypercarbia in OSA cases?
Yeah, in severe OSA, because there is a case report. There is
Yes,
a case report which I had actually reviewed also, and it got published also. And in that, the patient did not get up in the morning. He was posted for a hernia repair. He was given just 0.25 milligrams of alprazolam. He was a known severe OSA patient. So once he was not getting up, so the call was sent to the anesthesiologist. So immediately went to the ward, shifted the patient to the OT, started ventilating. In the meantime, he had taken an ABG also. He had very severe hypercarbia. It was somewhere 100 millimeters of mercury of PaCO2. So you have to be extremely careful with these sedatives and hypnotics for these OSA patients.
So can we take it as better to avoid, sir?
Yeah, better to avoid in severe OSA.
Yes, sir.
Better to go for psychological pre-medication rather than
Yes.
pharmacological pre-medication, anxiolysis.
Yes, sir. And Sudeep Royal, sir, do we need to do bedside autonomic function test for every diabetic patient in the exam?
No, you can do definitely 2 tests. That's what I was telling. So one is you palpate for the pulse, and then also the temperature, and try to know if there is tachycardia. Try to rule out all the other causes of tachycardia. Once you rule out all the other causes of tachycardia, then you can say resting tachycardia. And also you can make the patient to walk for few steps, and then see whether the heart rate increases or not. So that test you can do. The second test you can also do, already we discussed, is to make the patient stand and record the pressures after 2 minutes. and see if there is a difference of more than 20 or 30 millimeters fall of systolic pressure. These
Yes.
only two tests you can do. Other tests you only you'll be asked, and then you may have to be able to tell about the Valsalva and other tests. You don't have to do all those tests.
So from exam point of view, you have to know everything. I mean,
Yeah,
test.
all the
So you will be
CAN
asked.
tests,
Yeah.
the cardiac
Yes.
autonomic neuropathy tests.
Yes, sir. So the other question was from Nipa, sir. One of my type 2 diabetic patient complain of jaw pain with claudication. So what could be the correlation, sir?
Jaw pain.
So, because while claudication, patient develops jaw pain. I mean,
So he may be having both myocardial ischemia as well as peripheral, decreased blood flow.
correct.
Jaw pain is usually due to
Yes.
myocardial ischemia.
Yes, sir. Should not
Yeah,
be taken.
both are not directly related, but definitely patient is having both myocardial ischemia, because claudication also occur after a particular distance the patient walks.
Yes, sir.
At that particular distance when the patient has walked, so he might have developed myocardial ischemia, which is producing a jaw pain plus claudication.
Yes, sir. So take home messages should not be taken it lightly. It should be valid.
Yeah, sure.
So Dr. Hemang's question, can we prescribe acarbase in type 1 diabetes?
The acarbose, definitely one can use it along with insulin, but insulin is more important in diabetic type 1 diabetic patients. Definitely one can use.
Yes, correct. So, but insulin is the main.
That is always, insulin is the drug, because there is absolute lack of insulin.
Yes, sir. And metformin in diabetes with pancreatitis.
Metformin, you may have to ask the endocrinologist this question.
Sir. Yeah. So can we give metformin in type 1? I mean, as you said, we can give, but still the insulin is absolute deficiency of insulin, so they need insulin, right? So can we give SGLT2 antagonist in type 1? Again, same thing. So probably, then how long before the surgery should we stop sulfonylurea, sir?
Sulfonylureas, ideally 2 days before.
2 days.
Ideally.
Yes.
But majority of the books say on the day of surgery, you don't continue. Why ideally 2 days before is, they inhibit this the preconditioning as far as ischemia is concerned. So that the ischemic preconditioning, again, to get back that, the preconditioning, it takes about 48 hours after stopping sulfonylureas for the potassium channels to start working again. That is why majority of the times we say that ideal would be 2 days, but invariably we stop the sulfonylureas on the day of surgery.
So again, Hemang, sir, out of glipizide, glibenclamide, glimepiride, which is the better one? I'm not sure.
The glimepiride is always better.
Glimepiride, okay.
Yeah, glimepiride.
So,
because glibenclamide is relatively longer acting when compared to glimepiride. But only advantage with glibenclamide is it does not have much effect on the cardiac potassium channels. So that's how glibenclamide may not inhibit the preconditioning, ischemic preconditioning much when compared to the other sulfonylureas. And other important thing about glibenclamide is also called as glyburide. So it has been used even in pregnant patients with diabetes, especially gestational diabetes, because it may not cross the placental barrier much, and also may not have much effect on the fetus. Glyburide. That's why it is one of the drugs that has been used in gestational diabetes along with metformin.
Yes, sir. Fantastic. So, Sudeep, again, sir, need info on intraoperative management of that we can discuss tomorrow.
That we will be discussing tomorrow.
Starting insulin surgery, hyperglycemia, post-operative, when to start, when to stop. Yeah. Suppose patient is on Diglide, TEGLUD, it's an injectable insulin. Do we need to give 2/3 of actual dose or
no, that
stop?
we will discuss tomorrow. I'll be talking about these insulins anyway.
Yes, sir.
We are discussing about basal insulins, the rapid acting insulins, everything we are discussing tomorrow.
Done, sir. And Dr. Satish is asking, good evening, sir. How do we calculate biological age in diabetic patients?
Yeah, that is another very important question. You see, I should have asked that. So there are two, commonly talked about the ages, isn't it? One is the chronological age and another is the physiological age or biological age. Chronological age is actually the date of, from the date of birth. What is our age? If I say that today I am 67 years, that is my chronological age. But physiological age or biological age is actually the aging of the tissues based on the aging process.
Yes.
So that is biological age. So in diabetics, the biological age is much higher than the chronological age. They age faster. So that's how, in case of type 1 diabetes, if the type 1 diabetic patients are not very well controlled, they age for 1.75 years for every 1 year of their chronological age.
Oh.
From the time they have been diagnosed.
Okay.
So suppose the patient is having diabetes, it has been diagnosed for the past 20 years. Okay. Now 20 multiplied by 1.75.
Okay.
So that means it will be 34.
Yes, sir.
Roughly. Plus the time when it was diagnosed. Maybe it was diagnosed when he was 10 years. So he will be 44 years instead of his probably 20 years or 25 years. Like 1.75 times. So he'll age compared to chronological age if he is not properly controlled. A well-controlled type 1 diabetic still ages by 1.5 years for every year of chronological year after his diagnosis. Whereas type 2 patients, so if they are not very well controlled, they age by 1.5 years for every year of their chronological age. And if they are very well controlled, the biological age is not much increased. It is just 1.03 years.
Okay.
So this is what is biological.
Yes, sir. So 1.
Yeah, you can remember as in type 1, 1.75 and 1.5. Well controlled, poorly controlled, and well controlled. And in type 2, 1.5 and 1.03.
Okay, fantastic, sir. So last question, sir. So we have to use DPP4 in spite of sulfonylureas in IST patients.
Now, DPP4, one of the problems with DPP4 is it can also produce cardiac failure. It may not produce any other problem for the heart. So many of the patients with cardiac disease, with ischemic heart disease, DPP4 are routinely used. It will not produce any problem. Only in patients who have developed heart failure, you don't use DPP4.
Fantastic.
And SGLT2 inhibitors nowadays, even though the patients are not having cardiac failure, they are given for cardiac failure. SGLT2 inhibitors, because they remove the water, they decrease the preload.
Correct. That is actually the recent advances right now. Yes. Yes, sir. Thank you, sir. And actually, this Zoom is hosted by the Sono site. Dr. Savita is the heading India.
Okay,
so she's kind enough to record the whole session and we will circulate among the students. So thank you once again, Savita, Ms. Savita, and sir, thank you immense. Thank you.
One question, sir.
Yeah, okay. Okay, Lakshmi.
Yes, sir. You told we have to ask history of OSA in a diabetic patient. So question is, even if the patient is having normal BMI, still can they have the higher chances of having OSA related problems if he is diabetic? That can you just elaborate once again?
Yes, that is what I was trying to tell you. Invariably, majority of these patients are obese.
Okay.
So definitely, because they are obese, you will be asking about OSA. So even if they are not obese, you have to take the history of OSA, because if they have diabetic autonomic neuropathy, the vagal influence on the dilatory muscles of the pharynx are affected.
Okay.
And because of that, there can be collapse of the pharyngeal muscles during sleep, and they can have OSA.
Okay.
Because invariably, you will not be asking about OSA if the patient is thin-lipped.
Yes, sir.
So that is why it is very important to take the history of OSA, even in those patients who are thin diabetics with autonomic neuropathy.
Okay, sir. Thank you, sir.
So, sir, we will touch upon difficult airway in diabetes, sir, tomorrow.
Definitely. Prior saying, I wanted to ask about tomorrow.
Yes, sir.
We'll be asking, because that has not been recorded.
Yes, sir.
In the examination. of this particular patient.
So
So
we
we'll
expected to
discuss.
record this in the history, sir?
Not in the history, in the examination, prayer sign.
Prayer, sir. Okay. I
So
mean,
because-
they need to tell this while they're presenting the case.
Yeah, they have to do this prayer
have to
sign.
do
It's a very simple sign. They
Yes,
can do, even if they want, they can do a palm print sign also. And they can grade the difficulty as far as the palm print sign is concerned, how they are graded. We'll discuss about that. I think they can read about it, and then we can definitely discuss tomorrow morning.
Yes, sir.
Sure.
At 10
Tomorrow
o'clock.
again, 10 o'clock, sir.
Okay,
Sir,
okay.
You will fix
Azam.
up your laptop. At least you'll be comfortable in. Thank you, sir. Thank you so much.
Okay. Thank you so much. Thank you, Sonosite also.
Yes,
Thank
sir.
you, sir.
Thank you.
We'll meet
Savita,
tomorrow.
thank you so much, Savita. Thank you.
Okay.
Thank
And
you.
your students are answering very well.
Sir.
Both of them are answering very well.
These
Thank
two
you.
are from these two are from Sion Hospital, sir.
Yeah, that's what Lakshmish was telling me. They have read well. So let us see how they'll answer tomorrow.
Yes,
I
sir.
want them to answer like this only tomorrow.
Yes, sir.
All the best wishes for them for tomorrow examination.
They
Thank
look very stressed, sir. They should smile little. Thank you, sir. Thank you so much.
Okay, okay, Azam. Thank you so much.
Thank you, sir.
Thank you.
Bye, sir.
Bye.
Savita, thank you so much, Savita, once again.
Yeah, my pleasure, sir. My pleasure. Take care, sir. Bye.
Thank you. You can log out.
Yes, sir.
Sir, the voice is okay, sir?
Yeah, yeah. So,
No echo, sir?
yeah, your voice is okay. There's no this.
Okay, sir.
Right. So, welcome back again. Thank you, Gurudat sir, for the second session, spending your precious time. And we do understand that how busy you are, but still, for the sake of students and on one request you have obliged, thank you so very much. And today we'll be discussing about the second session. So, over to you, sir.
Okay. Thank you, Dr. Azam, and thank you, Sonosite also for this opportunity. And we will continue with the previous yesterday's discussion. So we had discussed many things about diabetes, including the definition, the different types of diabetes, and what acute complications the patients can have, and then what chronic complications, and what are that is chronic or delayed complications, and what is the importance of these delayed complications that can produce for the patient and also for us as anesthesiologists. And also we had discussed about the drug therapy, and we were continuing with the drug therapy, oral the hypoglycemics or anti-hyperglycemics, and also non-insulin injectable hypoglycemics we had just discussed yesterday. So now today we'll continue with our discussion. We'll discuss with the insulins. Now with me, Dr. Lakshmish is there, and then Dr. Mukesh is there. Both are the postgraduates, secondary postgraduates in DNB from Mahavir Jain Hospital. So let me ask you questions for the youngsters. So Lakshmish, the question for you, but I'm not able to see you on screen.
Video is on, sir.
Yeah, now I am able to see both of you.
Yes, sir.
All right, Lakshmish, can you just tell me how do you classify these insulins?
Insulin.
Okay, first of all, let me ask you who introduced or invented insulin.
Not
What,
able to
Mukesh?
recall, sir.
Banting and Best.
Okay, sir.
Banting and Best. They got the Nobel Award also for the introducing. So, okay. So, how do you classify insulins? And it is very important for us to know about the classification also for us to manage the patient.
Yes, sir.
Okay.
Insulins are classified as rapidly acting or ultra short acting, then short acting insulins, intermediate acting insulins, and long acting insulins. And among these, in the rapidly acting or ultra short acting category, we have insulin Lispro, insulin Aspart, and insulin Glulicin. And in the short acting insulin, we have regular insulin.
Okay.
And in the intermediate group, we have NPH or isofen insulin and the lente insulin. And in long acting group, we have insulin glargine, insulin detimer, and insulin degludec, sir.
Okay. Is there any other classification as far as their use is concerned? Like I'll give you a clue, like basal insulins. Which are the basal insulins among them? These,
intermediate acting and long acting are basal insulins.
yeah,
sir.
very good. So intermediate acting like NPH, and then the long acting insulins like glargine and then detemar. They are basically are called as a basal insulin. Okay. Then another, insulins are prandial insulins or nutritional insulins. Which are these prandial or nutritional insulins, which are usually taken just before the food is taken?
Ultra short acting or short acting insulins are prandial insulins.
Yeah. Correct. So Lispro, Aspart, and then even regular insulins can be called as nutritional or prandial insulins. And the other is the correctional insulins. Sometimes they may have to take, or for us, especially during anesthesia, especially if there is alteration in the blood glucose levels, subcutaneously also we'll discuss that when we are discussing how we are going to manage these patients' glycemic status intraoperatively. We may have to give some insulins, especially the rapid acting insulins like Aspart, Lispro, and sometimes even the regular insulin.
Yes.
So these are called as what kind of
correctional insulins?
Yeah, correctional insulin. So this is another which is very important for us to know about, because correctional insulins you don't give the basal insulin.
Yes, sir.
In the prandial insulins, for prandial requirement, you don't give basal insulins. Okay, now Mukesh,
Yes.
Can you just tell me about the rapid insulins or rapid acting insulins or ultra short acting insulins? They are not actually insulins; they are insulin analogs.
Yes, sir.
Isn't it? Because they don't have the same amino acid sequence of the human insulin. So there is a modification of these amino acids in these from the human insulin so that we can get these insulin analogs. So can you just tell, because when we talk about these insulins, we should know about their onset of action, the peak effect, and the duration of action, so that we can properly use them, isn't it? For their therapeutic purposes or intraoperatively also, we know how to use them. So can you just tell about the onset, the peak, and the duration of action of rapid acting insulin?
So for
Aspart Lispro.
Yes, sir. For ultra short acting insulin, the onset is 5 to 15 minutes, and peak will
Okay,
be
very good.
1 to 2 hours, and it will
The
last for
peak effect is
1 to 2 hours. Sir.
no. Peak effect is half an hour,
Okay,
30
sir.
minutes.
Yes.
It is rapidly, it peaks also because it has to peak, because it has to be taken just before taking food, isn't it? So like how our insulins are released from the pancreas, that's how it has to, it is almost mimicking how our pancreas releases insulin. So in just 30 minutes to 1 hour, it peaks.
Yes.
Okay, duration of action?
4 to 5 hours. Sir.
It is 2 to 4 hours. It is short acting.
Okay.
Ultra short acting. That's what we started with this thing also, isn't it? 2 to 4 hours. Maximum is 4 hours. Okay. And Lakshmi, what about the regular insulin?
Regular insulins have onset of action in 30 minutes, sir.
30 minutes.
And
these are 5 to 15 minutes. Ultra short acting. Short acting or regular insulins, it takes about 30 minutes to start acting.
Yes, sir.
Okay.
And peak
effect
action will be seen by around 90 minutes, sir.
Yeah, 2 hours, roughly about 2 hours. Okay.
And then they'll last for 3 to 4 hours, sir.
Yes. No, 4 to 6
4
hours.
to 6 hours, sir.
Yeah, or sometimes even 6 to 8 hours.
Yes, sir.
Okay. Now, Mukesh, again, the intermediate acting insulin like NPH. What is the full form of NPH? Mukesh?
Neutral protamine agonist. Neutral protamine
agonist. Okay. So, what is the onset of action, duration, peak effect, and then duration of action?
Onset of action is 1 to 2 hours, sir.
It is 2 to 3 hours onset of action. So it takes more. Okay.
Peak effect is 5 to 6 hours, and duration is 18 to 20 hours.
Yeah, up to 12 to 18 hours. 12 to 18 hours is NPH. And how about Ditimer and Glargine? These are also again insulin analogs.
Yes, sir.
They are
Long
not,
acting ones.
yeah, they are not regular insulins. They are insulin analogs. So Lakshmish, can you just tell about their onset, their peak effect, and their duration of action?
Insulin glargine onset of action is around 1.5 to 2 hours, sir.
2 hours. Okay.
And glargine is one insulin which does not peak, sir. So the effect will be constantly maintained.
Yeah.
And duration of action is more than 24 hours, sir. 24 to 30 hours.
Yeah, around 24 hours.
Yes,
Okay, okay. One more insulin is there, Degludec. Yesterday,
Degludec.
somebody was asking a question about Degludec also. So what about the difference? What is the difference between Degludec and the Glargine as far as the duration of action is concerned?
Degludec lasts for almost 36 hours, sir.
Yeah, 36 to 40 hours.
Yes,
so longest acting insulin is Degludec.
And unlike glargine, Degludec also has a peak action, sir.
Both the Ditimer and Ditimer is the shortest of acting when compared to Glargine and Degludec.
Yes, sir.
It just acts about nearly 18 to 24 hours.
Yes, sir.
Sometimes it may have to be given twice daily, like NPH.
Okay.
Now, Mukesh,
Yes, sir.
why should we know about their onset of action, peak effect, and duration of action? What is the importance of knowing about them?
The risk of hypoglycemia.
Okay.
And to know which one to continue and stop in the previous day of surgery and on the day of surgery, sir.
Correct. That is another very important thing. Just one more thing is for using the correctional insulins.
Okay.
You cannot use basal insulins for correction of intraoperative hyperglycemia.
Okay, sir.
So, and also, you know that we have various regimes of the insulins for type 2 and type 1. Not only, I'm not talking about intraoperative.
Yes, sir.
Once they are admitted or even after their discharge, they may be taking this kind of a particular time they'll be taking, and number of times they may be taking these insulins. Again, depends on the onset, the peak effect, and then the duration. So many times, even once daily long-acting insulins, basal insulins are being taken, especially for type 2 diabetics who require insulin.
Yes, sir.
It will be only once daily, isn't it? So basal insulin, why a basal insulin is required? Do we have a continuous basal insulin in our body also, whether we fast or whether we feast?
Yes, sir.
Yes, sir.
Basal
Because
insulin.
always, continuously the pancreas will be releasing some amount of insulin, and this is required for our metabolic effects.
Yes, sir.
That is why it is also called as metabolic insulin.
Yes, sir.
So basal insulin. So this is very, very important. Suppose in a patient with type 1, why you should know that in these type 1 there is no insulin at all.
Yes, sir.
Even basal insulin is also not secreted. So Lakshmish, why should I know about this particular thing about type 1, where there is no basal insulin also?
In the absence of basal insulin, at any point they can go into hyperglycemic emergency, sir, like diabetic ketoacidosis. So,
okay, so that is the reason they should always be given insulin.
Yes, sir.
Isn't it? They should always have some circulating insulin should be there.
Yes, sir.
Otherwise, they may develop DKAs, rapidly they go in for diabetic ketoacidosis. So that is a very important thing when compared to the, the patients with type 2 diabetes on insulin.
Yes, sir.
They need not require all the time insulin.
Yes,
There
sir.
will be some amount of production of insulin. Okay. So one more thing about these is that only basal insulin once daily they may be on. But if a patient is type 1, so he may be on basal bolus type of regime. Because these regimes, we have to know whether to continue the same regime intraoperatively or postoperatively or preoperatively. What regime of insulin these patients are taking. So basal bolus. Mukesh, what do you mean by basal bolus?
So the minimum requirement of insulin for the patient. Usually the long acting will be given as a basal.
Then bolus. So now it has become very popular. This basal bolus type of insulin regime has become very popular. Though number of injections the patient may have to take are more. So here, once daily or twice daily, the patient will be taking a basal insulin, depending on the duration of action of these basal insulins. If he is taking Determer, he may have to take twice daily. If he is taking Glargine or Degludec, he may have to take only once daily. But just before he takes his regular food, like before breakfast, before lunch, and before dinner, so he has to take this ultra short acting or rapid acting insulin. That is a bolus.
Okay.
So that will almost mimic like the body, how the body secretes insulin.
Yes.
So that's how the basal bolus, because we know that the ultra short acting insulins or insulin analogs will start acting within just about 15-20 minutes.
Yes.
Suppose if he takes about 15 minutes and then it peaks in about half an hour, it peaks. So the patient takes 15 minutes before, and he takes his food. Another 15-20 minutes, the carbohydrate level will peak. So your insulin levels also will peak.
Yes, sir.
And then their duration of action is just 2 to 4 hours. So gradually they come down. And basal insulin is working, isn't it, to prevent any problem of decay. So that's how the patient may have to take 3 to 5 injections per day. So that is one of the regimes that can be used. Or patient may be on intermediate acting insulin twice daily, along with in the same vial, there can be a mixture of both intermediate acting insulin and regular insulin, or intermediate acting insulin and rapid acting insulin, isn't it? So that also, because just before breakfast, if the patient takes this intermediate acting insulin with rapid acting insulin, the rapid acting insulin will immediately start acting for his breakfast. It looks after its breakfast.
Yes, sir.
Because the intermediate acting insulin will peak after about 4 hours. 4 to 6 hours it peaks. So by the time he takes lunch, now it will be peaking. And one more dose he takes just before dinner. So again, same thing. So the whole night, the intermediate acting insulin will be acting like a basal insulin. So that is another regime that can be followed by many of the patients. So here only 2 injections will be there. So this also we will have to inquire whether the patient is on this type, 2 injections, that is intermediate acting insulin with ultra short acting insulin, or whether he is on basal bolus type of insulin regime. Or sometimes patients may be on continuous subcutaneous insulin infusion pumps also, isn't it? Of course, it is not so popular in India because of the cost probably, and the patients have to adjust their insulin levels. There is a continuous bolus, so continuous basal insulin will be given to the patient continuously by the pump. So just before he takes food, he can take an extra dose of insulin through the pump only. So this pump will contain only the rapid acting insulin, either Lispro or Aspart.
Okay, sir.
So the patients can be on these insulin pumps also. So if the patient with insulin pump, if he is there, and how we should manage these patients. Now there are closed loop pumps are also have been introduced in West, wherein the patient need not have to inject the bolus. There is a closed loop because there is a continuous glucose monitoring, CGM is also there. And that CGM continuously will be also associated with this pump. They'll have a connection, between them. And because of the CGM, the pump adjusts its amount of insulin delivery to the patient. So this may be a beautiful, it is like an artificial pancreas, isn't it? So it's also called as an artificial pancreas. So that is another thing which you should always know about, and you don't know, some patients may be on these continuous subcutaneous insulin infusion pumps also. So many regimes can be there. So one of the things you can remember is whatever the regime one has to adopt, we'll have to go with something called as a mnemonic is STEPS, STEPS. So what is this STEPS? S actually stands for the safety. How safe is the particular drug? And T stands for tolerability, whether the patient is able to tolerate that drug or not. E stands for the effectiveness of the drug. And P stands for the price, because it should not be too costly, patient may not be able to afford. And yes, another S stands for simplicity. So just remember about these steps when you want to prescribe, or the patient wants to take, or your friends want to take any particular type of antidiabetic drugs. So STEPS, so safety, so effectiveness, tolerability, price, and the simplicity of the regime. Okay, so these are the different insulins, and we should know about these insulins, and we will later we'll discuss about in detail when we go into the management of these patients, especially the glycemic status, what kind of insulins if they are on, how to manage these insulins pre-operatively, intraoperatively, and post-operatively. Okay, now these are the things about the medication the patients will be taking. Lakshmi, in your particular case, this patient, after getting admitted, he must have been put on some other medication because his blood sugars are 320.
Yes, sir.
That 320 blood sugars was when he got admitted or subsequently?
It was when he got admitted, sir. Random.
Okay. Now, has he been put on a particular type of insulin regime in the hospital?
As per the sliding scale, sir, they were giving, sir.
No, that means he is being given insulin now.
Yes, sir.
Okay. How many times he is being given insulin?
3 times a day, sir.
Yeah, 3 times a day. Must be regular insulin is being given.
Yes, sir.
So you have to know the total dose of insulin also that the patient is being given. Okay. That is again very important. Why total dose per day requirement is important for us?
It will help us to manage the correctional dose of insulin if at all required during the perioperative period, sir.
Yes, very good. So you'll have to know, what is his insulin sensitivity factor. So in order to calculate the insulin sensitivity factor, you have to know the total amount of insulin the patient requires to maintain his glycemic status. We'll come to that when we discuss about the anesthesia part. Okay, so the other medications the patient may also be on, like especially ischemic heart disease is very common. So yesterday we were discussing, so he may be on many of the drugs for his ischemic heart disease. He may also be on antihypertensives, because invariably, because of the peripheral vascular disease, patient will be hypertensive. So, or if he has the long duration of history is there, if he has developed nephropathy, again that can be a cause for his hypertension. So he can be on antihypertensives also, isn't it? So these are some of the medications the patient can be on. So you have to know about the importance and their interaction, whether to continue them on the day of surgery, or if we continue, what are the interactions with our anesthetic drugs. So we'll have to know about. One of the most common antihypertensives these patients can be on is AC inhibitors. So if the patient is on AC inhibitors, should we know about this, Mukesh?
Yes, sir.
Now, how it is important for us? Any extra investigation you have to do if the patient is on AC inhibitor?
Electrolytes should be done.
Yes, very good. Which electrolyte?
Potassium.
Yeah, why potassium? If the patient is on ARBs or AC inhibitors?
There will be risk of hyperkalemia in this patient.
Very good. Why hyperkalemia? Why with ARBs and AC inhibitors, hyperkalemia can be a problem? Lakshmi, can you?
In the presence of AC inhibitors or ARBs, there is impaired aldosterone mediated reabsorption of sodium and water. So potassium excretion will be hampered. So patients will have hyperkalemia.
Yeah, very good. So because AC inhibitors and ARBs, they stimulate this angiotensin 2 receptors, and thereby they release aldosterone. And aldosterone, it has got a mineralocorticoid, basically mineralocorticoid activity. So retains sodium and excretes potassium. So once you have this, the angiotensin 2 being inhibited, so then aldosterone secretion will be hampered. So there will be more retention of potassium and excretion of sodium. So hyperkalemia. So it is very important that we should check for potassium levels in these patients when they are on AC inhibitors or ARBs. The other thing is whether to continue the drug or to stop the drug on the day of surgery. There are a lot of controversies are there. There are no definite guidelines. So majority of the anesthesiologists know the word stop on the day of surgery. They, especially both these AC inhibitors and ARBs, because it has been found that they may produce vasoplegia and also can interact with our anesthetic drugs. They can produce refractory hypotension. And that is the reason volume status becomes very important before continuing these drugs. You may have to even preload with at least about 500 ml of the balanced salt solution before you undertake any anesthetic management for these patients if they are on AC inhibitors or ARBs and if you want to continue. And only drug which can help for refractory hypotension of AC inhibitors and ARBs is vasopressin. Other conventional vasopressors may not be effective because the vasoplegia that they produce. So these are some of the medications and their importance for us is very important. Okay, now let us go into some of the examination things. Yesterday we were discussing about one of the things which you have forgotten. Of course, already I told about spine examination you should have done, and also the blood pressure examination, both in lying down and then the standing position. So these two, and then temperature recording. So one of the things is many of these patients, especially long-standing diabetics, can have hero-arthropathy.
Yes, sir.
Or stiff joint syndrome. So if they have stiff joint syndrome, we may have a difficult airway also with them. So how do you know whether the stiff joint syndrome, whether they have or not?
By doing a prayer test, sir.
Yes, okay. What is this prayer test and how you perform?
Here the patient is asked to approximate both the palmar spaces along with the fingers, sir, like how we normally perform prayer. And
okay.
If he is unable to approximate the phalanges and the palms, it is a sign that he may have chiroarthropathy, sir.
Mainly the interphalangeal joints.
Interphalangeal joints,
Yeah,
sir.
because the tips he may approximate, but interphalangeal joints he may not be able to approximate. Why
Yes,
why this particular prayer sign is used? Why for fingers? Why not for other joints?
Because with stiff joint syndrome or hero-arthropathy, most commonly affected joints are the interphalangeal joints. Okay, sir.
They are the most commonly affected. Afterwards, the other joints get affected.
Okay.
That's how the introduction of this prayer sign. So, Mukesh, can we quantify this prayer sign by doing some other sign?
Palm print test we can.
Yeah, palm print sign or palm print test you can do, isn't it? So you apply ink to the whole of the palm and ask the patient to press it on a white paper, and you just check what is the imprint of the phalanges, especially the interphalangeal joints. So how do you quantify what is grade 0? It is grade 0 to grade 3.
Yes.
What is grade 0, Mukesh?
Sir, all the digital print will be visible in the grades. So,
yeah, all the interphalangeal joints and the phalanx are visible on the print. Okay. What is grade 1?
Grade 1, sir, 5th to 3rd interdigital will be visible.
Yeah, maybe only the 5th also may be involved. That means the interphalangeal joint of the 5th digit may not be seen, or sometimes even the 4th digit also may not be seen. That is grade 1. What is grade 2?
Grade
from 2nd to 5th digit.
Yeah, 2nd to 5th digit. If the interphalangeal joints are not seen, the prints, so then you call it as grade 2. And grade 3 is
only tip of the fingers are visible.
Tip of the digits are seen, and no interphalangeal joint imprint will be seen on the paper. Yes. So that is grade 3. And grade 3 is more severe. That's why you can quantify the palm print sign and then the prayer sign. So Mukesh, why should you know about this? Does it have any effect on the other joints which are important for us?
There could be a stiffness of the atlantoaxial joints.
Okay.
There will be restricted neck extension, so can anticipate difficult intubation.
That is one of the joints. Okay, any other joints?
Cervical spine.
No, that you said. Temporomandibular joint also.
Yes,
The
mouth opening
temporomandibular
can
joint
be
also can get involved. So mouth opening may get restricted. So another joint that can get affected is cricoarytenoid joint.
okay, sir.
So if this cricoarytenoid joint is also involved with stiff joint syndrome, so the problem is the abduction of the vocal cords will not be effective.
Okay, sir.
So then what will happen is if you are taking a particular size tube, for example, for male patients 8.5, female patients 7.5 or 8, so you may damage the vocal cords. That is why you have to be very careful. What is the size of the tube you have to select when a patient has probably grade 3 palm print sign positive. Okay, so because the cricoarytenoid joint also make it involved. Okay, that's about another test which you should have performed. And okay, now we'll go into the investigations part. So what all the investigations are required for these diabetic patients? Lakshmish, and then you know one thing you should always realize,
Yes,
whenever we want to do any investigations, every investigation should be an indicated investigation.
yes, sir.
There is no unwanted, unnecessary investigation should not be done, and they'll have their own consequences. So
Yes,
what
sir.
are the indicated investigations that are done for these patients?
First is random blood sugar. Or
So straight away, why do you don't want to do, because this patient has got a wound, and we know that these diabetic patients are highly prone for infections,
yes, sir.
isn't it? They're immunosuppressed. Their wound healing also gets delayed,
Delayed.
isn't it? Mukesh, why the wound healing gets delayed in these patients? What are the reasons?
So because of hyperglycemia induced immune suppression.
Now, what are the different reasons that have been given for chronicity of any ulcers?
So the hyperglycemia, if presents, acts as a culture media for some of the bacteria. So infection may not come down. So that is one of the reasons for delayed wound healing. And atherosclerotic changes due to complications will reduce the blood supply also. So in the absence of good blood supply, wound healing will be hampered, sir.
Okay. Anything else? Actually, the chemotaxis is affected.
Yes.
Because anywhere, any wound or any infection that occurs, immediately there will be rush of these WBCs, isn't it? So that is what is called as chemotaxis. So that will get inhibited. So enough number of WBCs or white blood cells may not reach the infected area. That is one. The second thing is, there can be suppression of the effectiveness of the phagocytes.
Okay.
So they may not be functioning properly to take care of this infection. The most important thing is the problem in the formation of collagen.
Yes, sir.
Because of the glycosylation that will be non-enzymatic glycosylation that will be occurring, there will be problem with the proper collagen formation. So because main thing they say that the collagen formation is very important because the superficial wounds will heal rapidly.
Yes, sir.
Whereas the deep wounds, especially which also involves the deeper layer of the epidermis and dermis, where collagen formation is very important for healing. So that gets involved. So that's how they'll have a chronicity of the ulcers. So because of all these, there is a routine immunosuppression in these patients. So that is the reason a complete blood count becomes very important. And again, the hemoglobin is also important for us to know, because invariably if they have nephropathy, what will happen to their hemoglobin?
Reduce, sir.
Yeah, hemoglobin anemia is very common in patients with chronic nephropathy,
Yes.
isn't it? Because again, erythropoietin is not secreted, so hemoglobin is a problem. So anemia. So your patient also has got this anemic. He's got about 8.4 or 8.5 grams of hemoglobin. So Mukesh, why do you want to know about hemoglobin? Because I said every test should be an indicated test. What is the importance of knowing about hemoglobin? There are two indications for there are anesthesia purposes.
So one thing, sometimes the wound debridement associated with the blood loss, and second, for anesthesia.
So this patient may also go for even amputation.
Yes.
Or these patients may be posted for complex surgeries where there can be quite a bit of blood loss. So maximum allowable blood loss you have to calculate, and knowing that a particular surgery, the amount of blood loss will be a certain amount of blood loss will be occurring, so that whether this amount of hemoglobin is sufficient enough to meet that amount of blood loss. That is what is called as a maximum allowable blood loss. If that is not meeting, then you have to arrange for extra amount of the blood.
Yes, sir.
Listen, you may have to give transfusion intraoperatively or postoperatively. That is one thing. Second thing is, hemoglobin is the most important component of the oxygen content.
Yes.
So in order to know what is the oxygen carrying capacity of the patient, we require to know about the hemoglobin estimation. These two, during examination, you have to tell about this.
Yes.
One is oxygen carrying capacity or oxygen content. Second thing is to calculate the maximal allowable blood loss. Again, the total count is very important here to know whether the patient is having the infection, how much of infection, whether he is even going in for sepsis. So that becomes again crucial. Okay, then urine is the next thing, isn't it? After a complete blood count, including platelets. So next will be the urine examination. So here you have done the urine examination in this patient and you have found ketone bodies. That is the most important thing. First thing is the proteins, isn't it? So
Yes,
Mukesh,
sir.
why proteins are important in urine to know?
Usually in long-standing diabetes, they might having a diabetic nephropathy. They will be present microalbuminuria.
Yes, very good. So when do you say microalbumin?
When is the when the protein exceed more than 300, 30 milligram per day.
Yeah, 30 milligrams. When the excretion of albumin is more than 30 milligrams per day, then you call it as microalbuminuria, isn't it? And later, Frank, lot of albumin excretion through the urine can occur once he goes for frank nephropathy,
Yes.
isn't it? So it entirely depends on the duration of diabetes, whether it is properly controlled or not properly controlled. Usually this microalbuminuria starts after about 5 to 8 years. And by 15 years, the patient will have, frank lot of albumin excretion will be occurring. Already his creatinine will be going up and his GFR will be going down. So he may, about 15 to 20 years, so he may require, either a transplant or renal replacement therapies. So that's how duration of diabetes becomes very important to know about nephropathy. So again, albumin becomes very important to check in the urine. So the other things very important for us is the ketone bodies. So Lakshmish, what test is done to check for ketone bodies, which is commonly asked in the exam, though we are not performing this test?
For the
Normally, how these sticks are used, isn't it?
Yes, sir.
These sticks use what kind of a test?
Nitroprusside solution.
Yes. Yes, very good. So they use nitroprusside test. So in olden times, what test we were using when we were not having these sticks? Heard about Rothera's test?
Yes, sir.
How this Rothera's test is performed? See, you are not doing this, but for exam purpose, you should know about Rothera's test. Invariably, it will be asked. What is Rothera's test? How it is performed? Just for all the, many students might have been logged in. We'll just, I'll tell you. You have to take 5 ml of urine, warm the 5 ml of urine, and this urine should be supersaturated with ammonium sulfate crystals. How do we supersaturate? Is you keep on putting these crystals into the urine and keep shaking the test tube. So they'll be dissolving. After some time, there'll be residue of ammonium sulfate crystals will be there at the bottom. That means now the urine is supersaturated. Now to this, you have to add liquor ammonia from the sides and then sodium nitroprusside from the sides. A pink ring that is coming at the junction of these will indicate that the patient has ketone bodies. So this is Rothera's test. Okay, now we use these sticks for the sodium nitroprusside test for using these sticks. So again, you can have 1+, 2+, 3+ based on the color, the chain. So, 3+ means maximum amount of ketone bodies. Very severe ketosis is there. So in your patient, I think it is 2+ or 3+.
2+.
2+. So Mukesh, what are these ketone bodies?
Sir, ketone bodies are the metabolite of fatty acid, lipid metabolism, some byproduct of
Lipolysis.
Lipolysis.
Okay.
They are acetone, acetate, and beta hydroxybutyrate. Sir.
Okay, which one is formed first?
Beta hydroxybutyrate, sir.
No, it is always the acetoacetic acid or acetoacetate. It is the main important acid, that is keto acid, acetoacetic acid. That's why we call it. So it gets converted to ketones, acetone, and also beta hydroxybutyric acid. So with these, you can, but beta hydroxybutyric acid cannot be tested with nitroprusside.
Yes, sir.
What you are testing in the urine is either acetone or acetoacetic acid. So we'll go into details about these ketones and diabetic ketoacidosis later when we check for the complications of the acute complications of diabetes, because whenever a patient is posted for an emergency surgery and you are asked in theory or in practicals, a clinical scenario is created, you have to talk about diabetic ketoacidosis and how to manage and what are its importance. We'll discuss that later. Okay, now what are the other investigations, Mukesh, you would like to perform in this patient? Now urine is over. Other tests.
Sir, electrolytes.
Okay, serum electrolytes, especially if the patient is on SGLT2 inhibitors, because more amount of the water he'll be losing. Along with that, he may be losing electrolytes also. And already we discussed if the patient is on AC inhibitors. And many of these patients may also be on diuretics for their cardiac conditions, isn't it? So they may have even diastolic dysfunction is very common, and even systolic dysfunction is also common. Both can occur in these patients. They may have a left ventricular failure, for which usually you want to decrease the preload. So best drugs for decreasing the preload is diuretics. So the patient may be on diuretics, either thiazide diuretics or loop diuretics. And thiazide diuretics themselves, they may produce hyperglycemia. That is also the drug interaction you should always be remembering. So if the patient is on these diuretics, then you may have to, ideally, you have to get the electrolytes done. Okay. The other, because I told you that these patients will have ischemic heart disease, 100% of the diabetics will have ischemic heart disease. So what important investigation you have to do?
Electrocardiograms.
ECG. Okay. So electrocardiography. So what the important things you would look for in the ECG of these diabetic patients to know whether the patient has got ischemia or ischemic heart disease?
T-wave inversion, QT prolongation.
Yeah, ST wave changes, and then the QS complexes, isn't it? In particular leads, like whether they are there in 2-3 AVF, that is inferior wall. If they are there in lead 1 AVL and V5, V6, that's a lateral wall. If it is they are there from V1 to V6, it is the anterior.
Yes, sir.
Which artery? Again, anterior wall is left anterior descending artery, and lateral wall is circumflex. Then inferior wall 2-3 AVF, right coronary. So by just looking at the ECG, you may know whether the patient has the ischemia first of all, or whether he has already had an infarction. Suppose he has the QS complexes are there, Q waves are there, significant Q waves, then you know that the patient already has an infarction. So you have to be extra careful in managing these patients. And you have to take the history also when the patient has had the infarction. So when do you call it as a recent infarction and acute infarction, Lakshmish?
Acute infarction in past 1 month, sir.
No, acute is 7 days.
7 days. Okay.
Recent is 28 days.
Okay, sir.
Because why we should know is we should postpone all elective surgeries at least for 28 days.
Yes, sir.
Ideal would be 6 months. Ideal would be 3 to 6 months. But there are some time sensitive surgeries where you cannot postpone for long, like malignancy surgeries. So minimum duration of postponement can be about 28 days for such surgeries. Okay, so ECG is important. So echocardiography.
Yes, sir.
If any changes in the ECG is there, then we will ask for echocardiography, sir.
Even otherwise also. Now
Okay.
echocardiography, a non-invasive test, definitely is usually done for all these diabetic patients. So because definitely you can know whether there is any regional wall motion abnormalities are there. And other very important thing here is the diastolic dysfunction. These patients are highly prone to develop because they'll have hypertension. So because of back pressure effects, the afterload is increased. So that is why they may have the left ventricular hypertrophy. Compliance of the ventricle is reduced. So because of that diastolic dysfunction, now many of these patients can have diastolic failure with preserved systolic function. That is a new term that has been coined for left ventricular functions, left ventricular failures. Isn't so? An echocardiography is a must, and they are also prone for dysrhythmias, especially the older people. They may have an atrial fibrillation is another common dysrhythmia they can have. So they can even have a left atrial clot. So in order to rule out, or even a left ventricular clot if they are in failure. So becomes very important for us before taking them up for any kind of surgery. Okay, you have done all these investigations. Now, what are our goals for, in general, for diabetic patients? Mukesh, can you just answer?
So we have to maintain the tight blood sugar in this.
No, what is first a very important goal? What can kill the patient? Or can
hypoglycemia can kill
hypoglycemia, isn't it? It's very dangerous. Even if the patient is hyperglycemic, it may not be any problem, and we allow them some amount of hyperglycemia also.
Yes, sir.
So hypoglycemia is a killer. So we have to avoid hypoglycemia.
Yes.
Your first goal is to avoid hypoglycemia. Okay, Lakshmi, what is your second goal?
Avoid hyperglycemia also to the maximum extent and avoid ketosis, sir.
No, what is this avoiding hyperglycemia? Is there any avoid hypoglycemia? Yes. We don't want the blood sugars nowadays. We don't want the blood sugars to drop down below 110.
Yes, sir.
Now that's how we are so careful about the prevention of hypoglycemia. But what about hyperglycemia? Is there something called as a permissive hyperglycemia?
Blood sugar more than 200 is usually avoided, sir.
About 180.
180.
Is it? So that is called as a permissive hyper. That's how we always say avoid excessive hyperglycemia.
Okay, sir.
Avoid excessive hyper. So first goal is avoid hypoglycemia. Second goal is avoid excessive hyperglycemia. What is the third goal? You said already.
Avoid ketosis.
Avoid ketosis,
yes,
isn't it? So why you say avoid ketosis? And who are prone for ketosis? Which patients?
Type 1 patients are more prone for ketosis.
Type 1 patients are more prone for ketosis. So how we can prevent ketosis in them?
By preventing the further stress response from any kind of
insulin.
Also,
no, by continuing insulin.
Okay, sir.
By giving them insulin 1 and not allowing them to starve without glucose. So you have to give them glucose. You know, if they are made to starve, they go for neoglucogenesis and glycogenolysis.
Yes, sir.
And neoglucogenesis is the one, the lipolysis, which can produce free fatty acids and ketone bodies and ketosis. The other thing is, if they don't have insulin, again, they go for the neoglucogenesis, isn't it? Now, for that, you have to know what is the function of the insulin. So, can you classify the functions of insulin, Lakshmi? How they are classified, the functions of the insulin in brief? I'll give you a clue. They are classified as anabolic functions, anti-catabolic functions, because insulin is the only anabolic hormone in the body.
Okay.
Only anabolic hormone. So it has got anabolic functions and anti-catabolic functions. So what are these anabolic functions and what are these anti-catabolic functions?
Anabolic functions are it stimulates the glycogenesis, where the breakdown of
So you can say carbohydrate metabolism,
metabolism.
fat metabolism, and protein synthesis. All these, isn't it? So formation of amino acids, even that is also very important. Then the formation of lipids also is again an anabolic effect of the insulin. So what is this anti-catabolic effect? What do you mean by catabolism? Breaking down, isn't it?
Yes, sir.
Lipolysis and proteolysis.
Yeah. So anti-catabolic effect is prevention of breaking down of proteins and lipids. And this is a very, very important function of the insulin. And the amount of insulin that is required for anti-catabolic effect is minute, very small amount. Whereas for anabolic function, the amount of insulin required is quite a bit. It is higher amount is required. So even a small amount of basal insulin, as long as it is there in the circulation, it is going to prevent the lipolysis, that is anti-catabolic effect it will have. Catabolism it can prevent.
Yes.
That's how the lipolysis can be prevented. Once the lipolysis is prevented, ketosis is prevented, isn't it? So for that, it's very important to know this anti-catabolic actions of insulin. Okay, that's how, by giving them insulin and also giving them glucose continuously, you are going to prevent ketosis in these patients. Very important. Otherwise, they can develop DKA intraoperatively and postoperatively and will have a real problem. Even preoperative, because we are starving them. All the patients are starved, isn't it? At least 6 to 8 hours starvation for nil per oral status is always given. And in these patients, you have to be extra careful because they have a gastroparesis also. They have diabetic autonomic neuropathy.
Yeah.
Okay. Now, that is another important goal. Okay. What is the next goal? Maintenance of fluid and electrolyte balance.
Yes.
Because they are highly prone for the imbalance of fluids and electrolytes. Because if they develop hyperglycemia, the glucose will be going across the urine and along with electrolytes, along with that fluids. So you have to continuously monitor and maintain the fluid status and electrolyte status throughout the perioperative period, isn't it? So that is another very important goal. Okay, what is the next goal?
Avoid
Okay,
prolonged
Mikesh, any
fasting.
other goals?
Fasting hours should not be.
No, that already we said about ketosis. You are giving intravenous glucose for that.
And as far as possible, try to maintain the insulin or other OH regimen which patient is already taking, sir, in the perioperative period.
Okay, that may not be as such a goal.
Okay, sir.
Comes with our regimes, different regimes. Another very important goal is, these patients will have peripheral arterial disease. They also have peripheral neuropathy. Symmetrical peripheral neuropathy is very, very common. Glove and stocking type of peripheral neuropathy is very, very common. So because of this, they are very much prone for neurovascular injuries.
Yes, sir.
So you have to protect the areas, the pressure areas. And especially under anesthesia, they may not know at all.
Yes, sir.
And the circulation is affected already, because of the macroangiopathy, the peripheral vascular disease is there. Plus, they are already having neuropathies, already neurological damages already occurred. So we may produce further neurological damage. So it is very important to see that the pressure points are protected. Okay. So these are some of the goals you have to keep it in your mind. Okay. With these goals, now how do we prepare these patients before taking up for surgery? Any kind of surgery. There's maybe a major surgery or a minor surgery.
We will do the detailed pre-anesthetic evaluation, sir.
Okay. No preparation now. Already you have done the this thing also evaluation, which includes the investigation also. So now is the preparation,
We will
which is done
advise-
pre-operatively.
We will advise them regarding the nil by mouth status.
Okay,
Uh,
that is the same for these patients also. 6 hours and 2 hours. 6 hours for solids and 2 hours for clear fluids.
In presence of gastroparesis can be NPO can be prolonged.
No. Even in diabetic patients, the whatever the NPO status regime is not, we are not going to change. Same 6 hours for solids and 2 hours for clear fluids. That is NPO status. Now, other main important thing in the preparation is, suppose I told you that these patients may have the comorbid the delayed complications,
yes, sir.
especially the cardiovascular complications. You have to optimize their cardiac status before taking up for surgery. He may have diastolic dysfunction, systolic dysfunction, he may be in failure, isn't it? Or he may have dysrhythmias, he may not be on any drug therapy. So all these things have to be kept in mind in optimizing their cardiovascular status. Second thing is, they may have the problems with their kidneys,
Yes, sir.
isn't it? So many of these patients may have nephropathy, even end-stage kidney disease. So you have to optimize the kidney functioning also, and then the fluid and electrolytes also will have to go with, isn't it?
Yes, sir.
So that is what is, and then their preoperative glycemic status. Suppose the patient is like your patient, who has been admitted with 300 milligrams of blood sugars. Now, unless you optimize his preoperative glycemic status, so it will become very difficult. Suppose, now, is there many of the trials that have been done regarding preoperative hyperglycemia, any effect on the patient's the prognosis as far as the surgeries are concerned? Preoperative hyperglycemia. I'm not talking about intraoperative.
When the preoperative blood sugars are like more than 200, sir, in the perioperative outcomes are sometimes bad, sir, regarding recovery from the anesthesia and regarding the wound healing is concerned.
Yeah, one thing again, you started with that investigation, so we did not specific into the investigations only, we forgot. So you have to do a fasting blood sugar,
yes, sir.
postprandial blood sugar, and also HbA1c.
Yes, sir.
So anything to do with HbA1c?
HbA1c will tell the glycemic status in the past 3 months, sir, and
Okay.
how the sugar is controlled.
Okay, now let us say that ideal HbA1c should be what for well-controlled diabetic status?
4 to 6%.
No. Well-controlled diabetics. I'm talking about diabetics, not in normal persons. Normal persons up to 5.6 is normal.
Less than 8.5.
Less than 8.5. Usually, when you have to optimize their glycemic status, it should be ideally between 6 and 7. Ideally 6.5 to 7. Now, elderly patients 7 to 8. So that we have to err on the hyperglycemia only, not towards the hypoglycemia. So that's why ideal would be. So suppose if a patient's HbA1c is 10, should I postpone the elective surgery or should I accept him for surgery? He is totally not very well controlled. Anything above 8.5 or 9, so is not properly controlled at all. HbA1c 10 or 12 or 11. Should I accept him or should I postpone? Any guidelines are there? ADA guidelines or Australian guidelines or British and Ireland Diabetic Association guidelines.
Nice guidelines.
Okay.
According to NICE guidelines, sir, if up to 8.5 HbA1c, we can take up for the surgery. In case more than 8.5, if the infection is the reason for the hyperglycemia, we can go ahead with.
No. 3 months. This is 3 months. So this thing, it cannot be just 1 or 2 days. Over 3 months, his blood sugars are very high. That is why the HbA1c is very high. Now, only Australian guideline says that if the HbA1c is more than 8, postpone surgery.
Okay, sir.
Even ADA guidelines do not say anything. So other guidelines also have not commented much on this HbA1c. So again, practically also you'll have to think about. If HbA1c is high and then we are going to postpone the surgery, for how long? You'll have to postpone at least for 3 months. You cannot accept within 3 months because it takes another 3 months for the HbA1c to change.
Yes, sir.
And they have done this in one of the trials. They did this and they found out only 20% of the patients HbA1c came down.
Okay.
Other 80% of the patients HbA1c did not come down. So that's how, in the exam, if you are asked, you can still say that, of course, if HbA1c has been found to be more than 8, definitely the patient's outcome after the surgery can be, not a proper one. It can, the patient can have, the wound healing may not occur properly. So the patient may require prolonged hospitalization also. And also even he may require, there are incidences where in HbA1c is high and they have taken up for surgery. Patients required even ICU management in the post-operative period. So all these risks are always there. So we'll have to think about the risks and benefits also. The risks of taking up the patient with a high HbA1c, postponing the surgery, the risks of postponing the surgery, the patient is not prepared for postponement. Surgeons will not be ready for postponement. Even the patient's attendants, everybody would have come. People have applied leave. It's so difficult to get leave and they would have somehow got the leave and then they would have come. So there are a lot of implications in postponing surgery. That's how, even if the HbA1c is more, you can always discuss with the surgeon and then the patient. And if they agree, you can take up for surgery. Another very important thing is the preoperative or intraoperative or peroperative, on the day of surgery, the glucose you have estimated, and till what level of glucose you can accept the patient, Lakshmesh?
Till
on the day of surgery.
180 to 200.
So that means suppose the patient's blood sugars are more than 200, you want to postpone?
We will give correctional dose of subcutaneous insulin.
No, but are you postponing or you are not postponing?
No.
In your institution anyway, because you are working there. In the previous institutions also where you have worked. You postpone?
No.
If there is no other signs of ketosis or acidosis is not there, you will take up.
Now it is said that even up to 350, people do not want to postpone the surgery, and only postponement is if the patient also has the complications of this hyperglycemia, and especially either HHS or DKA. If the patient doesn't have any signs or symptoms, and even your the lab investigations have also proved that the patient doesn't have HHS or DKA, definitely you can consider the patient for surgery. So you don't postpone. That is what is the many of the articles are also there that you need not have to postpone till 350 now.
Yes, sir.
But don't tell this to surgeons. They'll start demanding.
Okay.
So anyway, so most important thing is it is not the hyperglycemia itself is not the problem. It is the complications of acute hyperglycemia. That is more important for us. Okay. Now that is what, as a preparation, you have to optimize the glucose status. At least you may not be able to optimize the HbA1c, but definitely you will be able to optimize the whatever the glucose, blood glucose of these patients, isn't it? So next is, once you have optimized the patient, now you have prepared the patient, now you are going to accept the patient. Now for accepting the already, whatever the conditions already we have discussed for accepting, if the patient meets this, you are going to accept the patient. And now what kind of anesthetic technique would be ideal? Whether a regional anesthesia technique would be ideal or general anesthesia technique would be ideal in these patients. Okay, Mukesh.
Sir, Whenever possible, regional anesthesia is preferred in absence of
Okay, so
autonomy.
regional anesthesia is preferred. Okay, very good. So why do you want to go for regional anesthesia?
Because
What are the
regional-
advantages of regional anesthesia? There must be some problem with your net. I think the video is stopped.
Yeah, sir, I think they have got disconnected, but other phone is on. I will.
Okay.
I
They
will.
can, yeah.
I'll just unmute him, sir. Lakshmish, can you hear? I'll just unmute you. The other phone. Lakshmish. Are you able to unmute Lakshmish or? Yeah, I will.
Sir, you have
Okay,
to make
you can.
another mobile host, sir.
Yeah, you can unmute.
Okay.
It's not coming. Yeah.
Okay.
Can you
Can
see us?
you- Yeah, we are able to hear you. No problem, Lakshmish and Mukesh. Mukesh, I was asking you about the benefits of regional anesthesia over
under-
general anesthesia.
Under regional anesthesia, the surgical stress will be less, so there will
Okay.
be decrease of stress hormones, so risk of hyperglycemia will be less when compared to regional, sir. And also it gives post-operative analgesia and helps in
Very good.
early mobilization and lesser
Very good.
recovery times.
Early mobilization is very important because these patients are highly prone for DVT because they will have a procoagulant status all the time. They have a procoagulant and pro-inflammatory status, and pro-inflammatory, especially the pro-inflammatory cytokine like interleukin 6 and then TNF alpha are released quite a bit intraoperatively, and these can make them to develop coagulation also and DVT also. So early ambulation is again an important thing about the regional anesthesia. Again, post-op analgesia is one more thing. The stress response is very minimal. The other very important thing is they can take their regular diet early. That is very, very important for these diabetic patients. If they can take their regular diet early, so, we can go back to whatever the regime of the... You're able to hear? Lakshmish?
1 second, sir.
Okay.
I think their net connection is suddenly dropped out. Just
That's
one.
what you had already cautioned in the beginning only.
Yes, sir.
Okay, connection.
Yeah. There's a lot of
Hello, sir?
disturbance.
Okay.
Why your laptop is not working, Lakshmi?
The Zoom is not.
In laptop connection.
Progress.
Sorry? Okay, you come back. You can unmute yourself on the laptop. Oh.
Can you hear us, sir?
Yeah. Now it's okay. So most important thing is the early resumption of their regular diet. That is one of the most important things because you can switch back to their whatever the anti-hyperglycemic regime they are there, which they have been used to, and in the hospital also, isn't it? So that's how regional anesthesia definitely is better than general anesthesia. If possible, regional anesthesia definitely you can select as the anesthesia of choice. The other thing what you should also consider is the type of surgeries.
Yes, sir.
So usually we classify the type of surgeries into two here as minor surgeries and then the major surgeries are complex surgeries. So what is a minor surgery in a diabetic patient?
A minor surgery is one, sir, where the patient is expected to resume his normal diet, or where he is asked to skip only one meal of the day, sir.
Yes, and also the duration of surgery, not more than 2 hours. Not more than 2 hours surgery.
Yes, sir.
And intraoperatively, you don't expect much of
Much
blood loss
hemodynamic fluid
or
imbalance.
hemodynamic disturbance, or even the fluid shifts. That is what is a
Yes, sir.
minor procedures or minor surgery. A major surgery is the one where the patient may require intravenous fluids for more than 24 hours, and where the monitoring becomes very, very crucial. And the other thing is where the surgery is so complex and it produces quite a bit of fluid shifts and also a lot of blood loss. So that's how your regimes, insulin regimes, or intraoperative whatever the glycemic regimes depends on whether the patient is posted for a minor surgery or a major surgery. Now again, we have different kinds of patients here. One group of patients are type 2 diabetics only on diet and exercise. Another group of type 2 diabetics only on the the oral or injectable non-insulin anti-hyperglycemic agents. And the third group is type 1 diabetics. And the fourth group is type 2 diabetics on insulin. So these four groups of patients are there for us, isn't it? So our regimes also will be different for each group of patients. Okay, suppose a patient with he is only on diet and exercise, a diabetic patient, and he is posted for a minor surgery. So what is the regime we can, or first of all, what is the goals for the intraoperative glycemic status? Because usually you have a tight control regime and a non-tight control regime. That's what Mukesh was trying to tell before. So what is tight control and what is non-tight control? Mukesh, what is tight control?
Glucose level will be maintained between 70 to 110 milligram per
80 to 110, not 70. 70 will be hypoglycemia. So 80 to 110 is a strictly, if you can maintain the blood sugars, that is tight control regime. And non-tight control regime?
Sugar level up to 180 milligram per deciliter.
110 to 180.
110 to 180.
110 to 180. Some people also nowadays, they want 140 to 180.
Okay.
So that is what is, we are not very tight with these non-tight control regimes, 110 to 180. So what are the problems with tight control regime?
Hypoglycemic risk.
Yeah, because many of these patients may go in for it. It's very difficult to, it's like walking on a tightrope, just keeping the blood sugars just between 80 to 110. There's hardly margin of safety is very, very low. The intraoperative, post-operative hypoglycemia is very common. And, that is the one thing which we wanted to prevent also, isn't it? So that is what, tight control regime started with Vandenberg's initial in 2001. The Vandenberg and colleagues, they conducted these studies, especially in the ICU for post-surgical patients. So their results was when the blood sugars were kept very tightly between 80 to 110, the outcome was very good. Especially the number of days in the hospital, number of days on mechanical ventilation, everything was less. Again, the same thing was the same group again repeated in 2006, 2003 and 2006. 2003 they did for ICU patients, non-surgical ICU patients. Again, they found out the outcome was much better. Again, they did in 2006. The outcome, they found it to be much better. But later, many of the studies, Gandhi et al. And many of the people who studied, they found out that many of these patients had severe hypoglycemia and even mortality was high. So because of these, now the tight control regime is not usually now undertaken. Now we always go for non-tight control regime.
Yes, sir.
So in the tight control regime, in the older books, if you see, tight control regime is also there. I'll also tell you how the tight control regime was being done, or you can also discuss with me. Nowadays, what we have, our goal is to maintain the blood sugars between 110 to 180. And we don't want it to be less than 110, and we don't want it to be more than 180. Okay, so these are our non-tight control regimes. In this non-tight control regimes, what are the different non-tight control regimes you know of? Non-tight control regimes. Okay, Lakshmi.
Like insulin regimen, sir.
Yeah. Non-tight control is always insulin
Yes.
only intraoperatively. That is the best thing we can manage the blood glucose levels. Non-tight control regimes.
Sliding
The
scale.
older one. GIK regime you must have
GIK
heard.
regime, yes, sir.
GIK regime or Albert's
regime.
Isn't it? So that is one of the older regimes, and many of the people are still use this Albert's regime. We'll discuss that also. The second thing is using subcutaneous correction insulins, intraoperative.
Yes, sir.
Subcutaneous correction insulins. The third thing is variable rate intravenous insulin infusion.
Intravenous infusion regimen.
Yeah. This is called as VRIII, variable rate intravenous insulin infusion regimes.
Yes, sir.
So these three are the non-tight control regimes we have, and either one of them are being used nowadays.
Yes,
as long as you know about these three regimes, it is okay. And if the patient is on a continuous insulin, subcutaneous insulin pump, that also can be continued.
Yes, sir.
Depending on what kind of surgery the patient is being posted for. So that is CSII, that is continuous subcutaneous insulin infusion pump, before we have discussed.
Yes,
okay, sir. Now we know about these different regimes are there. Now a patient with maintained on just diet and exercise, posted for minor surgery.
Okay.
So which regime you want to go for? One more regime is no insulin, no dextrose regime is also there.
Yes, sir.
So can we go for no insulin, no dextrose regime for patients with
patient is not on any insulin agents and it's a minor surgery.
not on anti-hyperglycemic agents also.
Yes, sir.
And minor surgery, definitely
so
you can go in for.
Are required.
Isn't it? So, but monitor the patient. Every hourly monitoring of blood glucose is the most important. Preoperatively, yes, and intraoperatively, you can continuously monitor the patient. That is the most important thing to check for whether the patient has hyperglycemia or hypoglycemia. Okay, one of these regimes you can definitely follow. And the other patient is, patients who are on oral anti-hyperglycemic agents, posted for minor surgeries.
Except
still we can go for no insulin,
no regimen, no insulin
regime. But in both these patients, when you are monitoring the glucose levels, if the glucose levels cross 180, then you may have to go for subcutaneous insulin regime.
Yes, sir.
Even when they are posted for minor procedures. Because, I want you to have minimal confusion regarding these things.
Okay, sir.
Even in those patients where they are not on any anti-hyperglycemic agents, but still if their blood glucose levels intraoperatively is crossing 180, because we know that if the blood glucose hyperglycemia intraoperatively is not good, because it can produce many problems. Like one is the patients can develop acute complications like DK or HHS, or the patient can develop myocardial ischemia, sudden cardiac death, and then the delayed recovery, and also the post-operative surgical site infections. So these are some of the complications that can occur because of intraoperative hyperglycemia. So that is why we don't want any intraoperative hyperglycemia to occur. So that's why even in these patients, you can definitely go for subcutaneous insulins, and ideal subcutaneous insulins can be rapid-acting insulins.
Okay, sir.
Okay. So this is one of the regimes you can definitely use in these patients who are posted for minor surgeries. Okay. So if they are posted for minor surgeries, this subcutaneous correction insulin, how it is given? Because you are monitoring the blood glucose.
Yes,
It is
sir.
as long as it is between 110 and 180, you need not have to give anything.
Yes, sir.
But if it is crossing 180, then only you have to start.
Yes, sir.
Okay, how you are going to give? One thing I said, you have to know about the insulin sensitivity factor. That's why I was telling you that
Total
what is
daily.
the total dose of insulin that is required. But of course, these people are not on any kind of insulins. If they
Yes,
are
sir.
not on any kind of insulins, usually what is the insulin sensitivity factor?
It is
How much each unit of insulin will metabolize the blood glucose within the body?
Sir, there is a formula for this one insulin sensitive factor that is a
No, that
1008.
is there. If the patient is on insulin, then the formula you can use. But otherwise, usually you accept as 40 milligrams will be metabolized by 1 unit of insulin. Insulin sensitivity factor will be 40. But if you
Okay.
know what is the total dose of insulin the patient is taking. Yesterday, we had a patient in our for our surgery. So patient was on 90 units of insulin every day. So how to, you are telling about Mukesh the formula. Can you just repeat the formula to calculate the sensitivity factor once you know the TDD, total dose of
That so
insulin
1008
per day?
divided by total amount of insulin required per
Very
day.
good. Yeah, 1800 divided by the total dose of insulin that is required per day. So that is 1800 divided by 90 will be 20. I was giving one example, like in our hospital. So that means 1 unit of insulin will metabolize only 20 milligrams.
Yes,
So
sir.
with this, you know the sensitivity of the patient, isn't it? So once we assess the sensitivity, suppose now because these patients are not on insulin, we know that it is 40 you can take. How much of correction insulin, how do you calculate?
From the formula, sir.
Yes,
Actual sugar level of the patient minus 100 divided by the insulin sensitivity factor, sir.
yes,
And if
very
the
good.
PDD is not available, then denominator will be 40, sir.
40, very good. So you can just go with that. Suppose the patient's blood sugar levels are 240. 240 divided by 40. So 6 units of
6 units
insulin.
of subcutaneous correctional insulin.
Yeah, subcutaneous correction insulin is not regular insulin, mind you. It is
Okay, sir.
always the rapid acting insulin, either Lispro or Aspart. So
Okay,
this is the insulin is ideal for correction insulin. So you can give using this formula based on the insulin sensitivity. So what is the other, if you, for example, now these patients, I don't want to use this insulin sensitivity factor and calculate. Is there anything else just based on the blood sugars? You
Sliding
can
scale.
also call it as a sliding scale also.
Yes, sir.
So suppose if the blood sugar is up to 200, how much of correction insulin is given? So it is like every 50 milligrams from 150, you can give 2 units of subcutaneous insulin. It is 2, 4, 6, 8, 10
Yes, sir.
regime. 2, 4, 6, 8, 10. So up to 200, you give anything above 150 to 200, you give 2 units subcutaneously. That too you give only when it crosses 180. Even if it is between 150 and 180, you don't give. But once it crosses 180, you give 2 units subcutaneously. If it is 200 to 250, then 4. 250 to 300, 6. 300 to 350, 8. And 350 to 400 is 10. So that's how this is 2, 4, 6, 8, 10.
Yes.
Suppose if the patient is insulin resistant, who are all the patients who are insulin resistant patients?
Patients who are obese, sir, and
Yes.
patient who is on steroid therapy, sir.
Yes.
And patients
Sepsis.
in sepsis and patients who
sepsis.
are on CABG, sir.
Yeah. So these patients will have insulin resistance. So you keep on adding 1 more unit extra for this 2, 4, 6, 8, 10. for resistant patients. Okay. So who are all the patients who are supposed to be sensitive?
Patients age more than 70 years, sir.
Elderly patients,
elderly patients,
lean patients,
sir.
and type 1 diabetics.
Type 1 diabetics.
They are sensitive. So you reduce by 1 unit.
Yes, sir.
For them. Is it clear?
Yes, sir.
Yes.
Otherwise, you go for 2, 4, 6, 8, 10, every 50 milligram rise of blood glucose. And resistant patients, you keep on adding 1 unit extra. Sensitive patients, they require less. So
Yes.
you decrease by 1 unit. Otherwise, if you know the insulin sensitivity factor, that also you can definitely use. That is more accurate than
Yes,
this. Okay, so these two you can definitely use as correction insulins. This is for correction insulins. Okay, now the another group of patients is there who is now a type 1 diabetic, okay, or type 2 diabetic on insulin, posted for minor surgeries, with surgery not lasting more than 2 hours. So again, the non-tight control regime, which one would you like to use?
non-tight control regimen only, sir. Where we allow the sugar level from.
No, again, in these patients, another very important thing is, so they will be on insulin.
Yes, sir.
Already we have discussed about the oral hypoglycemics, whether to continue on the day of surgery or whether to stop on the day of surgery, when they should be stopped. Sulfonylureas preferably 2 days. Sometimes you can continue till the previous day, isn't it? And DPP4 you can continue even on the day of surgery. SGLT2 inhibitors at least 48 hours before,
Yes,
because they can produce severe dehydration and electrolyte imbalance. And you know, the biguanides, metformin. So ideally, maybe the previous day the patient can take, on the day of surgery you can avoid. So we are already discussed about these oral hypoglycemics. And GLP-1, again, you know, you may have to stop on the previous day depending on the duration of action of these GLP-1 agonist drugs, receptor agonists, because some of them are given even once weekly. They're quite prolonged, this thing, because, you know, they have to be stopped because they can produce delay in gastric emptying and make the patient more prone for aspirations. That's why GLP-1 drugs are also, so they are stopped, not given on the day of surgery. They may have to be stopped at least 1 to 2 days before. Now coming to insulins.
Yes,
now the patients may be on many of those regimes. So once a day regime, the patient may be on basal bolus regime, or patient may be on twice daily regime using that intermediate acting insulin with the regular or the rapid acting insulin. Now, what shall we do for these patients who are on insulin on the previous day and on the day of surgery? What about if the patient is on a basal insulin once a day?
If a patient is on basal insulin once a day, on the day of surgery, it will be continued, sir.
It will be, the whole thing is continued, or you have to reduce, because you don't want any hypoglycemia. Though they may not peak, they may not produce hypoglycemia as such, the incidence is less, but you have to be extra careful.
Yes,
it all
sir.
depends on what time the patient is taking. If the patient is taking in the morning, the previous day, if he is taking in the morning dose, the previous day you continue full dose, whatever he is taking. So how it's usually the basal bolus also is calculated is, the total dose of insulins are calculated, and half the 50% of the dose is given as basal for them at home or even in the hospitals, and another 50% is divided into 3 equal units and given as a prandial insulins.
Okay.
So the patient is on required about 60 units, for example. 30 units is given as a basal insulin, and another 30, 10, 10, 10, just before breakfast and before lunch and before dinner, it is given like that. And some patients may be only on basal insulin. That's what I said, type 2 diabetics. If they are on only basal insulin, they may be taking it on the morning or evening. If they are taking it in the morning, So the previous morning, you just continue. If they are taking in the night, you have to reduce by 20 to 30% of the night's basal insulin.
Okay.
Okay. Even basal bolus, if they are taking, so the bolus is continued till the previous night. The basal insulin, if they are taking in the night, again reduced by 20 to 30%. Okay. Now, on the day of surgery, basal insulin again should be continued, because in these patients, if you stop the basal or if you stop the insulins, already we have discussed they are highly prone to develop decay. So you have to continue the basal insulin, but you may have to reduce it by 30 to 50%.
Okay, sir.
You reduce it by 30 to 50%. The same thing with intermediate acting insulin also. I told you that they may be on twice a day in intermediate acting with rapid acting insulin regimes.
Yes, sir.
So the previous night, again, the intermediate acting insulin with rapid acting insulins, you give 80%. You withhold 20%. Because they can get extended up to 12 to 18 hours. And the next day morning, these intermediate acting insulin only to be given, not the calm mixture.
Yes, sir.
Don't give the mixture, because you know that rapid acting insulin, if you give, can produce hypoglycemia, isn't it? So intermediate acting insulin, you give 50% when they are posted for even minor surgeries.
Yes, sir.
So that intermediate acting insulin or the basal insulin, that will continue to act as basal insulins and prevent DKA in these patients. So that is what about the previous day insulins and on the day of the surgery insulins. If they are posted for minor surgery, or even if they are posted for major surgery, this is the same thing. For patients who are on type 1 and also type 2 diabetics on insulin. Okay. Now, other very important thing for these patients, if they are having only type 1 diabetic, they have to be started on 5% dextrose.
Yes, sir.
Because already we discussed, if you don't give them, enough of glucose, they're going to develop DKA, because they'll start going in for neoglucogenesis. So a basal insulin and glucose at the rate of, you can give about 5 grams in 1 hour. 5 grams means it is 5% dextrose. If you are giving in 1 hour, you have to give 100 ml, because 5% dextrose contains 5 grams in 100 ml. So if you just give 100 ml, that is fine. Okay, so I just repeat this. If the patient is on the basal insulin alone on the previous morning, if he is only taking morning dose, you continue the previous morning. Next day morning, you have to reduce it by 30 to 50% on the day of surgery. If the patient is on basal bolus, so the night dose of basal, if he is on, that has to be reduced by 20 to 30%. Bolus you continue, because he'll be taking food on the previous night. Then the morning, you give only the basal insulin. Don't give bolus. Bolus insulin, that is the rapid acting insulins, have to be stopped. So only basal insulin, you give about 30 to 50%. If the patient is on intermediate acting insulin, so the previous night, you give the mixture, 80% of the mixture, a combination. Next day morning, you change over to only intermediate acting insulin, either NPH or LNT, you give 50% of the dose. This is for both minor surgeries and major surgeries for type 1 and type 2 diabetics. And again, once you give them insulin, you have to give carbohydrate substrate. So you have to give them 5% glucose at the rate of about 5 grams in 1 hour. That is, 100 ml of 5% dextrose. So this is very, very important for these patients. And again, if they develop hyperglycemia intraoperative, you can go for correction insulins, because they are being posted for minor procedures. Still, you can go for correction insulin. Already we have discussed how to give correction insulin. You can even calculate their sensitivity factor. Based on the sensitivity factor, you can give them the correction insulin. But if they develop hypoglycemia, you should not allow them to develop less than 110 glucose, blood glucose levels. If they develop hypoglycemia, you have to again correct this. That we will discuss. And another very important thing, how frequently you give the correction insulin. How frequently you have to give the correction insulin intraoperatively, because you are using rapid acting insulin not more than 2 to 4 hours. 2 to 4 hours. Ideally 4 hours, but you can still give between 2 to after 2 hours also you can repeat the rapid acting insulin. So that is how frequently you have to give the correction insulin. Okay, now understood about this particular regime of correction using correction insulin, subcutaneous correction insulin for patients who are on insulin. Okay, now coming to the major surgeries or the complex surgeries for type 2 diabetics. So what would be the ideal regime in this? Because in these complex surgeries means you expect a lot of variation in their blood pressures, isn't it? And even they can develop hypotension for a long time. If you are using subcutaneous insulin, the problem is the variability in the absorption of subcutaneous insulin, isn't it? So that is why in such patients, it is always, whenever they are posted for major surgeries, whether these patients are type 2 patients, whether they are on insulin or not on insulin, on oral hypoglycemics or not on oral hypoglycemics, and also type 1 patients on insulin, better to go for variable rate intravenous insulin infusion method.
Yes, sir.
And this was the olden days, this was called as sliding scale insulin. It is the same, the nomenclature has been changed to variable rate intravenous insulin infusion. Here, even now today, many of the hospitals are still using this Alberti regime. So you'll have to know about this Alberti regime as well. Now, can you just, Lakshmish, can you just tell Alberti's regime? Original Alberti's regime, modified Alberti's regime. When Alberti's regime was introduced?
1979.
Yeah, roughly in 1974, it was introduced by Alberti. Okay. That is otherwise called as glucose insulin
Potassium
regime, GIK regime.
Yes.
Okay.
So
can you just tell what was the original and what is the modified one?
We will take 500 ml of 10% glucose solution. To that, we add 10 units of insulin and then 10 millimoles of potassium, sir.
Potassium chloride.
Potassium chloride. And then we infuse at a rate of 100 ml per hour, sir.
Okay. Okay. But you are using, it went into disfavor because using 10% dextrose.
Yes, sir.
That's why the modified Alberti regime or GIK regime nowadays we use 5%
dextrose, sir.
Dextrose. And for 5% dextrose, 10 units of insulin is added,
yes,
and 15 milliequivalents of potassium chloride is added.
Yes, sir.
Because Alberti thought when you give insulin and dextrose, potassium from extracellular compartment will move into the intercellular compartment.
Yes, sir.
So you have to provide extra potassium in order to prevent hypokalemia. That is what he thought, and that's how potassium was also included in this Alberti regime. Now we are using 5% dextrose, and usually it is given at the rate of 125 ml per hour.
Okay, sir.
10 units of insulin, as long as the blood sugars are between 110 to 180.
Yes, sir.
Because why I am telling you about Alberti's regime, invariably you will be asked in the practicals about Alberti's regime and the concept about the Alberti regime also, the rationale or reasoning about that. Why 10 units of insulin are added to this 5% 125 ml of dextrose? For that, you have to know each unit of insulin will metabolize how many grams of exogenous glucose?
1 unit metabolize so 1 gram, 2.5 gram of glucose.
Yes, very good. So each unit will metabolize about 2.5 grams of exogenous glucose. Now, how much of glucose is there in this 125 ml?
25 gram.
No, because 100 ml will contain
5 gram. 5 gram.
Yeah, okay. Now we have to know, okay, let us say about 500 ml. This 500 ml, we are adding 10 units, isn't it? So
Yes,
this
sir.
500 ml contains 5% dextrose, means how many grams of glucose it contains?
25 grams.
Yeah, 25 grams. Because 5% means 5 grams in 100 ml. That you should always realize. Weight by volume. So it
Yes, sir.
contains 25 grams. So for metabolizing 25 grams, how many units of insulin is it?
10.
10 minutes.
10. That is the reasoning here why modified Alberti regime or modified TIK regime, we are adding 10 units. That means we are also giving glucose, we are also metabolizing it by
Yes, sir.
giving insulin, and we are preventing decay. Do you understand?
Yes,
We are
sir.
preventing decay because insulin is also being given, dextrose is also being given. We are not producing hyperglycemia because whatever dextrose you are giving from outside is also, you are giving adequate insulin to metabolize it. Okay, so that's how. Plus 15 milliequivalents of potassium. Suppose if every 30 milligram increase of blood glucose, because every hourly you are going to monitor the glucose. You have started with this regime when the blood glucose was between 110 to 180. Next, once it is increased by 30 milligrams, it has gone to 210. Now we'll have to change the whole thing because you have to start a fresh one with 15 units of insulin.
Yes, sir.
From 10 units, you have to increase it to 15 units. Suppose if it is gone above 210, you have to prepare fresh solution of 20 units of insulin and the same amount of potassium.
Yes, sir.
So suppose if it is less than 110, then you have to add only 5 units of insulin. Again, a fresh solution has to be prepared
Yes,
with
sir.
15 milliequivalents of potassium. If it is less than 70, you give only glucose
Yes, sir.
and no potassium, no insulin. That is the Alberti regime. But the main problem, the advantages were many because you are managing the glucose status, you are also giving insulin, you are preventing decay, you are also preventing hypokalemia. And other very important with this regime is you can extend this into the post-operative period till
Yes,
the
sir.
patient takes oral his regular diet. Till then you can continue. So that is the greatest advantage. And post-operatively, you need not have to monitor every hour. You have to monitor once in 4 hours. Because 125 ml, if you are giving, 4 hours you can run
Yes, sir.
this 500 ml. That's how a lot of advantages were there with Alberti's regime. That's how it had become very popular, modified one. And even today it is being used by many people. But only problem with Alberti's regime is every time it is altered above 110 or above 180 or less than 110, you have to have a fresh preparation of the whole solution. You have to waste the previous mixture.
Yes.
So that is the main problem. So, okay, one question here. What is 15 milliequivalents of potassium? How many ml of potassium chloride you will be adding? No, you only said potassium chloride has to be added. If I say 15 milliequivalents have to be added, how many ml? Each ml of potassium chloride, how many milliequivalents it contains? What is the percentage of potassium chloride you get? It's 15%. Potassium chloride is 15%. That means 15 grams in 100 ml or 150 milligrams in 1 ml, or each ml contains 2 milliequivalents. How I get this is because it is 15%, that means 15 grams in 100 ml. For milliequivalents, you have to calculate per liter.
Yes.
So in 1 liter, it will contain 150
into 10.
150 No, 15 milligrams in 100
100
ml. So 150
In
grams in 100 ml. 150 grams in 1 liter.
1 liter.
150 grams is 150,000 milligrams.
Yes, sir.
So divided by the molecular weight, you get how many milliequivalents per liter. Molecular weight of potassium chloride is 75. 40 is the potassium, 35 is chloride. So 150,000 divided by 75 is 2,000.
Yes.
That means 2,000 milliequivalents in 1,000 ml because 1 liter. So 1 ml contains
2 milliequivalent.
2 milliequivalents. Now you know
Yes.
how we got this. So each ml contains 2 milliequivalents. So you have to add 7.5
5.5 ml.
ml. If you have to add 20 milliequivalents, then 10 ml.
10 ml.
So these are all very important things for your exam purpose also and for your day-to-day practical use also. Okay, that is about Alberti regime. Now coming to, because there are a lot of drawbacks, especially wastage of insulin and wastage of glucose and potassium, we now have gone for variable rate intravenous insulin infusion regime. So for all complex surgeries, whether the patient is type 2, type 1, or whatever it may be, only thing is in the type 1, they have to be given basal insulin in the morning and they have to be started with 5% dextrose.
Yes, sir.
That is a must for these patients with type 1 and also type 2 diabetics on insulin, because already there is exhaustion of the pancreas in type 2 diabetics, long-standing type 2, now they are on insulin. So usually you start them on whatever the basal insulin plus 5% dextrose. This is not required for those patients who are type 2 and may not be on insulin. That is the only difference. Otherwise, variable rate intravenous insulin infusion is same for both. Okay, now how do we start the infusion?
If blood glucose level is more than 246, sir.
No,
we have-
one basal infusion we have to start, isn't it?
Yes.
That means some amount of insulin with normal saline you have to start with. That 5% dextrose for type 1 is being given through another IV cannula.
Yes, sir.
Here you use normal saline with insulin. Always you can have an infusion syringe pump. You can start with 50 units in 50 ml.
Yes, sir.
That means you will be very accurate. 1 ml contains 1 unit of insulin. So once you start your anesthesia, you can also connect this. Before that, you have to do a blood sugar estimation. And let us assume that the blood sugar is between 110 to 180. Whatever the blood sugar is there, divided by 100 will be the amount of insulin you will be giving for that 1 hour when you start the anesthesia.
Yes, sir.
And every hourly you are going to monitor. Let us say it is 180. So you have to start with 1.8 ml of this solution in that hour. The next hour you are going to do the monitoring, and then you have to increase the dose or decrease the dose depending on the blood glucose levels. You have to maintain between 110 to 180.
Yes, sir.
Okay. Next hour, the blood glucose remains between 110 to 180. What we do?
To increase the rate by 3 units.
No, if it is between that, you need not have to change it.
Don't have to.
It is maintained. There is no increase. Whatever the blood glucose it was there before, it is maintained. So you just continue with the same thing. No need to alter it. Whatever you are giving 1.8 ml or 1.5 ml. So you just continue.
Yes, sir.
So, but if it is increasing above 180, what should we do? Now you have to increase the insulin dose also.
Yes, sir.
For every 30 milligrams increase, you add 1 unit of insulin increase.
Yes, sir.
Suppose if it is 210, add 1 unit for this already running basal infusion.
Yes, sir.
So if it is 240, 2 units.
Total 3 units.
270, 3 units. 1, 2, 3, 4, 5.
Yes, sir.
Like that. So again, if the patient is insulin sensitive, then don't add 1 unit. You have to reduce it by 50%.
Yes, sir.
If the patient is insulin resistant, you add 1 extra.
Yes, sir.
So that's how it is altered, variable rate intravenous insulin infusion. Suppose if it is decreasing by 30 milligrams, then you have to reduce by 0.5 unit.
Yes, sir.
If it is reduced, for example, it was 150, now it has come down to 120. It is reduced.
Yes,
It
sir.
is not in the same range what it was. Now
Yes,
you
sir.
reduce by 0.5 units for every 30 milligrams till 110.
Yes, sir.
So once it is less than 110, then you have to stop the infusion.
Yes, sir.
Stop the infusion, wait for 1 hour and then see, or 30 minutes, wait for 30 minutes, see what is the blood glucose levels. If it is coming in the same range of more than 110, then run at the half of whatever you are running rate. Okay. Suppose if it is further reduced, it has come down to 70, then you have to give
Glucose extra.
glucose, dextrose, either 50% dextrose or 25% dextrose.
Yes, sir.
Then again, after 15 ml, you have to check the blood sugars. And if it is more than 110, again, continue, but at the half rate.
Yes, sir.
Okay. So that's how, you have to correct. If it is decreasing and decreased less than 110, stop, and less than, or it has come down to between 110 to 70, and even after 15 minutes, it has not increased, then you have to give glucose and increase the blood glucose level to again bring back between 110 to 180. And if it is less than 70, then definitely you have to give higher dose of 50 ml of 50% dextrose. If it is between 70 to 110, you give 25 ml of 50% dextrose.
Yes, sir.
Okay, this is what is called as variable rate intravenous insulin infusion regime. So this regime is for complex surgeries for whatever the patient. So there are ideally only 2 things now. Subcutaneous insulins, that is for minor procedures, and intravenous insulins for major complex procedures, whether it is type 1 or type 2. Easy to remember, easy to practice, isn't it? Not much of, should not be having confusions. Now, in the post-operative period, again, whether the patient has come for a minor surgery, then as soon as he resumes his regular diet, so whatever the regime he was following, it can be immediately followed.
Yes, sir.
Suppose if the patient is now for a complex surgery and you are giving variable rate intravenous insulin infusion regime, so you continue till the patient can take his regular diet.
Okay, sir.
And just before he takes his regular diet, you have to give at least 2 hours before his basal insulin.
Basal insulin.
Because as soon as you stop, the insulin levels will drop.
Yes, sir.
Because the half-life of intravenous insulin is just 5 minutes. Once you stop, after 5 minutes, the effect will not be there. So the patient can definitely go in for DKA.
Yes, sir.
Because he will not have any insulin, especially type 1. So that is why at least 2 hours before, whatever the basal insulin he was getting, you start that, and then after 2 hours you stop this, then ask him to take food.
Okay.
Okay, so that's how it is done in the post-operative period. So these are the different insulin regimes that we follow for the intraoperative and the preoperative, intraoperative and post-operative period. Okay, now coming to the anesthetic technique. Now we had thought about the regional anesthesia technique would be ideal. Again,
Yes.
in regional anesthesia technique, what precautions you have to take for regional anesthesia? Because many times in theory also, whatever I have seen, when you are asked about a theory regarding a diabetes patient, you'll be talking about only these regimes for management of hyperglycemia. You will not write anything about the anesthesia part, because that is the one which is very, very important. This, the hyperglycemia or glycemic status part or management part is a part of your anesthesia technique. So you have to write down how you are going to give your regional anesthesia, what precautions you'll be taking for regional anesthesia, and if you are giving general anesthesia, what precautions you'll be taking for general anesthesia. Those things you have to write down and you have to discuss. Okay, for regional anesthesia, what precautions you have to take?
If the patient is already having any sensory motor deficit due to neuropathy, it will be documented prior giving the regional anesthesia.
Yes,
sir.
this is one of the most important thing, because there are two things. One is, suppose your patient, he doesn't have any sensation in the foot.
Yes, sir.
Should you have to provide any kind of regional anesthesia? He doesn't have any sensation, no pain, no touch, nothing. Then debridement can be done without anesthesia. You can do a monitored anesthesia care.
Yes,
That is
sir.
one thing. Second thing is the medical legal aspects. The patient can sue you in the court of law if you have not documented that it is because of your regional anesthesia that he has developed this.
Yes, sir.
Whatever the paresthesias or the peripheral neuropathy he has.
Yes,
Based on, because of this, you have to really document in your case sheet regarding this. Okay. And what about the other precautions you will be taking? For example, I'm using a nerve stimulator. Should I take any precautions? Or should I use it, or better to avoid it?
Nerve stimulator can be used, sir, but concentration of local anesthesia should be.
No, that we will come to that. Nerve stimulator itself. What happens to their threshold levels?
Will be decreased.
Electrical threshold is increased or decreased?
Decreased.
Huh?
Decreased, sir.
No, it is increased.
Current should be less.
Threshold levels, electrical threshold levels are increased. So you may have to use higher current. When you are using higher current, more damage can occur.
Yes, sir.
That is why, ideally speaking, better to go for an ultrasound guided technique. And second thing is, already they will have some damage. Their nerves are extremely sensitive to local anesthetic.
Yes, sir.
So your concentration of the local anesthetics may have to be reduced. You don't have to give the same concentration what you would have given for a non-diabetic patient. That is the second thing. Third thing is, avoid adrenaline containing local anesthetics.
Yes, sir.
Because already there is, vasa nervorum has been affected, which is the cause for neuropathy. You can produce more damage to these nerves. So adrenaline containing local anesthetics to be avoided. Okay. Now coming to the general anesthesia. So if I want to give GA, so what precautions I have to take? One thing is, we expect them to have
Full stomach.
Should we give them till 2 hours before we are going to give them clear fluids, isn't it?
Yes, sir.
Any carbohydrate containing fluids should we have to give them? Is there any definitive guidelines as far as the giving carbohydrate preloading? Sorry, not preloading. Clear fluids.
But if we are giving clear fluid, it has to be non-pulpy containing juice or non-carbon.
No, because maltodextrin is one of the complex carbohydrate. Now in many centers, they give routinely for patients. Should we also give maltodextrin for these patients? Because in ERAS protocol, this is there.
Okay.
Isn't it? In ERAS protocol, giving complex carbohydrates as clear fluids 2 hours before is there. So is there any clear consensus regarding use of complex carbohydrate clear fluids for diabetic patients? There are no clear consensus.
Okay, sir.
So you need not have to give any carbohydrate containing, because one school of thought says that it unnecessarily may complicate the glycemic status in these patients.
Okay.
So that is the reason why many people do not want to give, even in ERAS protocol, the complex, the maltodextrin as a clear fluid.
Yes,
Okay.
sir.
Now, what are the other precautions you have to take for full stomach?
Aspiration prophylaxis to be given.
Yeah, very good. So aspiration prophylaxis. So many of you will tell in the exam anti-aspiration prophylaxis.
Okay, sir.
It's not anti-aspiration prophylaxis. It is anti-aspiration drugs or aspiration prophylaxis.
Okay, sir.
Not both. It will give you an opposite meaning. So, okay. Now, aspiration prophylaxis is what?
Injection metoclopramide, injection ranitidine or pantoprazole.
And then
On the
antacid also. If you have availability of,
non-particulate
the
matter.
non-particulate sodium citrate, 0.3 molar, that also you can definitely use. So aspiration prophylaxis is very important. Strict NPO status is very important. And in type 1 patients, starting 5% dextrose much before, at least 1 or 2 hours before the surgery is very important. So
Yes,
2 hours before only, once they are kept nilorally after 2 hours, before 2 hours, they can be started on 5% dextrose. And also they have to be given basal insulin. That is another very important thing, whether for GA or regional anesthesia. These are all the precautions you'll be taking. And GA again, you'll go for rapid sequence induction. So, somebody had asked for the steps of rapid sequence induction. The steps of rapid sequence induction is, first of all, you have to tell the patient about rapid sequence induction and why you are doing this, why it is so important. Because why this is important is because in rapid sequence induction, cricoid pressure or Selix maneuver is a part of it. And you'll be applying 10 newtons of Selix maneuver or pressures over the cricoid pressure, even when the patient is conscious.
Yes, sir.
So he may become really alarmed if you are applying pressure without taking him into confidence. So that's why the first step is always telling the patient about in detail about that maneuver, and he'll be the pressure will be applied over his neck. That is one thing. The second very important thing is pre-oxygenation. Next is pre-oxygenation. Why pre-oxygenation and denitrogenation of the lungs have to be done? Because succinylcholine is the drug of choice in India for rapid sequence induction. And after giving succinylcholine in regular rapid sequence induction, you don't ventilate. Only in modified rapid sequence induction, you ventilate with low pressures.
Yes, sir.
But many times during this 1 minute period before the succinylcholine acts and you start your laryngoscopy, the patient may be apneic. And he has to tolerate this apneic period of the hypoxia can occur. So that's why you fill the lungs, FRC, with oxygen. So 3 minutes of pre-oxygenation is a must. Then, giving the pre-medicants you can start during your pre-oxygenation. And another very important step here is, you have to mark the cricoid cartilage, and also you have to inform the assistant where he has to apply pressure and how much pressure he has to apply. And the patient also should be told that this amount of pressure is being applied till you lose your consciousness. That is another part of the cricoid, rapid sequence induction. Then you start inducing the patient using either propofol or tapentol or etomidate, whatever may be the induction agent. But here, induction is not till the patient loses the eyelash reflexes with rapid sequence induction. You just calculate the total dose that is required for induction and give the whole dose without waiting for the eyelash reflex to be lost. But you give slowly. All induction agents, IV induction agents, have to be given slowly only. Okay. The next thing is followed rapidly by giving succinylcholine. And wait for the fasciculations to reach the toes or wait for 60 seconds. Then you do the, and ask once the patient loses consciousness, ask the assistant to increase the pressure to 30 newtons. Of course, this 10 newtons and 30 newtons, that is one problem with cricoid pressure. I'll just come to that. So he has to increase the pressures over the cricoid cartilage. And then you do a laryngoscopy as fast as possible, quickly as possible. Intubate, confirm the presence of the tube by your capnography, inflate the cuff, then only you ask the assistant to release the pressure over the cricoid cartilage. Okay. Now these are the steps for rapid sequence induction, which you have to follow in these diabetic patients also. So now there are a lot of controversy regarding cricoid pressure. One thing is how much is 10 newtons, how much is 30 newtons. Definitely it is very difficult to know. That is one problem. Second problem is they have done various studies, including CT scans. The cricoid cartilage may not be just in front of the esophagus. Esophagus may be slightly away from the midline. So when you are actually trying to press the cricoid cartilage, the esophagus is not compressed between the lamina of the cricoid and then the C6 vertebral body. So still the patient can regurgitate. The third problem with cricoid pressures is, the normal airway can become difficult. So you may be struggling, and during that struggle, the patient may regurgitate and aspirate. So that's how, we may be doing away with cricoid pressures. But for exam purpose, you have to know about all these. Application of cricoid pressure also, you have to know the problems associated with cricoid pressures also, you have to. This is a rapid sequence induction. And again here, because we know that these patients, both for regional anesthesia, another precaution is, and again for general anesthesia, is because if they have diabetic autonomic neuropathy, the possibility of refractory hypotension is very common in both regional and general anesthesia. If they have diabetic autonomic neuropathy, better to avoid only spinal anesthesia. You can still go for spinal anesthesia, provided you go for low dose spinal with graded epidural. The technique is called as low dose spinal with graded epidural. Otherwise, nowadays it is also called as sequential combined spinal epidural. Low dose means only 1 ml of hyperbaric bupivacaine you are giving, which will not go beyond probably T10 maximum. So not much of sympathetic block. It will not produce much problem for the patient, but it is going to produce better epidural analgesia when you supplement your spinal with the epidural, because you have created a hole, and through that hole some amount of seeping in of local anesthetics will be there into the interthecal space, and a better sacral analgesia and anesthesia will be there with the epidural once you go for sequential combined spinal epidural. So this is the one which is becoming very popular in cardiac patients and also in diabetic patients with diabetic autonomic neuropathy. So the advantage is you can grade the epidural afterwards, whatever to the level, whatever you require, and you can prolong the duration of anesthesia. Also, you can prolong the duration of analgesia. So that's an advantage. There is another technique also you can use is dural puncture epidural. So you just puncture the dura with a 27 gauge needle. If you have a needle through needle technique for combined spinal epidural, this is ideal. You just puncture the dura, but don't give any drug intrathecally. Then pass the epidural catheter. Then you go for a graded epidural by giving only 3 cc's every time. So that way you can definitely prevent the severity of hypotension. Incidence you cannot prevent, but severity you can definitely prevent in these patients with diabetic autonomic neuropathy, or in those patients where they have got severe cardiac problems like mitral stenosis, severe aortic stenosis, or cardiac failures. In all such patients, if you think that regional anesthesia benefits are high, you can definitely do like this. In a patient with autonomic neuropathy or cardiac problems in a diabetic patient, but if you are going in for GA, then again you will have to go for, even though you are going for a rapid sequence induction, you go for a sleep dose of induction. You don't go for a calculated dose. Just now I was telling you the steps the calculated dose always you go. But one of the exceptions is in these patients with autonomic neuropathy, or if they have some severe cardiac problems. You go for a sleep dose, especially propofol. Propofol may be an ideal drug many times because it can suppress the intubation response better, because this is also very important in these patients. You have to suppress the intubation response because the cardiac conditions they may also have hypertension. There can be sudden increase in the blood pressure, and also they may develop all kinds of dysrhythmias. There can be increase in intracranial pressures as well. So in all such situations, you have to suppress the intubation response. Propofol may be an ideal drug compared to etomidate and thiopentone. But if you are using that, you have to go with a sleep dose. Sleep dose is you calculate the total dose that is required, give 50% of the dose slowly of propofol. Then for every arm brain circulation time, usually about 10 to 15 seconds, you give 10 milligrams increments. And then look for the eyelash reflexes. Till the eyelash reflexes are lost, you give, then followed by succinylcholine. That is a sleep dose. Sleep dose with thiopentone, the same thing. Give half the calculated dose, then give 25 milligrams in. That is the dose. Whereas for etomidate, you don't have to go for sleep dose. You give it slowly. Because we know that etomidate, as far as cardiac status is concerned, it is absolutely produces stable cardiac status, but it will not suppress the intubation response. So that is why better to go for propofol. If propofol is totally contraindicated, because we know that it is going to suppress inhibit the myocardial contractility, it also produces peripheral vasodilation, it also does not produce compensatory increase in heart rate. So in such situations only, either go for etomidate or go for the drugs like opiates with benzodiazepine if you are planning for post-op mechanical ventilation. Okay, now now understood about GA for these patients. Now coming to the diabetic patients posted for emergency surgery. This one aspect again we'll have to talk about. Okay, what about the emergency surgeries? Dr. Azam, it is 12:12. Can we discuss for another 20 minutes?
Yes,
Yes, sir.
yes,
No
sir.
problem.
Yeah, absolutely no problems.
I want to finish off this patients posted for emergency
Yes, sir.
surgery.
Another 1 or 2 hours also no problems. Not to
No,
worry.
just about 20-25 minutes.
Sure.
I'll finish
Sure,
off.
Sure, sir.
Okay. Thank you so much.
Thank you, sir.
Okay. Mukesh,
Yes, sir.
patient posted for emergency surgery. We can have both type 1, type 2 patients posted for emergency surgery.
Yes.
I told you that all these patients, when when you are asked in theory or in practicals, you have to say, I'll assume that the patient has diabetic ketoacidosis.
Okay, sir. Okay.
So immediately you'll be asked about the management of diabetic ketoacidosis and why it is important to manage diabetic ketoacidosis before taking up this patient for the surgery. Even though he is posted for emergency surgery, all emergencies definitely can wait for 2 hours.
Okay.
Unless it is a cesarean section, a patient with gestational diabetes. Otherwise, all surgeries can wait for, usually majority of our emergencies can wait for 2 hours, and that is their time is there for you to optimize their condition of DKA. So how about this management of DKA? When do you say the patient has DKA? What is the criteria to say DKA?
When the blood glucose level is more than 350 gram percentage and
250. Blood glucose more than 250, one criteria. Okay.
And the pH level is
Less than 7.3 of pH.
and
Yeah,
bicarb is less than
7.3 pH, arterial pH less than 7.3. Then
bicarb is less than 18.
Less than 50 milliequivalents per liter.
in some books it is also given as 18, less than 18 milliequivalents per liter. One more.
And with presence of ketones.
Yeah, at least 2+ ketone bodies in the urine or in the serum. You can
Yes,
even
okay.
estimate the blood.
Anemia
flow
more than
system.
3 milliequivalents per liter.
Yes. These are the criteria to diagnose DKA, because the patient can also have HHS
Yes, sir.
Yes, sir.
as an acute complication in a patient who is posted for emergency surgery. HHS, the difference is the blood glucose level will be much higher. It will
Yes,
be more
sir.
than
500 to 600.
600, more than 600.
Yes, sir.
And the pH will be
More than
More than
7.3.
7.3.
7.3. It will not be less than 7.3. It will be more than 7. It will be normal pH, isn't it? No acidosis. Bicarb will be more than 18.
Yes, sir.
And absence of,
Ketone.
now you can say, and presence of some neurological problems, because
Yes, sir.
hyperglycemia produces hyperosmolarity. Hyperosmolarity can produce a lot of neurological symptoms in these patients. That is HHS, isn't it? Hyperosmolar hyperglycemic state.
Yes, sir.
So usually DKA patients may not have so much of neurological problems unless it is a severe DKA.
Yes,
Whereas
sir.
HHS is more common to have. Okay. The patient with DKA, you have found out that all these criteria the patient is meeting. So why should I not take this patient for the surgery straight away without optimizing his?
Patient with DKA will be having dehydration, sir.
Yeah, very
So,
important thing. So
in the
dehydration, definitely he'll collapse if you give spinal, epidural or GA. He'll have a arrested patient.
Yes.
Okay, what is the second problem?
Second problem is acidosis, sir. Acidosis itself will have myocardial depression and
Yes, very good. So
problems
already
with
depressed
development.
myocardium. Over and above, you are also using drugs which can depress the myocardium. So again, you can have an arrested patient. Third problem.
It also have a myocardial depression.
What?
Anesthetic drugs also have a
Myocardial
some amount of
depression.
No,
myocardial.
that because of that only. Because already myocardial depression is there. Third is potassium.
Yes, sir. Potassium.
Potassium imbalance, isn't it? So because of the potassium imbalance, the patient can develop fatal dysrhythmias.
Yes, sir.
Now these three things you should tell why you want to optimize the patient, or at least partially optimize the patient before considering him for any kind of emergency surgery. No elective surgery.
Yes, sir.
The patient has DKA. No elective condition. You have to really optimize the whole thing, and then only you have to take up. Okay. Now, how do we, manage or treat DKA? One thing, first thing you said that the fluid
Yes, sir.
deficit. Why fluid deficit?
There
Cause
will be
for fluid.
osmotic diuresis. Osmotic diuresis will be there.
Very good. So osmotic diuresis is there. So you have to estimate the amount of fluid loss or fluid deficit. How do we estimate the fluid deficit?
Clinical signs of dehydration.
Yes, very good. Based on the clinical signs, especially like the eyeballs, then skin turgor, then the moisture of the mucous membrane, his pulse, the volume of the pulse, the rate of pulse, the pulse pressure, then the blood pressures, then sensorium, then the urine output, then the specific gravity of urine.
Yes,
So
sir.
you have to consider all these. Based on this, I will not go into details about how do you really classify them, but you classify them as mild, moderate, and severe dehydration. And for mild dehydration, the required fluid deficit is 30 ml per kg body. For moderately severe, it is 60 ml, and for severe, it is 90 ml per kg body weight of fluid deficit in adult patient.
Okay, sir.
For pediatrics, it is 50, 100, 150 ml per kg, because their body surface area is more than their body weight. That's why the deficit will be more. So that's how you calculate. Invariably, many of these patients will have severe dehydration.
Yes, sir.
With DKA. So if they have severe dehydration, let us say is a 70 kg man. So 90 ml per kg body weight is fluid deficit. How much of fluid he requires? 90 multiplied by 70 is roughly 5.6 liters, roughly 6 liters.
Yes.
That's why in many of the books, if you just see, they would write 6 liters of the fluid deficit in DKA patients. It is not same for all patients. So you have to calculate mild, moderate, and severe. So adults 30, 60, 90, pediatric 50, 100, 150.
Okay.
That amount, because you can have pediatric type 1 patients who directly come to emergency department with DKA.
Yes, sir.
So you should know about what is the fluid deficit, how much to be given for them. Now this fluid deficit, how do you correct? How rapidly you can give this?
In the first hour, around 15-20 ml per kg fluid is given, sir.
You just don't have any, this thing, rain. Just give first 2 hours 15 ml per kg body.
Okay, sir.
Subsequently 7.5 ml per kg.
Okay, sir.
So it will be very simple. You calculate the total deficit.
Yes, sir.
And based on that, you have to give this, isn't it? You invariably, if the patient is severely dehydrated, so he requires 6 liters. So if you can correct 15 ml in a 70 kg man is 1 liter in 1 hour. Second hour also another 1 liter. Subsequent hours 500.
500 ml.
Okay. This is how you correct, because you should not produce circulatory overload.
Yes, sir.
By rapidly, if you give, you can produce circulatory overload. That is why this is how you can always give. Suppose you have calculated lesser amount of, for example, the patient is moderately dehydrated. His requirement is now less. His
Yes,
requirement is about 60 ml per kg body weight, maybe 4 liters, isn't it? So then in the first hour, you give 15 ml per kg body weight, subsequently 7.5 ml per kg, depending on the amount of dehydration the patient is having.
Yes, sir.
Okay. Now that is about the fluid. And what fluid?
Normal saline.
Yeah, ideal would be to go for normal saline, isn't it? So many of the books also have given ringer lactate.
Yes, sir.
Because a balanced salt solution. So plasma light, ringer lactate also can be given, but plasma light, the problem is the cost.
Yes, sir.
You don't get any more benefit than normal saline. Ringer lactate, the cost is not a problem, but lactate can get converted to glucose.
Glucose.
And in a patient whose liver is not working well, lactate can increase the acidosis. Normally, lactate gets converted to bicarb in the liver. So no question of, acidosis.
Yes, sir.
But it can produce. And again, you will have a problem. The patient already who is having a lot of sepsis and his lactate levels are on the higher side. Your ringer lactate may also theoretically may increase in the lactate levels, and you don't know why is the increase. So because of all this, because these are the questions we'll ask you. Why only normal saline? Why not plasma light? Why not ringer lactate? Okay, understood. Okay.
Yes, sir.
This is the fluid, and afterwards, once the blood glucose levels comes down to 250 and below, you change the fluid to 5% dextrose with half normal.
Yes, sir.
Okay, that's about the fluid. Now coming to the hyperglycemia is the cause for dehydration. Now you have to treat hyperglycemia. So how do we treat hyperglycemia?
Before starting insulin, the potassium should be corrected, sir.
No, you are, as soon as the patient comes, you are going to do all the investigations. ABG you are going to do. That's how the criteria, isn't it? You would have done an electrolytes also. You would have known what is the bicarb levels also. Everything you know. That after that only you are going to start your whatever the management. Everything occurs within few minutes, and you know what is his potassium also. Okay. So how much of insulin initially they require, and when do you want to avoid insulin as a starting thing?
Initially, the bolus will be given, sir, 0.1 units per kg.
Yes, okay.
IV, and followed by the 0.1 unit per kg per hour, sir.
As an infusion.
As an infusion.
So usually you go for bolus also. Now sometimes you may not give the bolus also, but usually bolus is given. Why a bolus is given? Why do you have to give a bolus of 0.1 unit per kg? What is, how, it is going to help?
Bolus dose will act rapidly and it will reduce the sugar level, sir. Then to maintain that.
No, you should not reduce the sugar levels also rapidly, isn't it? It can produce hypoosmolarity and cerebral edema and other problems. Everything has to be gradual.
Yes.
Nothing should be done fast. Rapid change, nobody will tolerate, including the body. It has to be gradual, not more than 50 to 70 milligrams per hour of reduction. So,
Yes,
because there are insulin receptors in the body. First, you have to saturate these insulin receptors. And once you saturate, you maintain the saturation by giving infusion. That is why the bolus dose will saturate the insulin receptors. There are not many receptors in the body as far as insulin receptors are concerned. Easily, you can saturate them by just giving 0.1 ml, 0.1 unit per kg body weight of insulin, and maintain the saturation by giving continuous infusion. That's how you always go with. Infusion, you can also give based on the blood sugars also.
Yes, sir.
So blood sugars in milligram divided by 100 in those patients who are obese, on steroid dependent, and having severe sepsis. Otherwise, divided by 150.
150.
Or you can go for 0.1 milligram unit per kg per hour infusion. But every hour you have to do the estimate of blood glucose levels. And once the blood glucose levels comes down to 250, you have to start glucose also, 5%.
Yes,
By 250, you have to start this 5% extras. Because the threshold of hypoglycemia is elevated.
Okay.
Anything less than 250, they may, or 200, they may develop all kinds of hypoglycemic symptoms.
Okay.
Because they are having a sustained increase in this blood sugar levels. So the threshold of hypoglycemia is increased. That's why at 250, you don't want to take any chance. So you substitute 5% dextrose also. And also that will further reduce any lipolysis that is occurring. Okay, these are the two reasons why at 250 you will start 5% dextrose with half normal saline. Okay, now Mukesh, you said that you will avoid, you first want to see what is the potassium levels. Based on that, you would like to give insulin. You want to avoid any time if the potassium levels are low.
If potassium levels are low, then insulin should be delayed, sir. First, potassium correction has to be.
No, how much low?
Less than 3.5.
Yeah, anything less than 3.5. Some books also give 3.3. It's okay. If the potassium levels are less than 3.5, avoid insulin. And that hour you don't give insulin, you give only fluids. Next hour, again, you do a potassium estimation. If the potassium is increased to more than 3.5, you can give. In the meantime, you have to give potassium supplementation. So as long as the potassium is more than 5.5, you don't give any potassium. Because here what happens is total body potassium levels will be low. Because the potassium, because the acidosis comes out of the cells, because potassium basically is an intracellular electrolyte. Intracellular, it contains 150 milliequivalents of potassium. Extracellular, it is just 3.5 to 5 milliequivalents. So intracellular potassium will come into the extracellular compartment and then it is thrown out through the kidneys because of the hyperosmolarity is there. So the urine output is increased. So naturally, potassium will also be thrown out. So the patient may have a spuriously high amount of extracellular potassium levels initially. Once you start correcting the DKA, the potassium will start entering the intracellular compartment rapidly. The patient can develop hypokalemia. That is why you have to supplement these patients with potassium. If the potassium levels is more than 5.5, don't give any supplementation. Okay. Initial potassium levels. If it is between 4.5 to 5.5, add 10 milliequivalents of potassium and run it over 1 hour. Okay. 10 milliequivalents of potassium per hour supplementation you can give. If it is between 3.5 to 4.5, give 20 milliequivalents of potassium per hour. And every hour you have to check. And if it is less than 3.5, add 40 milliequivalents of potassium, run it over 1 hour and check after 1 hour.
Okay.
And after 1 hour, once the potassium level is more than 3.5, then start insulin. Okay, that's how you correct the potassium levels. Third is the acidosis.
Yes, sir.
So should we correct acidosis or we need not have to correct acidosis?
If pH is less than 7, we have to correct acidosis. We have
Very
to give
good.
bicarb.
So if it is more than 7, you don't give any bicarb because it produces more harm than any advantage. Because bicarbonate, it's a carbonic acid, its pKa is 6.1. So as long as the pH is between 5.1 to 7.1, it will have some amount of benefit. Of course, I'm just telling you 5.1 because nobody less than 6.8, nobody will be alive. That means between 6.8 to 7.1, only it is going to help. If it is more than 7.1, it can produce more harm than any benefit. That's why if it is more than 7.1, don't give bicarb correction. If it is less than 7.1, again you can give correction again based on the base deficit. Base deficit multiplied by body weight in kgs multiplied by 0.3 should be the total requirement of bicarb. Half of it you correct and then do an ABG and then see whether it is required or not. Once it is more than 7.1, now pH, you don't require to continue it. That's how you always, because there are a lot of drawbacks of giving bicarb unnecessary. Okay, that's how we treat. At least 2 to 3 hours you optimize, then only take up for emergency surgeries. And whenever a patient is posted for emergency surgeries, always better to go for variable rate intravenous insulin infusion method for management intraoperative glycemic status.
Okay.
In the exam also, you can just tell about VRIII. No question of subcutaneous correction insulin. Okay, for all their emergency surgeries. Because emergencies means it have to be done as early as possible.
Yes, sir.
Their urgent surgeries are slightly different. They can wait. Fractures, they can wait for 24 hours. Okay, time sensitive or wait can wait for 4 weeks. Elective, more than 4 weeks. That's how you classify the type different surgeries. Okay, the another thing which we should always discuss is hypoglycemia management. So how do you classify hypoglycemia? There are 3 levels of hypoglycemia. They are classified as level 1, level 2, level 3. Level 1 is a severe, is a very mild form of hypoglycemia. From 70 to 54 is level 1. 70 milligrams per deciliter to 54 milligrams per deciliter is the level 1 or a mild one, where only adrenergic symptoms will be present. No other symptoms will be there. 54 to 40 is level 2, where cognitive dysfunction will start.
Okay.
Loss of memory, confusion, all those things will start. Less than 40 and below is level 3, where neuroglycopenia will occur, where the patient can develop, convulsions. He can even go for coma, and even brain damage can. So this is level 1, level 2, level 3 of hypoglycemia classification. Usually, invariably, you give 50 ml of 50% dextrose, and also try to know what is the cause for hypoglycemia. If it is due to oral sulfonylurea drugs, you may have to continue giving 5% dextrose even afterwards, infusion, because there can be, this can prolong also hypoglycemia. If it is due to rapid acting insulin, only this 50% 50 ml dextrose is sufficient. If it is due to intermediate acting insulin, again you continue with 5% dextrose afterwards. Okay. Now this 50 ml of 50% dextrose, why? Why not 100 ml of 50% dextrose? Or why not 25 ml of 50% dextrose? What is the rationale? Because you should also know that 7.5 grams of exogenous glucose will raise the blood glucose by 30 milligrams.
Okay.
7.5 grams of exogenous glucose when you give IV, it is going to increase the blood glucose levels by 30 milligrams per deciliter. Now, if you give 50 ml of 50 grams, you are giving 25 grams of glucose.
Exogenous glucose.
Exogenous, 25 grams. So 25 grams is how many times of 7.5? At least 3.5 times.
Yes.
That means how much of increase of blood glucose level will?
Almost 100.
100 milligrams.
Hmm.
We want that,
Yes.
isn't it? So if it is around 70, you don't give 50 ml, you just give 25.
Yes, sir.
Because already it is nearly 70, like level 1 and level 2, you can just give 25 ml of 50% dextrose. Level 3, 50 ml of 50% dextrose. Now we know how you should manage hypoglycemia, because this is another acute complication. Then another acute complication is HHS.
Yes, sir.
Where there can be severe dehydration.
Yes,
And
sir.
it is only the dehydration. There may not be any ketosis. There may not be any acidosis. So you just have to correct hyperglycemia and fluid. You can even, for all these patients, you can have an invasive monitor, and based on invasive monitoring, especially arterial line, to know if you know the systolic pressure variation or pulse pressure variation, or the stroke volume variations, you can keep on giving boluses. And you know how long the patient is fluid responsive. So you can even do that instead of just calculating, okay, let me give 15 ml per kg body weight per hour. Instead of that, you can accurately give the amount of the fluid that is required as long as the patient is fluid responsiveness.
Yes.
And HHS is more dangerous than decay. Somebody is just now, I saw the question there. HHS, because neurological symptoms, the hyperosmolarity is very high, hyperosmolarity because of HHS, because the blood glucose level can be more than 900 milligrams. And the osmolarity we always calculate based on twice the sodium plus glucose in millimoles. And how do you convert milligrams in millimoles, Hector?
So the 1 millimole is approximately equal to 18 milligram per deciliter.
1 millimole is equal to 18 milligrams. Okay. How did you get this?
Not able to recall.
No, I'll just tell you. What is the molecular weight of dextrose? Dextrose is C6H12O6. Okay, carbon is 12.
Yes.
12 multiplied by 6 is 72. Hydrogen is 12. Okay, 84. Plus oxygen is 16, 96. 96 plus 84 is 180.
Okay.
Now the molecular weight of glucose or dextrose is 180. Now glucose. So I want to convert milligrams per deciliter into millimoles per liter.
Yes, sir.
So this is milligrams per deciliter will be milligrams per liter. You have to convert.
Okay.
Okay. Now it will become, you have to multiply with 10.
Yes, sir.
Divided by 180. The molecular weight. Mass
Yes,
divided, mass in milligrams divided by molecular weight, you get the millimoles. Did you understand? Suppose let us say it is 90 milligrams per deciliter is the blood glucose. I want to convert these milligrams into millimoles. 90 multiplied by 10 is 900 divided by 180.
Yes.
0 gets cancelled. It is 90 divided by 18.
Yes, sir.
Now you know the correction factor, why 18?
Yes, sir.
When you want to convert milligrams per deciliter to millimoles per liter, correction factor is 18.
Yes, sir.
So millimoles to milligrams, you divide it by 18.
Yes, sir.
Oh, sorry, multiply by 18. So milligrams to millimoles, you divide it by 18.
By 18.
So that's how you convert. Okay.
Okay.
So these things you should know always, because many of the books will give in millimoles blood glucose levels also. Okay. So osmolarity, normally you calculate twice the sodium plus blood glucose in millimoles. Suppose 140 is the sodium, 280 plus 5. 285 is the normal osmolarity. if the blood glucose is increasing, so the osmolarity keeps on increasing, isn't it?
Yes, sir.
So patient will develop hyperosmolarity. And you know the consequences of hyperosmolarity and on the brain. That is why early onset of all these neurological conditions. So it's more dangerous. HHS is more dangerous than the DK. Okay. Those things are fine. Now, another very important thing we should discuss is gestational diabetes,
Diabetes.
isn't it? So
Yes, sir.
gestational diabetes can be pre-gestational or gestational.
Yes, sir.
The pre-gestational is already patient is diabetic, now become
Yes.
pregnant. Invariably type 1.
Yes, sir.
Type 1 diabetic becoming pregnant.
Yes, sir.
Or gestational diabetes is, how do you differentiate gestational and pre-gestational?
In gestational means there is a first time abnormal glucose level in the second or third trimester of the pregnancy, sir.
Yeah, usually after 20 weeks.
Yes, sir.
Listen, this 20 weeks is a very important milestone in pregnancy. A lot
Yes,
of things, 20 weeks. So that's why you don't test till 23 weeks many times.
Yes,
You
sir.
might have tested in the first trimester just to rule out pre-gestational diabetes. But usually after 23 weeks only you test, isn't it? So
Yes, sir.
you can go for glucose challenge
Tolerance.
instead of GTT.
Okay, sir.
You go for glucose challenge test. You can just give 50 grams of glucose and then see what is the rise
Okay, sir.
after 1 hour. That is 50 grams, 1 hour glucose challenge test. Instead of regular GTT, you always give,
75 grams.
75 grams and every half an hourly you keep doing.
Yes,
isn't
sir.
it? So that's how you can do. If the patient's blood glucose is anywhere above 140 and between 140 to 180, then you have to subject her for
GT.
100 grams, 3-hour glucose challenge test.
Okay.
That is usually you do in. If it is more than 180 from with this 50 grams, you need not have to do because you know that she has got gestational diabetes. So these
Yes.
gestational diabetic patients can be classified based on Priscilla White's
The white
classification.
classification. Yes, sir.
Can you, I had asked you to read Priscilla White's classification. Can you just
Yes,
tell
sir.
Lakshmi?
Type A1 and type A2, sir. In type A1, there will be abnormal glucose tolerance level values, but in the postprandial or subsequent glucose levels may be normal. So only the diet modification is enough. So in A1,
Diet and moderate exercise.
yes,
For type 1A.
yes.
Okay. 1B.
In 1B, where
Sorry,
abnormal glucose tolerance
1B.
level and both prandial levels are high, sir. So they have to require a insulin therapy to the management of diabetes, sir.
Yeah. Because again, you also look for the duration of diabetes.
Yes,
and
sir.
any, the one is duration and the other thing is the vasculitis is present or not.
Yes,
Isn't it?
sir.
Onset, age of onset, duration, and vasculitis. These three
Yes.
are very important in Priscilla White's classification. In B type,
In B type,
B and
age of,
below are pre-gestational.
yes, sir.
It's only type A is gestational.
Yes,
Type
sir.
A1 and A2. Okay. Pre-gestational is from B onwards. So onset of diabetes, age of onset
Above 20 years,
after 25 years.
25 years,
After 20, duration of diabetes
10 years,
less than 10 years.
less than 10 years,
Okay. Vasculitis not present.
not present.
Insulin always required.
Yes, sir.
Okay. Now C.
Where
See,
the
Between
age
Onset
of
is,
onset is,
onset is between 15 to 25 years.
yes, sir. And
Okay.
duration of
more than 10
diabetes
years.
is more than 10 years.
More than 10 years. Isn't it? And
Yes.
vasculitis not present.
Not present.
Okay. Require insulin.
Yes, sir.
D is onset,
Uh,
age of onset.
10 to 15 years, sir.
Age of onset less than 15 years.
Okay.
C was 15 to 25 years. This is
Yes.
less than 15 years. So, and duration of diabetes is more than 15 years. Vasculitis may or may not be present,
Yes, sir.
and insulin is always required.
Yes, sir.
Okay, and then H,
Onset is less than 10 years. Sir.
no, onset and duration doesn't matter
Okay.
after D. H means patient has a heart disease
Heart involvement. Yes, sir.
and vasculitis invariably will be there. Okay, and then T, patient has a transplant, renal transplant. Again, vasculitis is there and they always require insulin. So this
Insulin.
is the Priscilla White's classification of gestational and pre-gestational diabetes. Okay. Now, if these patients are posted for, or they are, suppose if they are on not on any drugs also, and they can be on insulin also, because insulin is ideal, isn't it? Why insulin is ideal to manage these patients?
Because they do not process the placenta.
Yes, very good. So the molecular weight of insulin is so high that it will not cross the placental barrier, so it will not have any effect on the fetus. So that is the advantage of going in for insulin. So whereas all oral hypoglycemics, they do cross and they also can produce fetal hypoglycemia. So that's why usually we can avoid. Only metformin, because it does not produce any hypoglycemia, is being used in gestational diabetes. Otherwise, usually they have to be on insulin and a strict diet. Okay. Now, if these patients are posted for labor analgesia or cesarean section, how you are going to manage?
We will check the sugar level. Sugar level is expected between 70 to 110 milligram per deciliter.
No, again, no tight control regime. In olden times, we used to have tight control regime for pregnant patients, for cardiac surgery patients, for neurosurgery patients, and for trauma patients, and also for ICU patients.
Okay.
Now, for all patients, we don't go for tight control. We always go for non-tight control regime. So the same variable rate intravenous insulin infusion technique you can use.
Okay.
Whether she is posted for elective section or she is posted for emergency section.
Yes.
Okay. When usually they are taken up for elective section? Usually section is done in these patients. They may not be allowed to go for.
Yes, sir. Baby is having large for gestational weight, and if the baby is having macrosomia.
So invariably macrosomia is the rule.
Yes.
When do you say macrosomia?
Weight more than 4.5 kg.
4 kg, 4,000 grams.
Okay.
So why macrosomia?
Hyperglycemia in the mother, so hyperglycemia in the fetus. So there is release of insulin in the fetus. So there is more growth of fat and liver tissues which produce macrosomia.
And the growth is which part of the baby will be growing more?
Shoulder.
Yes, shoulder dystocia is very common. That is why there can be delay in the progress of labor, and
sir.
there can be injuries to the mother's genital tract.
Yes,
That's
sir.
why we don't allow them to go for vaginal delivery. Majority of the times we go for cesarean section by 38th week.
Yes,
Will not allow them to go for 40 weeks because of they can develop macrosomia. That is very important. That's why 38 weeks. Always give a steroid before taking them up for fetal lung maturation. And the other important thing you should always remember in gestational diabetes or pre-gestational diabetes is neonatal congenital abnormalities are quite common. And intrauterine death is also quite common.
Yes,
so all these things you have to keep in mind for all gestational diabetic mothers. And immediately after the delivery, the neonate can go in for hypoglycemia.
Yes, sir.
Because all this time the baby is subjected to increased amount of glucose and there is circulating insulin levels are very high.
Yes, sir.
So now suddenly there is no glucose from the mother. after birth. So suddenly the insulin levels will not come down. So the baby can go in for hypoglycemia. You have to give 10% dextrose. You have to keep ready for neonatal resuscitation. So these are few things about the gestational diabetes. And I think majority of the things regarding diabetes we have discussed. So Dr. Asam, there are any questions?
Yes, sir. There are.
I'm very happy with our discussion today because yesterday with the mobile,
I
I
know,
was
sir.
really, my mind was not
I could.
working at all.
Yes, sir. Yes, sir. I could make out that.
Yeah, yeah.
There
Okay.
are few of questions, sir, if you don't mind.
Yeah, yeah, sure.
I think Muthu Kumar is a regular for your classes.
Okay,
Rajkumar, Muthu Kumar. He's
Yeah,
asking
thank
how
you,
is insulin.
Muthu Kumar, for asking many questions.
Yeah, Muthu Kumar is asking how is insulin produced. I think that's a more of theory. I think he can.
Not required. Beta
Yeah,
islet
he can read them.
potassium channels have to open and then.
Yeah.
And
No,
the stimulus is glucose.
sir.
Stimulus is glucose.
Yes, sir. Sir, and note
And
on.
it is always released, actually synthesized along with C-peptide, which is called as pro-insulin. And cleavage of insulin from C-peptide has to occur. Afterwards, only insulin is released. That is what I think Dr. Muthu Kumar wanted.
Yes, sir.
to know.
Exactly. I think the next question.
And C-peptide levels are usually used to estimate the amount of endogenous insulin quantity. To differentiate between type 1 and type 2, C-peptide levels are used.
Correct. That was the next question, sir. A note on C-peptide, which you have already answered.
Oh, it was there.
Yes, sir.
From Dr. Muthu Kumar only?
No, it was somebody else, sir. I am not sure. Somebody by name Admin, I believe, sir.
Okay, it's okay.
And Muthu Kumar, sir, few words about patient on insulin pump coming for surgery. How do you manage? I think you have spoken about this.
No, I did not speak deliberately because hardly we have patients with insulin pump. So usually, if the patient is posted for a minor surgery and awake patient, so definitely he can adjust the insulin because he knows how to adjust his insulin levels, because he'll be giving the the correction insulins by himself whenever he is taking food and all. So once you tell him what is the insulin, the glucose levels, he can use the correction insulin by himself through the pump, as long as he is awake. Or if he is posted for a complex surgery, better to discontinue the pump, change over to whatever the regime what we use.
Yes, sir.
I think Dr. Muthu Kumar is satisfied.
Yes, sir. Hemang Doshi, what is the insulin resistance and how to know and how to manage it?
Now, insulin resistance, it is difficult to know as such, because majority of us are impaired glucose tolerance. If we will have insulin resistance. So impaired glucose tolerance is fasting blood glucose between 100 to 125, and postprandial blood glucose is anywhere from 140 to 180. We know that we have insulin resistance. That means that amount of insulin is not able to push the glucose into the cells for utilization of glucose by the cell. That is what we call it as insulin resistance. So you know that insulin resistance is there in a patient who is having impaired glucose tolerance. He need not have to develop diabetes. Definitely he is going to develop diabetes if his lifestyle modification he will not do, if he doesn't.
Okay. And Muthu Kumar, no, that's okay. He's asking, do we provide? Yeah, we'll provide the videos. Yes, sir. So Hemang Doshi was asking, basically Hemang Doshi is from Gujarat, sir. He's a practicing anesthesiologist.
Okay.
To obstetrics more of.
Yeah.
So how to calculate continuous infusion of insulin, and I have glucose in peri-operative period in type 1 diabetes. So we'll answer the first part, how to calculate continuous infusion of insulin.
No, that already I told you.
Yes.
Take 50 ml, 50 units of insulin. Based on, you have to start a basal infusion based on the initial blood glucose level divided by 100. That you can give.
Sir.
Or if you know the insulin sensitivity factor for subcutaneous insulin, not for infusion.
Yes.
For insulin sensitivity factor, if you know, blood glucose minus 100 divided by the insulin sensitivity factor. That is for subcutaneous insulin. Insulin infusion, you always start divide by 100, and afterwards for every 30 milligrams increase, you start increasing 2, 4, 6, 8, 10. And in resistant patients, you have to add one more. Resistance means usually these patients' insulin sensitivity factor itself will be very high. It will be more than 60 units, 60 milligrams of insulin sensitivity factor, or if they are on steroids, or if they are morbidly obese. These are the patients who require extra amount of insulin when you are giving an insulin infusion.
Yes, sir. Sir, in fact, one very good question by Darshan. Now, recent guidelines on NPO have come, no, sir. They say 1 hour of liquids, clear liquids.
That is, I think, for pediatrics 1 hour. For adults, has it changed to?
No, sir.
I don't think it has changed to 1 hour. Still 2 hours for
still
adults.
Consider as 2 hours.
2 hours. Pediatric, it has changed to 1 hour.
Yes, sir. So, diabetic pediatric patient, you can still give 1 hour?
Continue same. There is no change for diabetic patients.
Yes, sir. Pediatric diabetic patients.
Yeah, no
But
change.
adults, still 2 hours.
2 hours, clear fluids.
So, Hemang Doshi.
But always start with 5% dextrose for these children. Before at least 1 or 2 hours before you start your case, much earlier. 5% dextrose has to be started. Their basal insulin has to be given.
Yes.
To prevent decay.
Hemang Doshi again, is there any term like relative hypoglycemia? Example, in a patient in OPD printed with HbA1c about 10 and mean around more than 280 milligrams. After giving OHA sugar, OHA sugar goes around 150 and patient suffers the symptoms of hypoglycemia.
Definitely. As I told you in DKA itself, we say that anything less than 250, they may develop all signs and symptoms of hypoglycemia. So their threshold for development of hypoglycemia is elevated in all insulin resistant patients and also in DKA. So that's what is, if they develop symptoms you treat.
Yes, sir.
Typical symptoms.
Yeah. So there is a term called relative hypoglycemia, sir?
No, that I don't know. I have not read as relative hypoglycemia, but definitely hypoglycemic threshold levels are raised.
Done, sir. Again, Hemang, sir, please suggest the book. Many have asked this, sir. Please suggest the book and journal for diabetes and complications and management. That's why I told them. Sirs is about 35, 40 years of experience reading so many books, articles and all. He's put in 1 hour, almost 4 or 5 hours of discussion. It is not easy. That is what I have mentioned.
No, many of the articles are there in many of the journals, standard journals like Anesthesia Analgesia, BJA, very good articles are there. Up to date, very good articles are there.
Yes.
Up to date, this thing also.
Yes, sir.
App also. So definitely one can read about all this.
Yes. I think Muthukumar's question, I think you've already answered, sir. RS protocol with carbohydrate drink can be given for diabetes uncontrolled. Absolutely.
Yeah, that is what. Now, many people do not want to give.
Yes.
Even in IRAS.
And that too for a diabetic uncontrolled patient, or definitely no.
Yes.
One more question from Hemang. One patient with femur fracture due to RTA and presents with DKA, age 15 years. What should be the fluid and electrolyte management? What is the management of anesthesia? I have faced the same patient.
Yeah, that is what you calculate the fluid deficit. So based on the fluid deficit is a pediatric patient. So 50, 100, 150 ml. So you start correcting as 15 ml per kg. So definitely this can be, the patient can wait for at least 48 hours.
Yes, sir.
Or 24 hours. Before that only you can correct the DKA.
Yes, sir. And
afterwards, definitely you can take up. So for all children, it is better to go for GA. But, if you can always, talk to the child and you can talk about the regional anesthesia, especially the epidural or even the combined spinal epidural. If the child accepts, definitely 15-year-old child, you can go for a combined spinal epidural.
Yes, sir.
Otherwise, GA is ideal.
Sure. In fact, DKA, he can first stabilize the baby
Yeah,
always.
that is very important.
Yes.
He can wait for 24 to 48 hours before accepting the child for surgery.
Surgery. Yes, sir. So Muthu Kumar's question has been answered. So can carbohydrate be given for errors? Okay. Hemang Doshi, as the insulin in the as the insulin is the anabolic hormone and type 2 is the insulin resistant. So majority of the patients are overweight, but some adults are having good BMI under 25 without LADA. What would be the cause of diabetes? Diabetes 2, and what type of hypoglycemic agent should be given? Not able to understand the question, sir. I think we will leave. Okay.
Probably that latent autoimmune diabetes mellitus of the adult, he may be asking. LADA.
Ah, yes, sir. LADA.
LADA,
Okay.
has he written LADA there?
LADA, yeah.
That is latent autoimmune diabetes mellitus of the adults. They are type 1 diabetics.
I think,
So
sir,
it is-
I was reading somewhere, is there a type 1.5 diabetes also, right? Now I think they're going to come out
This
with
is what is sometimes called as 1.2
0.2. Yes, sir.
LADA.
LADA. Fine. And you manage them as a type 1 itself, right, sir?
Yes, yes. There's one more thing. MODI is there, MODI device.
Yes, sir.
Maturity onset diabetes in the young, which occurs before 25 years. They are thin patients. This is majority of the times genetic, monogenetic etiology for MODY.
And but these patients again will require insulin.
No, they may not require. That is, they can be managed. This is maturity onset diabetes, like type
Yes.
2.
Yes.
Though they are thin patients, they can be managed with oral hypoglycemia.
Yes, sir.
Diet, exercise,
Yes,
and antidiabetics.
Dr. Satish is asking.
LADA patients always require insulin.
Yes, sir.
MODY patients, they do not require insulin.
Lifestyle modification with
That
anti-hyperglycemic.
is what the difference. Though it can occur in adult patients, both.
Okay. Satish is asking, are type 1 diabetic patients on ACE inhibitors are more prone for hyperkalemia? Okay. Due to insulin deficiency. What is the ideal to stop the ACE inhibitors? When it is ideal to stop the ACE inhibitors?
So ideal is, it is still, guidelines have not come, but in majority of the textbooks, they say that you avoid on the day of surgery.
Yeah. And more so, sir, when there is hyperkalemia, it's better to stop, no, sir, and think of some other drug.
No, hyperkalemia is usually because of some complication. The patient might have developed a DKA.
Okay.
And DKA means severe hypotension will be there. There is no question of
Yes, sir. Yes, sir.
giving AC inhibitor.
Right. So what would be the best way to manage hyperkalemia in a diabetic patient with CKD using glucose insulin infusion is the right way, sir?
And glucose insulin infusion and bicarbonate.
And bicarbonate.
Because bicarbonate is one of the best and fastest method of decreasing the hyperkalemia. And before that, definitely calcium gluconate has to be given.
Yes, sir.
To reduce the impact of potassium on the heart.
And more so CKD patient.
Yeah.
Yes, sir. So bicarbonate, calcium chloride can be.
Yeah, calcium gluconate or chloride. Chloride, if it is a central vein, is there.
Yes.
Access is there.
Yes, sir. Sir, would you please clarify the formula actual sugar divided by ISF? What is ISF? I don't know.
Insulin sensitivity factor.
Huh? I think, sir,
Insulin sensitivity factor.
I think sir has mentioned about that in the.
No, insulin sensitivity factor, once you know, so you measure the blood glucose levels and blood glucose levels minus 100 divided by insulin sensitivity factor should be the number of units of insulin for correction to be given subcutaneous. Suppose, let us say that the patient's, this thing is 200 blood glucose. Okay, minus 100 will be 100. His insulin sensitivity factor is 25.
Yes, sir.
So then he requires 100 divided by 25 is 4. 4 units of subcutaneous insulin he requires.
Yeah.
It is a formula.
So that question was from Riddhi Rao. And Okay. Uh, can you provide these regimens as handouts? I will give them, sir. So can you give? Okay, yeah. Next question is, so, I think you answered this also. Deepshika was asking, how do we come to know 10 newtons pressure is applied?
Yeah, very difficult, very difficult.
So, yeah. Nipa says, superb class, sir. So much of basics got cleared. Thank you for scheduling the class, and thanks to Guru Dutt, sir. Sir, in which space the dura should be punctured? That is, you were telling about dural puncture epidural.
Yeah,
Question.
anywhere below L2.
Yeah.
You do not go above L2 because spinal cord is there.
Yes, sir. And Roshan, excellent case discussion. Thank you, Guru Dutt, sir and Azam sir, and for the PGs who presented the case. Okay. Muthu Kumar, should we check eyelash reflex or verbal response to propofol?
No, that debate has been cleared. Now it is always eyelash reflex. Even whether it is propofol or thiopentone or etomitate or whatever it may be, because we know that the verbal response will be lost only in the first stage of anesthesia. That means the patient is not completely unconscious. Second stage, patient will be completely unconscious because eyelash reflexes are lost only in second stage of anesthesia. Once you know that the eyelash reflexes are lost, now we know that the 100% the patient is unconscious.
Yes. So we take that as a
endpoint for induction.
Right, sir. Sir, you also mentioned about this was a personal message from Chima. You mentioned about graded epidural.
Yes.
Yeah. So the question is, what exactly mean by graded epidural?
That means, you are not achieving the level of the block with a large dose of the local anesthetic. You are grading whatever the total dose that is required, you are going to grade it over some time. You are going to give, that means in increments.
Yes, sir.
Waiting for at least about 5 to 7 minutes in between the two increments. For example, now I give about 5 ml. I'll wait for 5 minutes. I'll check the level of the block. Then if I'm not satisfied with the level, then I repeat another 5 ml.
So
like
electrodes of 5 ml can be given.
Increments. And in those patients where you expect more hypotension like DKA, in autonomic neuropathy, you go for 3 ml increments.
Yes, sir.
And you achieve the maximum level over, say, 20-25 minutes you will take. So during that time, the body will have sufficient time to compensate for the sympathetic block. And sympathetic block also will be delayed. Gradually, it will start occurring. So body has got enough time to compensate for this. So there won't be much hypotension.
So that is what is graded epidural.
Yeah.
Sir, other thing from her only. If they ask what is the difference between modified rapid sequence and rapid sequence, what are we supposed to answer in the exam?
Now, the only difference between modified rapid sequence and regular rapid sequence is in modified rapid sequence, you ventilate the patient after giving succinylcholine. But you ventilate with the pressures of less than 15 centimeters to 20 centimeters of water pressure. You will not allow the intrathoracic or airway pressures to go beyond 20 centimeters because 20 centimeters is the pressure at which the upper esophageal sphincter will open up. So as long as you are keeping a low pressure ventilations, so all your oxygen will be going to the lungs only. It will not open up the esophageal sphincters to produce regurgitation. Why we don't ventilate is to prevent regurgitation. So that way, it's a modified, wherein, in certain individuals, they don't even cannot tolerate even this amount of the apnea. 1 minute apnea also they may not tolerate, like patients who have bled a lot, trauma patients, and APH pregnant women, antepartum hemorrhage.
Yes, sir.
And pediatric children, the pediatric age group, they don't tolerate this amount of apnea because their oxygen carrying capacity has come down and their requirement is high, especially in pregnant women and also in pediatric age group. Yes. So that's why you just gently ventilate. If you have a pressure controlled mode of ventilation, you just hold the mask, you go for pressure controlled ventilatory mode, and you keep a pressure of 15 centimeters there. Hold 100% oxygen. That's how is a modified rapid sequence induction.
So is there any modification of using drugs in modified rapid sequencer?
No, no, all other things are same,
Same. Okay.
except that you ventilate with low
Yes.
pressures, with
Yes.
low air pressures.
Yes. Now another question from Muthu. If there is a low urine output, how to calculate fluid correction, sir?
No, fluid correction, you always calculate based on urine output also is one of the criteria you take. In severe dehydration, there won't be any urine output. And why there won't be any urine output is because of dehydration. Once you rehydrate, urine output will start. Until urine output is not there, don't give any potassium. That is the only thing. Otherwise, fluids you have to give. And it's a severe dehydration. Because based on the urine output also, you calculate the amount of dehydration. If the urine output is more than 0.5 ml per hour, it is a mild dehydration. If it is more than 0.3 ml, but less than 0.5 ml, it is moderate. If it is no urine output, it is a severe form of dehydration with severe skin turgor, loss, and all others. The patient is unresponsive. The pulse are barely felt. Only the peripheral pulses are absent. Only you can feel the central pulses. They're all a severe form of dehydration.
Yes, sir. I think you were also mentioning about fluid management. I think the other best way is to do a focus, sir, point of care ultrasound used for
Yeah,
the
definitely. Now, that's what I told you. There are many things like if you have a invasive line, you can go for invasive this thing. Or a focus also, you can look for
IVC diameter.
IVC diameter, and then you can.
Yes, sir.
But that will not be. Sometimes if the patient has got a mitral stenosis or aortic stenosis, you cannot go with that.
Yes, sir. Yes.
Because it will be invariably dilated because of the back pressure.
Yes. Sir. So I think, for the benefit of the students, in that case, sir, you also see the portal veins. How are they? If they are very dilated, then I think you should be careful hydrating such patients. Then
Correct.
other thing is, I think Hemang is asking, sir, HHS with acetone. I'm not sure what this means.
No. There won't be usually HHS. There won't be any ketone bodies.
Yeah.
Yeah.
Yes, sir.
And one more thing about diabetic ketoacidosis. How do we know that the patient is improving? So it is based on the bicarbonate levels and the pH levels, and also about the anion gap. So anion gap also starts improving, and the delta gap in DKA, delta gap will be between 1 and 2. And as you start correcting, the delta gap starts coming down to less than 1. And once it is completely corrected, it will be less than 0.4.
Yes, sir.
That's how you know that the DKA is corrected. Because if you continue with only ketone bodies in the urine, acetone will be present in the urine for 48 hours.
Yes.
Even after complete correction of DKA, the patient continues to have ketonuria with only acetone. Acetone does not produce any harm for the patient. It will not produce any change in the acid-base status or the potassium status.
Sure.
So
It's an
when to
end
stop
product of,
insulin, sir, exactly?
pardon?
When to stop insulin infusion, sir, exactly in DK?
That is what once you go for the bicarb levels, and also I told you about all these criteria. The best is delta gap.
Oh.
Delta gap is otherwise called as a gap. That is nothing but, you have to know what is the anion gap. So anion gap minus 12 divided by 24 minus bicarb. That is what we call it as delta gap, the ratio or the delta ratio. It will be between 1 and 2 in all typical high anion gap metabolic acidosis. If it is less than 1 but above 0.4, it is a mixture of high anion gap and normal anion gap metabolic acidosis. That means the patient is improving, but still he requires treatment. Once it is less than 0.4, now the patient is completely cleared about DKA. Then, but you still give insulin, you may switch over to subcutaneous insulin.
Okay.
Because if you don't give insulin, one of the causes for DKA is because the patient has not taken his insulin.
Correct. Yeah, sir, one question from my side, sir. How do we differentiate between urine ketones that are present because of fasting or because of PKs? Apart from your severe acidosis on the ABG and other things, suppose if the patient is fasting,
I know.
so how do we, is there a way?
No, blood glucose levels.
Okay, suppose even, okay, if it is high, you take even that guy as a diabetic.
Yeah,
ketosis.
definitely.
Okay.
When somebody is fasting, his blood glucose levels will be low, but still he will have ketone bodies, because now the liver will be taking different methods to going in for to increase the glucose levels. So it will go for lipolysis. Lipid will break down. That's how people will reduce their body weight.
Yes, sir.
Because of lipolysis. Once lipolysis occurs, ketone bodies are produced.
Yes, sir.
And ketonuria will be there.
Yes, sir.
But blood glucose will be on the lower side.
Yes, sir. Any role of HbA1c in diagnosing gestational diabetes, sir, by Deepshika?
No, this is for pre-gestational diabetes.
Not for gestational diabetes.
No, definitely. If HbA1c is high, then it is a pre-gestational diabetes.
Yes, sir. Criteria to start or shift the patient on insulin having type 2 diabetes and along with insulin therapy with OHA, which OHA should be continued?
No, if not able to control with the diet, exercise, and OHS, then he requires insulin naturally.
Yes, sir. And I think, sir, the gestational classification you said is White's classification, right?
Priscilla White.
Priscilla White.
Yeah. That she did was in 1950s.
Oh.
Later, what we presently use is a modified Priscilla White's classification.
And Chandan has told you, sir, you are a god of anesthesia. Blessed to listen to your classes. Thank you very much. Exogenous insulin resistance. How can we know, sir?
No, by their body habitus, and also patients on steroids. That's all. Yeah. And if the patient is on insulin, now insulin sensitivity factor.
Correct.
If it is more than 60, you can say the patient is resistant.
Yes, sir. I think Ratika, I'll share the video. So she's asked to repeat the basal and intermediate insulin dose. I think I'll share the video. Saji, many thanks, sir, for your great efforts as always. Some patients on reasonably good control with TAD insulin pre-op on the morning of the elective surgery shows about 200 sugars, but ketones are positive. How to prevent it? Can they be taken up for surgery? If not, then will ketones clear in a day?
No, that is what ketones. Ideal would be to measure the serum acetoacetic acid and beta hydroxybutyrate, because ketones will be present. I was telling you, because acetone will be present for 48 hours.
Yes, sir.
So if you can get a serum beta hydroxybutyrate assay is done. So then now it is completely clear, because beta hydroxybutyrate has got a half-life of just 4 to 6 hours.
Okay.
Once the production is stopped, after 6 hours, it will not be there.
Got it, sir.
Yeah. So even though ketone bodies are there, just get an assay if possible for beta hydroxybutyrate. If it is nil, you can take him up for surgery. No problem.
I think Aarti, thank you, sir, for the great discussion. Thank you for I think we have done, sir. So thank you so much, sir, and thanks Lakshmish and Mukesh. You also put a great.
I should thank you, then Sonasai and your students.
Thank you, sir. And in fact, it will benefit many, sir. Many, sir. Thank you so much once again, sir. Yeah, no, sir. Yeah. If they read this now, I think for them the diabetes is over. If they hear this lecture. Yeah. Thank you, sir, once again for all that. And
can I get a certificate?
Sir?
Can I get a certificate? Like you always give one certificate for the attendance of my.
Yes, sir. Yes, sir. Sure.
To give it to my university.
Okay. Shall I do it on a PDF is okay, or should I send you this?
Yeah, email.
Both I'll do, sir. Both I'll do. Not a problem. I'll send
I don't require any this thing. Hard copy.
Oh, okay. Only done.
To submit to the university.
Done, sir. So I'll mention about 3 hours plus now it is almost 4 hours. So about on 2 days I'll give different certificates, sir.
No, anything, no problem.
Right. Sure. Thank you.
Just I can give them the certificate. It's
Yes, sir. Yes, sir. Sure. For
Submit the
the
certificate.
hospital.
Yeah.
Done, sir.
hospital.
Done, sir. Thank you, sir. Once again. Thank you so much.
Thank
So
you.
very kind of it. Thank you, sir. Thanks, Mukesh, and you did believe.
But today, absolutely no problem because I used my iPad.
Yes. Yes. I know yesterday you were holding the phone continuously
Yeah, that was
all the way.
And mentally, I was disturbed.
That is not,
I
that's
was not
what I
upright.
felt we should have cancelled it yesterday and redo it. But
No, it's okay. I don't know why this iPad did not flash. I would have used
yes.
iPad yesterday only.
Correct.
Yeah, yeah.
Fine,
That
sir.
would have solved the whole problems.
Correct, sir. Thank you, sir. Once again.
Thank you, Azam.
So much.
So
Bye.
you are sitting, you are fasting.
I
and, you
know,
know,
sir. I also learned a lot. I mean, anyway, knowledge is from you. Learning from you is something amazing, sir. Because what you see, how to calculate calcium, I mean, millimoles to milli equivalents. I mean, this is not easy thing, sir.
So there
Sir,
are
I think
basic things
one day,
I want
sir.
people to know. I want the students to know basic things.
Yes, sir.
Then
Yes, sir.
they'll understand what is millimoles, what is milligrams,
Yes.
why 18. Because Lakshmish was knowing 18, but he didn't know why 18.
18. Yeah, that is the beauty of your teaching, sir.
Yeah,
That
yeah,
is what
that is
even.
I always try to tell them.
Yes, sir. Thank you, sir. And I think, sir, whenever you're free, this adrenaline, how to calculate the 1:1000, how to calculate those small classes will take.
Okay.
It will be helpful for them. And you're the right person for that, sir.
Anytime if I'm free, I'm ready for discussion
Thank you, sir. I'll let you know, sir. Sure.
during your classes.
Done, sir. Done, sir. Sure.
Oh,
Thank you, sir.
okay.
Thank you so much, sir.
Okay, Azam. Thank you.
Thank you, sir. Take care, sir. Bye, sir. Bye.
Thank you, sir. Bye.
Thanks.